Can you see me?
Yes, yes, boss.
चला गया ना?
We can do something.
Sir, Puma ma'am told me to join in between. She told me whenever laryngology cases will start.
Now?
Yes, yes.
Now it's okay?
Yeah, fine.
Yeah. Now you can see the thing?
Yes, sir. You can.
Right, you can see the slide?
Yes, of course, you can see.
Okay. Hi, Dr. Manish.
Hi, how are you?
Fine. Satish Jain.
Hello, boss.
Because Hattu, everybody says.
Today I was speaking to Satish sir, yes, I was speaking to Dr. Rajeev Pachauri. No, we are of more information.
Yes, you can go live, sir. We are live.
Yeah. Andy?
Yes, on.
Yeah. Good afternoon and a warm welcome to everyone. And today is the webinar with Dr.
Volume
Satish
full
Jain.
रखो. Full.
And this is the 15th surgical demonstration from basic to advanced laryngology. And this is the 15th one with Dr. Rajeev Pachauri. And today we have again the galaxy of stars.
सब तैयार रखना.
Dr. Manish Munjal, and for a change, and then we have today, we have Dr. and we are missing and I think this again was going to be a very interesting and very telecasted and
Steepies, no?
webinars. Once again, heartiest welcome to all of you on behalf of Sunfarm. This is Mahindra Raman, Pharma Care Division, Dr. Super D, Superdom, and Market Effects, and Vita. So with this, let me hand over the session to Dr. Rajeev Pachauri for an interesting session. Sir, Doctor.
Yes. Good afternoon, everyone, my dear friends from all around the globe. I think this is our 15th webinar on basics to advanced ENT surgery from our team, headed by Dr. Satish Jain, Paramita, me, and we have many guests in between. Today we have Dr. Girish Misra sir, Dr. Manish Munjal, and our young dynamic Udham Mittal as a moderator today because we are missing Paramita for some other reasons. So this is the one more event where we are just dealing with basics to advanced ENT surgeries again because we are revising all the steps, and I think I requested everyone to repeat. Means you can say they should go for all the videos being shown before, all the structures, so they can review the anatomy and all the surgeries being done in past. So it will be easy for them to understand the basic concepts of the ENT which we are going to show, which we are going to show and share with you all. And again, next Sunday we will have a few more cases, and we will do Sunday by Sunday. And today, again, I welcome all my delegates, friends from all over the world. And we all know that today, again, I would like to thank Sun Pharma for organizing this wonderful event, which is, I think, they're breaking all the records of, you can say, in the number of attendance as well as the quality-wise. This is one of the best as for the review. So I would like to thank Sun Pharma again. Today we have a list of surgeries starting from recurrent respiratory papillomatosis, been operated many times, and today is going to show with the laser, and beside we will just give a monoclonal antibiotic injection at the site. Again, cholesteatoma with extradisation, interiorization, steppies, 3-4 steppies with different varieties of the approaches and the different how we can do the steppies in different way. Where we have seen all the cases of carotid body tumor. Today we have vagal paraganglionoma, CSM with face palsy. We already shown today's cases with different laser cordectomy with long discussion about the CA, vocal cord and larynx also. and we have very rare incidents, or we can say rarely done case like auricular sinus. He will operate bilaterally in a single space. We have galaxies of panelists with us. Again, I would like to welcome Dr. Misra sir, Dr. Munjal, and all the team. And we will call many people in between for a long discussion around it about it. So again, I would like to thank Sun Pharma and full team of Sun team for this wonderful event. Now I think I should over to Dr. Satish Jain. He is waiting for the discussion. And anything from anybody? Anyone to say anything? So Dr. Satish, over to you. Thank you. Yes.
Thank you, sir.
Again, a big day with the basics to advanced with our esteemed guest, and it's a pleasure to welcome today one of our very senior faculty with us, Professor Girish Mishra sir.
Yes.
We all know, Ajay, we all know Professor Girish Mishra sir has been in teaching for more than 3 decades. For last 2 decades, more than that, he is heading the Department of ENT at Concert Medical College. Before that, he has a special interest in cancer work. He has been associated with many of the, director of many of the projects of the ICMR pertaining to cancers. That is a big achievement for something need to be known by everyone. He has a special training in cochlear implant from Australia. Besides his training in cancer surgery from the prestigious Tata Memorial Hospital, and he has trained hundreds of students in the last 3 decades, and they are practicing at many parts of the India and doing really well. He is a very committed teacher. We welcome Girish Mishra sir. Thank you sir for joining us. Thank you very much. Can we focus his picture?
Dr. Mishra sir.
Michelle sir was online just now. I saw him. Ajay, can? Yeah, I think this country is coming. Welcome, sir.
Welcome. Thank you. The electricity on you because the power cut.
Yeah. So we are all so happy to have you here today to enlighten us. Thank you.
Thank you, sir, for the invitation. Thanks to Dr. Rajeev yourself for including us in the.
So it's a pleasure for us to have you, and we'll certainly learn from your huge experience, and everyone will be benefited. Thank you. And then today we have a very simple and a senior person with us, Dr. Manish Munjal sir. We all know him, how keen he is in academics, how dedicated he is, how involved he is in all academic activities. He is now presently professor at the prestigious DMC Medical College, Ludhiana. He is highly academically oriented, has many academic rewards to his credit. Thank you so much, sir. Thank you for sparing your valuable time for us.
Thank you. Always a pleasure to be with you.
Thank you, sir. And today Paramita is busy, and we have a very young, dynamic, upcoming superstar, Dr. Udbhav Mittal, with us. And I'm sure he's full of excitement to bombard questions today. He was very keen to be part of it, and we are so happy for him. He is dynamic. In the short span of his ENT career, he has worked with many stalwarts like Nupur. He has a special interest in laryngology. Today we have some laryngology cases as well. He has worked with Dr. Mubarak Khan as well in endoscopic pathology. He has worked with, very senior laryngologist, Dr. Ramalingam. So he has a keen interest in laryngology, and today he will be taking care of the questions to forward us. He will select important questions. Thank you, Udbhav, for showing your interest.
Thanks a lot, sir.
Thank you, Vishal, for joining again, the young dynamic. So today, like we had a last webinar was full of advanced surgeries. So today was the time to start with the basics again, to go with the advance in the end. So today we are going to start with a very interesting situation, which I would call it one of the most frustrating situation for the patient, their family, as well as treating surgeon. Recurrent respiratory papillomatosis. We all know this disease is a benign condition. This is notorious with no final cure yet. And the affected populations are mostly children, young children requiring repeated surgery for the airway. This is something so unfortunate for this disease. Can you connect the laptop? So, this disease, as I mentioned, there is no definitive treatment so far. So many things are being tried. So what exactly this disease is? What are we going to achieve with the surgery? Surgery has only the role of giving air and to maintain the voice. That's it. Surgery is not going to cure by and large. And it's not that if you do a radical surgery like a tumor, go all around with margins to remove the disease, it's not going to work like this. Because this papilloma, this disease is caused by a virus, HPV. We know there are more than 100 strains of HPV which are prevalent. And we know the HPV 16 and 18 are so notorious to give so many malignancies. This disease is mostly found in two groups of population. One, and the most common, is children. Children, young children, more young the child, more the difficult to handle, more extensive the diseases, more severe the diseases. So it invades the basal epithelium of the airway, and where the virus replicates and gives rise to it starts a sort of immune reaction and sets up a T helper 2 kind sort of inflammation where the virus persists. The role of surgery is to remove all those exophytic lesions which blocks otherwise the airway and to maintain the speech, voice. The virus remains in the basal epithelium and it's not going to go so easily. So these patients require repeated surgeries to maintain the airway. So what all we are going to achieve with that? What are our goals of treatment? So this is, as I mentioned, is an immune complex disease. Because this virus incites a local immunogenic inflammation. So the treatment should be directed towards immunomodulation. A lot of research work is going on. I am going to highlight the recent work going on and what are the present adjuvant therapies which are prevalent in the present scenario. So our goal is immunomodulation. Whatever the agents which help in modulating the immune response are going to help. Disrupting this virus replication which is giving rise to this replication. Then the control of inflammation because of this ongoing viral inflammation. And this inflammation has been proven to be because of neoangiogenesis. So now the next goal is directed towards prevention of neoangiogenesis to reduce the incidence of surgeries, to increase the interval amongst the surgeries overall. Because yet there is no simple cure. So as far as the adjuvant therapies are concerned, see the list of things. There are many more which people have been trying for years together to reduce the number of surgeries, to increase the interval amongst the surgeries. Cidofovir is on the top. There are hundreds publications on cidofovir use with local intralesional injection, IV injection. IV is not preferred because of their side effect. It's an antiviral drug preventing replication of the virus. That's how the other antiviral, ribavirin, acyclovir, have been tried. But long term, there is still, we have to go beyond. There is no favorable result as far as the long terms are concerned. Interferon, particularly the pegylated interferon alpha 2, has promising result by means of modulating the immune response. Normally interferon is secreted by our own leukocytes to improve the antigen response. So here the pegylated interferon alpha 2 has a response. It has shown response. The cost is a limiting factor, for particularly for our Indian population. This cost is too much, costing more than $1,500 or something. $1,500 for every dose of interferon, pegylated one, and that too the acquiring is too difficult a process, and yet there is no long-term cure. Then other things which prevent the replication of virus have been tried, like cis-retinoic acid. We all know it prevents proliferative activity of the cells. Mumps vaccine have been tried, and it's not, there's no harm in trying mumps vaccine because many of the children are already vaccinated by the MMR, as it is in our national immunization program. But yet we should inquire if somebody is not vaccinated. There is no harm in giving mumps vaccine. Then this HSP-E7 is a papilloma protein, the heat shock protein. This is extracted from the papillomavirus. Have been trying all these investigational. The biggest thing, the big thing in the recent time, which has come up, is a PD-1 inhibitor, programmed cell death 1 inhibitor, which has proven to have a big role. A lot of, the third round trials are going on. It has got approval by the FDA. Pembrolizumab, the cost is again a limiting factor, costing more than 2 lakhs per doses of pembrolizumab. So it's still long way to go. The other therapies, photodiamidine, have not, established their place. So what we are using now, these are the list of therapies which I am going to show now and share with you based on the evidence-based medicine. These are the things which have a quite, I would say, suggestive role in the treatment of juvenile respiratory papillomatosis. And number one on that is a vascular endothelial receptor inhibitor, bevacizumab, which is popularly available in India in the brand name of Avastin. So bevacizumab inhibits neoangiogenesis. As I mentioned in the goals of treatment, inhibiting the neoangiogenesis is one of the main goal of treatment, and this is how the bevacizumab, the vascular endothelial receptor inhibitor, works. So what we do, and we are now number of patients, we have been trying this for last 3 years and got exceedingly good results. Some of the patients have been cured now. And rest, the incidences of the frequent surgery has declined, has gone down significantly. So how we use is a very, very safe drug. You can use intralesional after the excision, and then the rest of the drug, like we inject 25 to 50 milligram intralesional, and rest 50 milligram we give IV. After the initial excision is a main role to remove the visual papillomas, to maintain the airway. As I mentioned, you are not supposed to be radical in excision. The more radical you are, more fibrosis you are going to give, more chances of laryngeal stenosis we are going to give, and that is detrimental to the child's voice as well as the airway. So goal of surgery is to remove the minimal lesion up to the surface without damaging the underlying surface, and then we can inject this bevacizumab in the base of the lesion to prevent further neoangiogenesis, and it has proven to be amazing. I am going to show today. Then celecoxib, as we all know, is a COX-2 inhibitor. Papilloma have shown number of COX-2 receptors on the surface, and celecoxib is a simple COX-2 inhibitor, has an immense role as an adjuvant therapy. There is no harm in giving. So what we are giving a lot of things as an adjuvant because there is no definitive treatment, and it's supposed to work. So we give all patients celecoxib, particularly children, 100 milligram twice a day for few months, and it is very, very safe. And it has, I believe it has some role. And the biggest role is as I said, this is caused by the HPV virus. Children are affected by either the direct maternal transmission or during the vaginal delivery. Particularly the young primipara ladies with the first child born, labor is prolonged. The prolonged labor is the region where the fetus or the child remains in contact with the vaginal surface more, and because of the friction and trauma, prolonged friction and trauma, this virus is introduced. That's how the theory, how the children are affected. Otherwise, that's how a lot of studies have proven that the delivery by the cesarean section reduces the incidence of recurrent respiratory papillomatosis, and the reason is This is mostly because of the young females affected by this HPV, and the common lesion is condylomata, genital condylomata, and which at the time of delivery can transmit to the child. So HPV vaccination has a big role. A lot of patients have shown amazing responses. It's a standard adjuvant therapy now, and earlier we were using Gardasil 4, and now the non-advalent Gardasil 9 is available, and that is amazing. Every patient we are treating, giving him Gardasil. All patients we are giving Gardasil to improve the immune response against the HPV to prevent replication, and this has proven to have a big role. And a lot of countries trying to immunize the young adolescents with this vaccine to prevent this transmission of disease to the children, because adult the transmission of mode of transmission is different because through the oral sex, but in children it is mostly at the time of delivery or the vertical transmission in the fetus. Then another thing which works is the PPI, proton pump inhibitor, to prevent G reflex, because more the G reflex traumatizes the laryngeal surface, more the virus replicates. It has been proven that the adjuvant PPI has a big role. Another what we can see, a lot of studies have proven, this indole 3-carbinol is a compound, works by the estrogen pathway, and it is available in the food in certain items like sprouts, broccoli and cabbage, and we can ask these patients to encourage more and more intake of sprouts, broccoli and cabbage. So this is what the available treatment resources we have. We are still short with a permanent answer, and this is something using all these adjuvant therapies with the surgical treatment. We have been able to control many of the patients by means of reduction of number of surgeries, by means of increasing the interval among the surgeries, and by means of giving cure to certain patients. And this is surprising. Earlier I have seen patients who have been operated more than 30 times for the papillomas. This patient today we are operating has already been operated. I reviewed his paper, every part of it is 7 times, and has a full of papilloma. He has a mild respiratory distress, yet we should avoid a tracheotomy in these patients. This is something very important. Giving a tracheostomy is something inviting another surface for the papilloma to grow. So in every possible situation you should avoid tracheostomy, and in case if there is a respiratory distress, this is imminent to do, we may have to do, but then the moment the respiratory the airway is established, we should wean off that from the tracheostomy. We should close it immediately to prevent the colonization of the bacteria, because these are the path for bacteria, this virus, to spread to the lower airways. It has been proven to go to the lower trachea, bronchi, lung, and sometimes it can result into mortality. So this is a very difficult disease. In less than 2% situation can still undergo malignant transformation. So this is, I mentioned in the beginning, that one of the most frustrating pathology, that too in the children, that too affecting airway with no definite answer. So our goal of surgery today, what our plan is today, I will show you the massive papillomatosis. I will share with our surgical technique, and then we'll inject at the site of lesions, intralesional, this monoclonal antibody, vascular endothelial receptor factor inhibitor, bevacizumab. Coming to the surgical point, there are so many things you can see in the literature. People are using laser, has been talked about since long, but believe me, we have stopped using laser for years together. It is detrimental. As I said, the more raw areas you create, more you are inviting the adjacent epithelium for the virus to grow further. So no further raw areas to be created, not deeper areas to be created to give invite viral replication, and at the same time laryngeal stenosis. So our goal is surface removal with minimal trauma to the underlying area. So nowadays we use more and more cobblator. Mostly the number one tool is microdebrider and then cobblator, which I am going to show you, using on the surface with minimal trauma to the underlying epithelium and the submucosa. That is going to be our goal, and then we'll inject this monoclonal antibody. airway was difficult to intubate, but we could intubate just now with a smaller tube, and then when you will see in between we may have to do some work in the apnea as well, but we'll try our best to avoid tracheotomy in these cases at any given point of time. So this is our protocol. Sir, you must be seeing a lot of such cases in the institutes, because this disease is something a lot of children, families looking up to the institutes for the cure. Girish Mishra sir, can you unmute sir?
Yeah, I'll do that. My electricity is a problem every time.
Yeah. So how do we look at this disease, sir?
Of late, we have not much of experience. We done qualification around 5,000 years back. And, not recording. Hello? Can you hear? Hello? Can you hear?
Yes sir, now.
So, I don't have much experience about debriders and coagulants, but we have cold steel instruments where we remove the entire disease, and then, of course, we don't have experience regarding velocity also. But never tried for homeopathy medicines like Thuja that was promoted.
Thuja have been, yes, a lot of...
We don't know. But the stories say like do repeated debridement and establish the airway, but with a cold steel instrument, not with this debrider. I don't have any experience with debriders and coagulator.
Yeah, the sir pointed out about very important aspect of homeopathic drug Thuja. The Thuja has been, used for this disease for long. I don't know the overall results, but yes, we have also used some time as an adjuvant therapy. And I discussed with the homeopathy guys, they said it works in some variety of papilloma. You show me the picture, I'll tell you. Even they don't know much about it. Homeopathy are using as a, covering for everything. So, Thuja but has a role. It has been, mentioned in the literature at several places. People have been using for years. But overall, there is no definite cure so far. So what we have been able to achieve by means of surgery and these adjuvant therapies to give at least good quality of life to the affected child.
Sir, Prakash Munga sir is asking any role of propanolol.
Propanolol is same, VEGF inhibitor, but here giving a systemic propanolol is not advisable to young children, and for that this bevacizumab is much safer. There are so many studies done with the bevacizumab, intralesional as well as systemic, and proven to be ultra safe. It has been used quite extensively in the other malignancies, as this is a factor inhibitor for the neoangiogenesis, and it is proven to be quite safe. The only thing is the cost as compared to the propanolol. But propanolol is not a selective, this thing, it has other beta blocker side effects as well. So it is not the first line drug to be used in children.
Your experience with debrider and coagulator, what difference does it make?
Sir,
less raw area?
Yes, less raw area.
Cold steel instruments?
The game is around the raw area. Laser, if you use the laser on the surface, it is going to raw area. And if you give any point of time raw area, it is going to, invite the surrounding surface to stimulate viral proliferation. So what we do, we first use debrider to debulk the lesion towards the surface and then pack for a while, because debrider itself cleans because of the suction attached and keeps the field good, so you can under vision remove the elevated lesions. And put close to the surface, and for hemostasis we use coagulator. A lot of irrigation to give minimal thermal damage. So our
does not cause mucosal damage?
No, we are not going to reach to the level, that level, and minimize it. I cannot say 100%, but just will minimize it. And secondly, particularly in certain areas which are prone to give laryngeal stenosis, like anterior commissure, subglottis, those areas you have to be very, very careful in giving mucosal damage, because that results in laryngeal stenosis. That laryngeal stenosis again is a big problem in children. Like papilloma, that again is second frustrating disease coming up as an after effect of this treatment. So we have to be very careful about preventing laryngeal stenosis, because that ultimately may make the child tracheostomized, and which is something which we certainly want to avoid.
And have you done Biger typing in this case? We say HPV11 is more aggressive and more extensive in comparison to HPV6.
Yes, so mostly these children have aggressive lesion, and most of the time it is because of HPV11. HPV6 is not so aggressive. 11 is so. So, and we have got viral typing done a couple of times, and it is almost always HPV11. And this vaccine works very well. It increases the immune response against the HPV, it increases the antibody titer, and this is something we need to follow the instruction for the full course of Gardasil to these patients. It's not a single dose, but a complete, until booster dose we should give.
What is that course like?
The Gardasil is 900 rupees.
What is the cost? The course.
Course, vaccine.
Yeah.
The first, as the patient remains in the first is the first time we give, then after a month and then 6 months.
Okay.
And we follow these children with a pediatrician for this all evaluation. And nowadays the non-availant vaccine has come, it is costly. This is proven to be much better than the Gardasil. So these on the screen what you see are the, I would say, safer and more effective regimens as an adjuvant therapy in the present context. Rest other are available. People have been using, still using, interferon, cetofovir according to their availability and the cost and other factors.
These sprouts and broccoli, cabbage, these are the things which you encourage the child to eat.
Yes, because they have proven to have a role through the estrogen mechanism in preventing proliferation of the HPV replication. So there is no harm in using any adjuvant therapy which can work. Like I said, we always use celecoxib. We don't know how much it is working, but there is no harm in giving this. So all these things we are giving as a combination to all patients, all these 5 things along with the surgery. So, and what we have observed in last couple of years, we have been able to reduce the frequencies of the surgery required in the children with the use of all these things. The cost is a factor. Bevacizumab is a costlier one, though we have been able to, achieve at a minimum cost through the wholesale and all this, and it costs in our, our setup now around 10,000 rupees per 100 milligram vial.
Okay, how much you give normally? How much ml you give?
Yeah, it is one time 100 milligrams. So what we do, we'll inject according to the surface 25 to 50 milligram, and rest immediately after surgery we'll give IV in the drip.
Okay. And most of these surgeries, they have double anterior commissure in most of the cases. How you prevent it?
Yes, so anterior commissure if involved, I would say it is better to stage the surgery. Remove on one side at a time and come after say 2 weeks or so to remove from the other side to prevent adhesions. Because giving that web or stenosis is most frustrating.
This patient has undergone 7-8 times, as you mentioned.
Yes.
Is there a possibility of some adhesions and you might need to use stents or something?
Because when we did scopy, yes sir, when we did scopy, he had a mild respiratory distress and it was full of papillomas. Nothing is visible beyond papillomas. So now once we remove papilloma, let's see what has gone earlier.
So are you prepared with the stent in case, or you must have had experience of putting stents in such patients?
What?
Stent, silastic sheet or some
Stent,
re-stenosis.
See, if you have already given a web or something like that, already stenosis has occurred, then of course you have to take all these measures. If the anterior stenosis, you may have to use a keel or you may have to do some spacer to widen the space. There are many methods to, treat the subglottic or laryngeal stenosis. And that is again a very difficult issue in children to treat with.
Any role of antacid for long time is reflux is a positive factor in this case besides
What?
aggravating factor. The reflex, chronic
Reflex is always to be added on along with the other therapies. The reflex treatment is a part of management because the reflex acid into the laryngeal part will further stimulate this raw area, and the raw area is a something which is going to stimulate the viral replication.
Sir, kindly tell the position of the patient, the size of the tube, and
Yeah, I will show you. I will show you. Meantime, my associate is already, I have watched up. My associate already, fixed the laryngoscope. I'll show you the laryngoscopic picture also.
yes, sir. So which laryngoscope you are using, which size people want to know?
Which laryngoscope?
Yes, sir.
Okay. We have the entire set of laryngoscope, but here, as a rule, whatever widest possible for the child, we'll show you.
Suppose there is pulmonary extension of this lesion, then what is the plan of management in this case?
Again, same. Pulmonary means aggressive disease.
Yeah, aggressive.
Yeah, so you have to, remove the lesions if they are removable with a fiber guided laser or something. Fiber guided laser because with the, that cold method, what do you call that? But whatever means, and then bevacizumab. Bevacizumab is the mainstay of treatment. And then massive bronchopulmonary, this thing, papillomatosis blocking the airway. People are using now the tracheal stents. Tracheal stents for the mechanical compression of the papillomas.
Okay.
And that prevents the further growth as well. So that is one of the remedies for the massive bronchopulmonary papillomatosis, tracheal stents, by their mechanical effect. Besides the other treatment, adjuvant therapy will go on more aggressively, more systemic bevacizumab frequently, this IV bevacizumab, and those patients are tracheotomized frequently. That is really, I would say, most aggressive course of the disease.
Sir, have you noticed any side effects of bevacizumab in long term?
Not really. It is put to be very safe.
Satish,
Virender. Yeah.
Yeah.
you can hear me?
Yeah,
Yes, please.
Satish, have you noticed with time sometimes these lesions they regress with themselves?
Regressed?
Yeah, sometimes after so many surgeries, at the age of 15, 16, 18, suddenly you feel that, they're not
Yeah.
coming.
Autoinvolution has been reported. Autoinvolution has been reported, but that is very, very unlikely, uncommon, I would say.
Yeah.
And still it is not known how. But that is very, very uncommon.
What do you prefer? It is a microscope or a video endoscope? The endoscope.
Yeah, this is microscopic picture. Are you getting the picture?
Yes.
Microscopic.
Yeah. I hope the picture is good.
Yes, sir.
Yes.
See this tube, how the tube was introduced.
So difficult.
See, the airway was completely full of these, and the papillomas here are in the supraglottis, are on the arytenoid here, the fosscoid here on both sides, and probably in the glottis. I don't know the attachment below. I can't see beyond. And this is the fosscoid area. See, everywhere are the papillomas. Can you see?
Okay.
See this massive, component.
So what is the size of the tube?
It is 3.5, huh? Yeah, it is cuff tube. Suction. See this posteriorly.
Yeah, going up
Yes,
to
sir.
that.
Yes, sir. Going.
It was completely blocking the airway. Look, back there now.
And role of radiology means which one you prefer, CT or MRI in this case?
Not really. It is not going to, help in, changing your management.
Sir, any role of NBI? Many people do NBI.
NBI has a role, not in this. In next case of a CA vocal cord, which I am going to remove with a laser, early lesion, NBI has a role there. In many of the other pre-malignant, malignant lesions, NBI has a role. NBI can guide you during surgery as well. NBI is what? For everyone, narrow band imaging. It is because of certain filtered wavelengths lights, the neovascularization of the superficial areas of the mucosa and some mucosa can be highlighted. So wherever neovascularization going on, you can assume that some tumor is going to be there in early stage back. So like when you are operating on a laryngeal cancer, laser, small lesion, you can take the help of NBI by means of ascertaining the margins around if there could be some hidden lesion inside the mucosa or some mucosa. Superficial. NBI is for superficial lesion, not for depth. But that is very important. Even, the NBI has not only in the larynx, has a role in the oral cavity, pharynx, everywhere, for the superficial mucosal and submucosal areas. And that is a good technology. But here again, NBI has no role for that matter. So what I am using is a simple for sir there.
Implant वाले को बुलाएं? बंदे को बुलाएं implant?
दूसरा दे पैक. Hello?
Yes.
Yes, boss. दे भिगो के दे. So I am just decongesting on the surface.
Are you using adrenaline swab?
Yeah, simple saline adrenaline swabs. As well. So using microdebrider for safety in terms of minimizing the damage to the mucosa, you have to be, you have to bear with little bit of the oozing, some extra time, but that is certainly something which is very important for the patient here.
Do you use some local injections?
Not really.
As doing microlaryngeal surgery otherwise?
Not sir. Here, not at all, debrider.
You prefer microscope over endoscope, or choice is microscope only?
Microscope. Endoscope I can use in between, to ascertain the lesions in the corners or somewhere else if they are not in the size of the microscope. For that purpose, you can use endoscope.
Any specific blade, debrider blade for?
Yeah. This is the regular laryngeal debrider blade. How's the picture, sir?
Very good. Very clear.
So what I am going to use the micro debrider section. See my blade of the micro debrider away from the surface.
Yes.
Away from the surface, as I don't want to give any mucosal trauma.
You may pre-op steroids for some time?
Yes. See, the patient has a little respiratory distress for last, 48 hours, little mild. We got his COVID and all those protocols have to be followed.
Yes.
See, I am elevating this with a section. See, this is just luminal component. See this?
Yes.
Sir.
For laser, you prefer same tube or laser selective metallic tube for laser?
Yeah, laser tube. But in children here, and the laser tubes are not available of this sizes,
Yes, that's the problem.
And anyway, we are not going to use laser. The next case we are going to use laser. The next larynx case when we do.
Yeah. In that case, we use that.
Yeah, so we'll take the larynx case on this table and in between, we'll do a quick clear stapes surgery.
Yeah, we have long list today.
Yes, sir. Long.
See what I'm doing, just creating the airway.
Yeah.
Any specific COVID precautions you are taking apart from testing and all that for aerosol?
All precautions.
Yes, sir, all those. Level 2.
Like
Level 2 PPE, all screening outside the hospital, all these patients are screened.
for
Right.
aerosol, what are you doing? You are using some shield or
Shield.
shield?
See the vocal cord in picture?
Yes,
Yeah,
sir, we can see.
we can.
Very nice.
I'm trying to avoid, workshops there. I'm just creating airway. Wash, मेरे को दे wash. Back.
It's difficult to get 3 number tube, 3.5 number with cuffed one. So I think.
Yeah, we have 3 number cuff tube also. Sometime in such situation when patient has a huge proliferative lesions, initial, debulking we may have to under apnea also to avoid tracheostomy. Here also I may have to remove the tube in between to remove this posterior lesion. Let's see.
Sir, how is your experience between juvenile onset and adult onset papillomatosis?
Yes, the adult, almost same, these, but the adults have more chances of, malignant transformation. See, I am removing all the surface. Can you see?
Yeah.
Yes.
Here you need a full control. You need to have a proper control over the micro debrider. See this?
So I'm not trying it.
It's not that you are using on the false cord and false cord stenosis doesn't affect.
Yes.
It will stimulate viral replication in the adjacent area. So prevent.
Yeah.
I need card number. Somebody's card number.
I'll have to go up and bring it. Anu?
See how the vocal cord is badly affected.
Yes. You remove anterior commissure lesion and subclotic extension.
See, I am not going to the anterior commissure to give me raw area for that matter. I am just working on the surface everywhere. See this?
Yes.
Yeah.
I have opened the airway.
Yeah.
Yes.
My surface is what as it was. See this anterior commissure. I have not given any raw area at all. Only on the surface of the papillomas I was working. And now in the base where the papilloma is attached to, I will use that monoclonal antibody to prevent neovascularization.
Okay.
That is the, aim of surgery. Surgery's aim is not to radically remove it. Like considering it is a tumor, if I try to remove radically, I am inviting more problems. Wash. Yes, more. Order.
Dr. Rohan Pandey is asking, is this bleeding is a source of migration of papillomatosis?
Not really. We have a calf tube, we have a thorough irrigation. And see the picture is good?
Yeah, it's okay.
Excellent.
So with debrider this much of oozing is expected. I'll just again place my pack for a while. Then again see if something more to be removed, particularly the posterior area.
Yeah,
that is not visible because of the tube. Thoroughly.
Yeah.
Sometimes we have seen, the lesions outside the larynx as well.
Yeah, hidden lesions, sometimes incidental. This thing.
Yeah. But the bottom line is don't go to the depth of the lesion to remove radical. That is something inviting big problem. Scarring, stenosis, and that's something as difficult as papilloma to treat.
Yeah.
Now after this, since he has come to us for the first time, after this resection and the injection, we will do a planned laryngoscopy under GA after 4 to 6 weeks. There may be some growth of papilloma we are going to observe during that period. Not will be this kind of a picture will never be now. After the injection which we are going to make, this will have a definite effect on this, and the papilloma will come down. And after 4 to 6 weeks, when we do a planned, laryngoscopy and a planned infiltration again with the bevacizumab.
Okay. Okay.
That time after 4 to 6 weeks will require minimal debridement, if required. If required, minimal.
Okay.
But that is a planned one because we never know the growth in every case, how it goes differently. So that is a planned, See that the larynx is looking so good now?
Yeah.
Just remove the gauge. Now we can. Yeah,
That
it's
is-
looking better.
Now, what I will do, let me, chota de le. I will this, tube anteriorly.
Okay.
I will push this tube anteriorly. Just a moment, I will show you. Suction. And see the posterior part of the larynx as well.
When you extrude the case, you do some laryngeal wash or some suction because sometimes intubation can migrate that papillomatous lesion into the trachea or down. So
Yeah, but we have already checked. Now, when I was washing, I could see the cuff below. And even if there was something, it has come out, and probably was nothing. Yeah, pack that. Yeah. Forceps. Just a minute, I am connecting, boss.
okay. So you do recheck after 6 weeks usually.
Yeah, that is planned.
Yeah, plan.
4 to 6 weeks. A laryngoscopy under GA.
GA.
Is there a web in the anterior commission? Anterior commission is not very sharp.
No web. So far, no web.
Because it seems to be quite broad area anteriorly.
Yeah, I will show that.
Do you leave some tissue in anterior commission in order to prevent the stenosis of the anterior commission?
Not really. The best is to prevent raw area. Best is to prevent raw area rather than create raw area and try to prevent issues. Yes, I think it will not come. Give me the apnea. Oh, the same laryngoscope. What I will do, will remove the tube. Hello? पहले laryngoscope लगा लूँ फिर निकालना. पहले laryngoscope लगाऊँ फिर निकालना. I will put the same laryngoscope. I will show you the same picture. Then we will remove the tube and see the posterior part of the larynx. Because at this point of time, before injecting my, injection, I would like to see the posterior part of the larynx. Let me show you, just a minute. Yes. हटाइए कैरियर हटाओ कैरियर नॉट ट्यूब अरे रुकना यार
Larynx look good, okay.
Yes, sir. Very.
Is the picture okay?
Yeah, yes.
See, minimal surface lesions. Still there are minimal lesions.
For that collator we will use.
Cobbleter I use in case there is bleeding. Debrider. See some lesions towards the anterior part. Could you see here?
Yeah.
Yes, sir. Sir, many people do intraoperative MBI to see the fine dots of papilloma.
Yeah, I told you MBA is a thing, but not much for papillomas, what I believe. You have worked with Nupur. Nupur does use?
Yes, sir, in pre-op and
with papillomas.
Yes, sir.
But how do it is going to change your management in papillomas? Because our goal is not radical excision. Right?
Yes, sir, yes.
Now, wash. Give. See now the anteriorly it is pretty clear.
Yeah.
Yes.
I don't want to go submucosal at all. My goal is visible papilloma removal. See this?
Yes, sir, very clear.
Absolutely, except the posterior part, which now I am going to see with the apnea. See, no trauma at all.
Yes, sir. Mucosa is looking very good and healthy.
खींच lip tube. लोग खींच तैयार है ना? रिजर्व है? वो ले ले जेट. चलो remove. See now the posterior part?
Yes, sir.
Yeah.
Some surface lesions, Only these surface elevations I am going to remove. Not much.
Do you recommend some speech therapy or voice therapy after the surgery?
Pardon?
Some speech therapy or voice therapy for these patients?
Not needed. See now? Absolutely clear?
Yes, sir, very clear. Very clear.
Tube.
You can see.
Tube. Okay, two down. So now we'll re-intubate.
Yeah.
And then we'll fix our laryngoscope, and now I am going to inject my monoclonal antibody. So not creating the raw area, not going radical, not traumatizing mucosa, that is the goal of surgery. Surgery itself is not going to give cure.
Yeah.
Our aim of surgery, goal of surgery is very clear: to give airway, at the same time to preserve voice. Same time to preserve voice and same time to preserve stenosis. Now things are very clear. Just a moment, I am connecting. Go.
Dr. Sanjay Khanna is asking why not to use cobbleter here.
I didn't feel like there was hardly any oozing.
Yeah.
In case I find I have the cobbleter, the laryngeal vent ready. See now, there is hardly any oozing. See, the mucosa everywhere is almost intact. I mean, what was affected by papilloma is like that, but otherwise no neuro areas. You can see.
Yes, sir, injection. Mucosal preservation.
See that? Because they have to preserve the function. We have to preserve the function. And that is voice.
So what is the maximum time you have operated on a single child in papilloma?
I have operated at a child 6 times also.
Okay.
But nowadays, in last 3 years, not more than thrice.
Because of this antibody.
All these change in our approach. Even earlier, I used to use layer. Not at all now. Now see the final picture.
Yeah.
Yes, sir.
Is that good?
I think
Yes, very good, very good.
Now what I'm using to infiltrate, this long needle is PCL needle,
Okay.
percutaneous lithotripsy needle.
Very nice, sir.
See now the submucosal areas. See this?
Yes, sir, yes.
See this infiltration. That's it.
yeah. Wonderful.
In different areas, wherever I saw the papilloma was attached to. See here.
So you're giving in the paraglottic space.
Yeah, see this? See this? You see the fullness coming with the injection.
Yes, sir, we can see.
See here the papilloma was attached. See this? See this?
Yeah.
And one towards the anterior commissure there. It was a papilloma here. Quite significant. Hata. See this?
Beautiful. I think biggest message today is the best message that laser is not the only treatment, because sometimes laser can be cause of recurrence.
Yeah.
I think there are so many options.
And now in the posterior commissure, see this? Section there. No. This is a very fine needle, I am using high magnification here.
Yeah.
This is a very ultra fine needle.
So which needle do you use for fat injection?
See this now in the posterior commissure.
Yeah.
Yes. Your question, which needle?
So for fat injection in larynx, do you use the same PCNL needle?
No. That's a different needle. That's a fat with injector.
Okay. That injector,
Yeah, you must have seen at Nupur's place.
Yes, sir.
I follow her only.
How much total cc you have injected?
Total, I injected 1 ml. That means 50 milligram. Little bit remaining in that. So goal is 25 to 50. Rest 50 milligram will, give IV immediately afterwards.
How much time does it take for this liquid to get absorbed? Because will it not cause any airway compromise?
Not really. The airway is adequate.
No, because of the injection, if there's some swelling.
Yeah. I know there is swelling, there is fullness, the tube is in place. There is adequate airway. See the picture of the glottis.
Yeah.
Overall larynx. So the mucosa everywhere is preserved. Can you see?
Yes.
And that is the goal.
And you will repeat this after 6 weeks?
Over there. See the small patch, quite little, outside. Yeah, after 6 weeks. Can you see this?
Yeah.
Come here.
Satish?
Yeah.
Any role of mitomycin C in this?
Not really. Mitomycin is used as an antifibrotic. See, this was under very high magnification. I don't know how the picture was there.
It was excellent.
See this place? I use this additional. Can you see?
Yes.
That's it. So now, after 4 to 6 weeks, if you ask me how this is going to be appearing, believe me, absolutely like what you are seeing.
What is the post-operative care, immediate post-op? Immediate post-op care?
Nothing. We just, steroid will give 5 to 7 days.
Follow-up is 6 weeks, and then subsequently, how frequently do you follow?
Yeah, we do, in the outpatient department of the fiber optic laryngoscopy. Every month, the moment we find any new lesion appearing, rather than allowing it to grow bigger, we take under GA and inject again. And the rest of the, all the adjuvant therapies will go on.
You will just inject, you will not remove that small lesion. Okay.
Yeah, if there is visible, above the level of the mucosa.
Okay.
See, I just removed in the end, if you see, a few seconds before, that's some elevated lesion,
Yeah.
See now, the mucosa is absolutely flat to the level where it should be.
Yeah.
No elevated lesion left behind.
Yes, sir. Very nice.
No need of tracheotomy.
Yes.
No, sir. No, sir.
And see the airway now. And now in the base we have injected the anti-neoangiogenesis drug. See the anterior commissure.
Yes.
Then I could retract that. Give me vocal cord.
In these cases, when you suppose there's a total obstruction, would you recommend to go for tracheostomy?
See, let me put the vocal cord retractor. See this?
Yeah.
This is already some fibrosis of the anterior commissure. Can you see?
Yeah, we can.
Little bit. See that?
Yes.
Yeah.
Yes, sir. We can see.
Yeah, but no disease there. See this?
Do not break this, or you'll just leave it like that.
Give me calculator there. Let me break this. See this? I can use, laser is also a good tool for this.
Yeah. Suppose patient is complete obstruction, would you go for tracheostomy or would you just intubate and go for the surgery?
Yeah, I will intubate.
The pressure and the forceful intubation will not harm or it might be the thing.
Amazing.
Yeah.
This is my vocal cord retractor in place. I will remove it now.
Would you put any stent or just leave it like that?
Yeah, we'll leave it like this. Home again. I am not very sure about it. There was no harm in doing it. Already it was fused. So, what else it is going to give? Nothing.
Yes.
This was all about, papillomatosis. Yes, any questions?
Sir, Dr. Bokasam from Tirupati is asking, how will you manage lesions in the posterior part of the larynx in arytenoid?
The same thing I had shown now. I did under apnea.
Yes, sir.
I removed the tube. Just had shown you under apnea. Can I uska?
Yes.
Microscope
what is the
लगाओ.
commercial name of this David?
There are many names. Avastin is a popular. Microscope sub ready. Avastin is available all over. But yeah, the other companies are also available. The company we are using is not probably Avastin. It is much economical brand. Oh, देना रे नाम इसका? While देना while.
Sir, Dr. Palmendu from Kolkata is saying, excellent. He is mesmerized with the surgery.
Thank you, sir. This name is, Event. What is that? The trade name is Above Me 100 from the Mylan company. I don't know. You can see.
Okay.
Focus कर दो. Focus कर दो.
Beautiful.
Nice, sir.
And because this cost 8,000 something to the patient.
Good.
The other brand costs 30,000 plus. It's a huge difference.
So what about acyclovir? Dr. Sunil Sharma is saying he's using since long time. Role of acyclovir in this case.
Yeah, I mentioned in the slide earlier, all antiviral drugs have been tried because this is HPV, the virus.
Yes.
So believing that the antiviral drugs will work, people have tried. Cidofovir is antiviral, ribavirin is antiviral, acyclovir is antiviral, but they work much against the herpes simplex than this virus. So they are no more in the first line drugs. The thing which works, I mentioned in the last slide, the 5 adjuvant therapies, which we have reached to the conclusion after extensively reviewing the literature, which works. We have used them and found them good. That's why we are propagating. That's it. But still, there is no 100% cure to this disease.
Fuja, we have discussed. I think I have also used Fuja. It's work in some cases. And
what? Kuza?
Fuja, yeah.
Kuza has no role in this, boss. Kuza, I believe. Kuza is different thing. You saw the Kuza last time.
Yeah.
Kuza has no role in this because this is something different. Kuza cannot ensure, prevention of mucosal damage. Once you place on the mucosa, that is different. And secondly, that works on a different principle, not like the debrider by means of cutting ability with the suction together. It keeps the blood away. You can control the speed of micro debrider. You can do under vision. You saw we didn't damage the mucosa at all.
Yes,
we were right on the target where we wanted to be. And such a huge lesion with no space at all. It was difficult to intubate. I know. And it works well.
So do you dispose them, these debrider blade and cobbler when after these papilloma cases?
Most important question from Udbhav. Immediately, you are not supposed to use it again. Because this is contaminated now.
That is best.
This is something to be disposed of.
Yes,
at all. Many of the people are using these blades again and again. But this is something, a very important message, Udbhav. Thank you. That these blades to be disposed. They are not to be used again to infect another, innocent person. Now, do we go ahead with the next case? Here on the same table where we operated now, we are going to take the next case as a CA vocal cord, the T1 lesion of the vocal cord for cordectomy. We'll discuss the principles in detail and then how the laser has a big role. In that case, the laser will have a huge role as a principal role with some advantages. And now we are here with the next case. In between, I mentioned we have 3 stapes. We have already shown 3 stapes in the stapes webinar. So we are looking for more and more, stapes, as the varieties in stapes surgery is something unlimited. We did a stapes carnival in 2013 in Jaipur. 50 cases in 2 days we did, and had variety of cases including gushers and all. So in the last webinar also all 3 cases were different. The first case had a difficult foot plate. The second case had a difficult incus. And the third case was most favorable, wherein we did a reverse staptotomy without laser. So every condition is different, and to give in more and more opportunity to interact with different situations. These are 3 cases. So first case I am going to show you right from the beginning with flap elevation and all. Rest 2 cases will show in between. In the sense, I will not show the flap elevation, and curatives will be done by my associate, and will go directly to the pathology, to the fenestration and prosthesis, so that we can save a lot of time. The 3 cases will be finished quickly so that we can focus on more cases. So this patient, just quick review on the radiology. We have discussed in detail in the stapes webinar. So what all to be seen quickly related to this patient? I am coming from above. This is my semicircular canal, superior canal. I want to rule out all third window lesions. So what I will see on, see this? This is my vestibule here. See this? And this is the superior canal. Follow the superior canal. Good. Follow the superior canal. See this? Absolutely intact. Intact bone over it. So you need to rule out third window lesions because of any communication to the subarachnoid space, with the carotid artery. See the carotid cochlear, this septum is intact. All semicircular canals are intact. This is lateral canal, vestibule is normal in size, and the cochlea is normal with normal aperture, normal modulus. Just to quickly recapitulate what we need to see. So by and large the inner ear is absolutely normal. Secondly, beside that, this is the vestibular aqueduct, good. And here this is the cochlear aqueduct, is good, not very enlarged. Any of the aqueduct is not very enlarged. Now coming down to the atic, see the malleus and incus. Now see no anterior fixation of the malleus with any bone. Can you see clearly? And at the same time I would like to see if there is any superior fixation of the malleus. See this malleus? And superiorly also there is no bony fixation. Because this is one of the common, surprise one may get when you find in this conductive hearing loss. The patient has a normal TM and, conductive hearing loss, and you may have such kind of fixation of other ossicles, which you can certainly rule out. In case there is a malleus fixation, we can plan our surgery in the way that we can go to the atic and vaporize that bone, fixing the malleus to the atic, which is not required here. Just to rule out. Now coming to the cochlea. Cochlea is absolutely normal, not eroded anywhere. See this? There is no involvement of the inner ear. You can see all the 3 turns of the cochlea. Now coming to the ossicular chain. This is vestibule, can you see? And this is the level of the foot plate. And what is this there is the stapedial arch. Very clear? See the stapedial arch. And if I see dynamically, see this is the incus. See this is the incus. Incudostapedial joint. Can you see? Yes, sir. And then this is the incus body and the malleus. The entire ossicular chain look good, nice and intact. And the stapedial, both the crura are seen, visible. And this is right on the vestibule. This is what we wanted to see. Now third is any visible otosclerotic foci. We all know the otosclerotic foci is seen at the fistula antefenestrum. Here, if you see carefully, this is a small hypodense area. That is fistula antefenestrum. This small hypodense area, if you see carefully, the small foci, rest is all normal. Rest is all normal. And see toward the round window also, it is round window, it looks patent, and there is no hypodense area in relation to round window to rule out any round window otosclerosis. Now, most important other things are to rule out the abnormal conditions like persistent stapedial artery. I mentioned that day, if you have, you'll have a dilated facial canal. It doesn't look like, can you see? It doesn't look like, and you see the foramen ovale and the spinosum well in place. This is ovale, this is spinosum. It is intact, so there is no possibility of, it rules out the possibility of persistent stapedial artery. Lastly, the facial canal. See, this is the horizontal facial nerve. In axial section, you never know how inferior it is. So again, we have to go to the coronal with this reconstruction and see if the facial nerve is overhanging. See this. Now how to see? See the vestibule. Let me enlarge. Can you see the vestibule here? This is a superior canal, this is lateral canal, and this is intra-auditory meatus. See that? And now, and this is round window. And here is the oval window. See this. See now how the ossicular chain is coming to the oval window. See this. See the step is going to the oval window. Very clear. Can you see this? And see what is there above. This is facial nerve. So this, what you can see, this is the level of your oval window. See here in the depth. And this facial nerve is just above. The oval window is not very broad, big, but still the facial is not obscuring by means of coming down onto the oval window. See, it is not coming down to obscure the oval window from our visualization. Okay? And lastly, we go to the the jugular bulb. See, as I go down, this is the round window. We don't see any jugular bulb at this level. As we go down, this is round window level. As we go down, now the jugular bulb is coming. So it is far below. So as far as the anatomy is concerned or any surprise diagnosis, I don't think it should create a major problem. Now rest of the thing, let's explore. So in the first case, I am going to start right from the beginning, and then the next two cases will show after the flap elevation, so that we can show more variety. And the next case will be the CA vocal cord. Any questions?
These are 0.5 mm cut.
0.5 mm. You can see points. This is 0.7 here. Sorry, let me show you.
So we should get at least 0.5 or 0.7 of.
Yeah. See this one. This is 0.7 mm here. Can you see? This is 0.7 mm cut.
The last time you told, it is not always that we see the hypodense ABL fistula and fistula. Sometimes
You may not see. You may not see. You may find absolutely normal, anatomy without any visible otosclerotic foci, because that is sometimes so small, but that is good enough to fix the foot plate. And the patient has a moderate conductive hearing loss, bilateral, same pattern with an intact drum. Let's explore what it can be. So our procedure is obviously an exploration. And the next case is now this patient is extubated already. So we'll intubate the next one in the other theatre.
There's a confusion is there. I asked for CUSA, not CUSA. That road in the capillary.
What do you ask for?
CUSA. Role of CUSA in capillary, not CUSA.
Not CUSA, then what?
I asked what CUSA, role of CUSA in the recurrent papillomatus.
Still I didn't get.
Why it's not?
Thuja. Yeah, Thuja. Thuja has a role. Sir has already mentioned. Girish Mishra sir had mentioned. It's a homeopathic drug which is very popular for the papilloma management. It has been used for other papillomas, so used for laryngeal papillomas also. Not very specific. We don't know what the content is, but even in the homeopathic literature, it has been proven to have a efficacy against the papillomas. So we are using. And we are using because we don't have any definitive answer.
Yeah, that's
So we can continue questions. In the meantime, I'm washing up.
What are the chances of Mealy's fixation even if radiology doesn't help? Means if radiologically
Yes.
we are sure that there is no Mealy's
Yes.
fixation above or
Intelligent question, Vishal, intelligent question. There are chances. The reason is radiology can pick up the bony fixation. It may not pick up the hyalinized ligaments,
yes, that was
So hyalinized ligament again can affect the mobility of the ossicles, which may not be picked up by radiology. So that's why I said we'll finally see on exploration. This is a broad overview to rule out any major issues. We discussed in detail last time the mallear ligament fixation. The Ashim had a, he explained in detail. Ashim had a huge experience of stapes surgery. We saw him, and in his series, he has found up to 10 to 15% patients having anterior malleolar ligament fixation to the level that affecting the hearing. Maybe mild, but yes, affecting the hearing. So that is something you cannot ignore.
one question is why we recommend at least 3 to 4 months gap between two studies?
Not 3 to 4 months. Sometimes people 1 or 2 years.
Yeah, why we
Because there are reasons to it. Number one, in stapes surgery, since we open the inner ear, and for that matter, any other surgery, when we operate in the middle ear, the ongoing reparative process, it goes up to or lasts up to 1 year.
Yeah.
So we need to stabilize the things until the reparative processes is over, number one. And in stapes particularly, since we open the inner ear, we are little concerned about, because every stapes has a potential sensorineural hearing loss. So it is always better to wait for at least a year, or some people wait for 2 years. There is no harm. And once you have given hearing in 1 year, there should be no rush for the other year. Yes. Yes, sir.
Why do you prefer endometal over endoral incision?
Same, if you are comfortable with it, you can always add a mini endoral like Ashim does. In case you are not.
Makes your both hands free if you are using a repeater.
Yeah, still you can make both hands free by using an appropriate size speculum, or by taking the help of your assistant if you have a regular assistant who can help you. Still you can. Majority of the times we go endometal.
So Dr. K.C. Prasad from Kolar is asking, is there any way to know the thickness of foot plate pre-op?
Yes, cone beam CT scan. We have many times, this patient has already the scan done. Otherwise, we get a cone beam scan done. When it comes to ordering a scan, of the temporal bone, hydrogel scan, cone beam, we can have the thickness up to 0.05 mm. And we have many times measured the thickness of the foot plate. There are many publications also which corroborates well with the cone beam. If cone beam shows thickness 0.3 mm, it is most likely 0.3. Many of the studies have been done. See, this is my horizontal incision, and this is a vertical. You have seen in the previous, how we make the flaps. This is just for people who had not seen earlier. That was the inferior. Now the
Why giving local in these cases?
Yeah, you are. Yeah, be careful not to create flaps. Nothing else. And we don't use strong infiltration like. Strong means this is just 1:2 legs. So 1:2 legs to prevent the flap necrosis. Not like 1:30,000, 60,000. A lot of people try to use to avoid bleeding, The best is use the regular one and wait for 10 to 15 minutes. The effect is going. Now see superiorly how thick the flap is. And you're not supposed to go in one go. See, in multiple goings, I'm reaching the level of the bone. And this flap, I am not going to give any release incision. As in case, like Vishal asked, in case some malleolar ligament fixation doubts, I can always go anteriorly to the malleolar ligament and do something to it. See, I have a full liberty to extend it anteriorly as much as I want. Not limiting anywhere this superiorly. Those who have joined, those who were not there in the last stapes webinar, we had a very useful discussion with Ashim and Ashish. They can go to the YouTube and watch that again.
So especially the first 3 hours discussion on the pre-op protocols and everything is very important. In detail we discuss each and everything. I think everyone should listen to this.
See, I have elevated superiorly more. Now, coming back.
Suppose at this level the tear to happen and left with some tear at this level, annulus, what you will do after surgery?
Yes. At the end of the surgery, you have to repair it. You have to repair at the end of the surgery, like we do in tympanoplasty. See, now I am reaching the level of the annulus. So I will reflect my flap anteriorly, and inferiorly I have already given a release incision. Just reach to the level of the annulus. Stapes surgery is always full of surprises. In spite of everything, you may get surprised because the fine difference in the anatomy makes a lot of difference.
I get more chance on the day of stapes, not on the day of implant.
More?
I get more chance on the day of stapes.
Yes.
Less on the day of implant. Implant is more.
Yes, exactly. See the overhang. This is different in different people. The canal anatomy is so variable.
Yes, canal is like
Narrow, tortuous. So you should be able to overcome. You can't help it. Let it be, whatever. Now, inferiorly, I will elevate to the level of my incision, so I can maximally push anteriorly. This is how my flap is not going to come my way. See this? So this is pushed anteriorly. This is not going to come. Now, our area of interest is superior.
You decongested the canal before giving local infiltration?
Not really.
Not.
Now see the glimpse of certain things. See, I can see the glimpse of, incus below and the chorda tympani. Chota cotton ball. What I will do additionally here, I will push this inferior flap so it doesn't fall back, with a small cotton ball anteriorly. Here. See this?
Yes, sir. Yes.
So now it will not fall again and again. See, our area will remain more and more open. Now, if I focus there down, this is your chorda tympani. See this?
Yes, sir.
And below that is your incus. And there is always some adhesions between the incus and the ossicles, See this? You can break them, curate. Now, I hope the picture is clear.
Yeah, it's clear. Glare is more.
Glare. Let me know. ज़्यादा ही स्पेकुलम चेंज कर.
Dr. Rajeev, Dr. Umesh Singh, he has done, I think, project of stepping the post-oral approach. He does with post-oral approach.
Yeah, post-oral, if he is used to, he can do it. He is a very senior person, very experienced. Otherwise, we avoid post-oral for the line of sight, is away. Yeah, see. See now? I am. Yeah, the same Karl Stoves curate.
Long time.
Yeah. This is I'm using for years. Some part of the ossicles now coming into the picture. See the incus, the morphology of the incus.
Yeah, different.
Yes. I can see the glimpse of the foot plate, the tendon. You can see everything.
Yeah.
Ideal case.
Yeah, the old window I told you is not very broad because I saw in the coronal the height was less. Old window height was less overall. Yeah, this curettage, this movement should be away from all important things. It should be away from the chorda. It should be away from the ossicles. This movement can be detrimental if you are not careful.
Yeah. What are the other methods of removing overhang?
Simple drill. You can take the drill.
The drill prior to elevating the flap or elevate the flap and then drill.
Yes.
To prevent the bone dust from going inside.
Yeah, I can leave a cotton ball wash away. This is not too much of drilling. Drill is a very simple way. See this? More and more. Right angle.
No exposure enough, I think.
First variable is at this point, incus is dislocated.
Oh, that's a disaster. Number one. Number two, if it happens to occur, now what kind of dislocation it depends. If the dislocation is to the level that it is completely, out of the joint, then you may have to go to the attic. There are many ways. If it is partial, you can repose it. You can see from here the malioinguinal joint, from here. I showed last time, if you remember, I will show you. And you can apply a drop of fibrin glue, reposite it, and come back after some time, after a few months. If it is completely dislocated, then you have two options. Either to go by a maliostepidiopexy,
I share the video on that day. Dislocating
yes.
wrong way of curating can dislocate it.
Yeah, can you see the tendon?
Yeah, we can.
I'm sure no glaze now. Because that speculum was giving problems, so this point of time, remove the speculum for a while. Correct. Now posteriorly, my aim is to that level that because I use a clip piston, I need little extra. See this curettage. I have ample of space now. See this? Hello? Superiorly to the level where the incus starts broadening into the body. See that? See that?
Yes.
Incus superiorly has started broadening in the body. See that? And that is the inferior edge of the inguinal joint. See that? See the joint proper. Inferior edge of the joint. That is my superior limit of widening. See, let me focus on the joint. A lot of people ask how superiorly to go. That is the ideal limit. Can you see the joint?
Yeah.
See the malleus anteriorly.
Yes.
Very clear?
Very clear, yes.
And that is the inferior edge of the inguinal. That is my superior limit. Now see the facial now.
Yeah, very clearly.
See, I told you the height of the oval window was not that much. And once the height is less, you can assume there could be some dehiscence of the facial also. Because this tympanic segment of the facial is very commonly having dehiscence. See that?
Yeah.
Now my next goal is to assess the mobility. Right? Next slide. Next slide.
Someone ready.
1 year already. What happened?
That's loss is there. Moderate to severe.
1 year.
Yeah.
Because of the previous surgery.
Previous surgery or any other reason.
So that means the only hearing ear.
Yes, yes.
See, this we discussed last time. Again, I tell you. In why we were avoiding earlier the surgery in the only hearing. Only hearing ear. Why we were avoiding? Because of the possibility of another sensory hearing loss. And then when the patient already has a hearing loss in one ear, you can totally deprive him of hearing. Now with the availability of, rehabilitation by means of various methods, the ideal way is first check the opposite ear whether the hearing is edible or not. If it is edible, go for the hearing, the staphylotomy in the other ear. If it is a good candidate, go for staphylotomy in the other ear. If it is not edible, and if it is implantable, again you can go with the staphylotomy in the other ear. And if anything untoward happens, you still have a chance to rehabilitate. Okay? So in the present era, no contraindication. Now see I am checking the mobility. See, I am stabilizing the malleus. Yes. See now, where is the joint? See the joint below.
Yes,
Suction there.
Dr. Satish,
Yes, please, sir.
I had a case whom I had operated almost 15 years back
Yes, sir.
and doing well for stapes surgery, and then he came with conductive hearing loss on the same side. Other side was of course having conductive loss.
Okay.
We found that the long press of incus was necrosed because of Teflon piston. And the piston and the necrosed part were just like...
One of the commonest finding.
Yeah.
See, this was the joint. Yeah, I am coming, sir. See, this was the joint, and this is my joint knife. See this?
Yes, sir. Yes.
Yeah. So on exploration after the surgery, stapes surgery, patient having conductive hearing loss, which is the commonest reason for exploration, or rather ideal indication for exploration, and the commonest finding is the piston, giving necrosis of the long process of the incus. So now, depending upon the length of the incus available, you have. How long the incus was? The available length?
Just near the body, where the long process starts broadening towards the...
Oh, that means the major part of the incus gone.
Yeah.
Because in the minor necrosis, you can lengthen the long process with the bone cement and carry out this regular, incudus staphylotomy. But if this much of the incus is necrosed, then the best is to do a malleus staphylotomy.
That is your prosthesis from malleus to foot plate.
Prosthesis for malleus to foot plate. Malleus just below the malleus neck.
Okay.
Normal Teflon piston can work.
Yeah, but see again, this patient is already, a victim of a Teflon piston.
You have titanium pistons available from malleus to foot plate?
Yes, very nice with a special piston with a ball and socket joint,
Okay.
So with that piston, the beauty of the piston is you get the piston height perpendicular to the stapes directly because it is a ball and socket joint.
And the piston is below the neck or above the neck?
Just below the neck.
Just below the neck.
That is the ideal side because above the neck, the broadness of the malleus doesn't allow the piston, number one, properly. Though you can do one thing, you can drill with your diamond the neck a little bit and still you can. But the best is just below the neck, make a facet, and that is ideal.
Do you need to interpose something because then the piston will
Laser on?
contact with the drum directly?
No, yeah, always interpose a piece of cartilage, thin piece of slice of cartilage. Now see, I have
maximum
Yeah.
exposure. Wonderful. In that case, vein graft is also necessary.
No.
Now,
Ab aaya. Yeah, pardon, yes, what?
At this point in time, if you don't have that crystal available, Melius to put plate. So is it worthwhile going for the opposite ear stapes surgery and giving a good hearing? Because the other ear is already having conductive deafness.
But then what to do at this point of time to this year?
You close it, patient is having serviceable hearing is not there because other ear is deaf, he was waiting for it to get done.
Yeah.
And
So
now is developed deafness.
if you are not,
Profession.
yeah, if you are not in position to give him good hearing by Melius tracheotomy at that point of time, then you can take call accordingly. But Melius tracheotomy, a properly done Melius tracheotomy has a good result.
So many times you don't have this thing in the stock, because
Yeah, I got your point.
it can come out.
Yeah, give me a suction. Now see what I'm scared of using laser here. My facial, which is looking thick because of the reduced height of the oval window, I am suspecting some minor adhesions of the facial also.
Yes, sir.
So what I will do beyond this, I will put a gel foam as a shock absorber to my laser. See this? Beam, section. I will come with my laser now. See, this is such a narrow area, and every time you come across some or other difficulty, there could be facial descent, there could be overcrowding of the structures, reduced height of the whole window. Every case is little different. Now see my laser beam?
Yeah.
Yes, sir.
I will simply, I can cut this tendon easily, but I use this as a rehearsal,
Yeah, for
that my beam is in alignment or not. See that?
Yes, sir.
yeah.
See that?
One good point.
Yes. Gone, sir. Gone.
Rehearsal for laser, that's a good point.
Yes. And see my gel foam is protecting the facial now.
Yes.
Sir, many people are asking what are the laser settings you use in stapes.
Yeah, different, For tendon, I use the 4 watts.
Okay.
For this, the crust, posterior crust, it is stout. See this?
Yes, sir.
Yes.
See, it is perforated.
Yes, sir.
See this?
Yes.
So what I have done, I have weakened the crust.
Yeah.
See, weakening the posterior crust is good enough. Why to use laser more? See now, I can easily break it now.
How is your experience with the craniotomy
See
seizure?
this? I can easily break it now.
Yeah.
Very nice, sir. Very nice.
And anterior is fragile, you can easily break.
How is your experience with the craniotomy seizure?
See this? Craniotomy seizures is again as a possibility of giving mechanical stimulus. See, laser is atraumatic. The energy is not transferring beyond that wherever you are using.
So I think for the audience, sir has shown the stapes without laser in the stapes webinar, so people can go and watch that.
I showed last time.
Yes, sir, without laser. So thank
Good
you.
again, he will show
See
no
some mucosal adhesions.
Yeah.
The facial is little overhanging.
But at this point, one question: if
whole
See my
foot
foot
plate
plate.
is coming out.
Yeah, yeah.
Whole foot plate is coming out at this point.
Yeah.
Then
First of all,
what
again, I
next?
would say it's a disaster. Number one.
Yeah.
That's why this laser has a role. That's why laser is something which can certainly avoid this. Now see my foot plate so nicely.
Yes, sir. Very nice.
So in case what you can do otherwise, suppose you don't have a foot laser, you
Yes.
can either give a floater. If you mobilize the foot plate, you can give a floater, or you can bring the foot plate out of the vestibule by means of at the time of fracturing the crus. You know.
Yes. Yeah. Yeah.
And that is a
And then,
disaster because that is a sort of total platinectomy.
but still we can do vein graft and all
Yes, yes,
piston. Yeah.
you have to, you have to
We have
seal the
yes,
vestibule.
yes, yes, yes.
That's why before hysterectomy, you should know how to take the vein graft and how to prepare it. That is the major requisite.
Yeah. Now see my area is very clear.
Yeah, yeah.
Yes.
Yes, sir.
Yeah, let's go. Section. See the foot plate.
Yeah. Clear.
Now my goal of fenestration, I told you that day.
Fine focus, please. Fine.
Yeah. My area of fenestration would be in the center of the foot plate, at the central part, inferiorly.
Inferior.
See how anteriorly that area is there. I am not going to go there and do that because that is something close to the sacule below. Here is the central part. See that?
Yeah.
Yes.
And first of all, I'll measure my required length of the piston. So since I'm using, I told you the simplest way piston one can think of in terms of application. It's like a video game. A piston should be simple to use, first of all. ये क्या रहा है? इसको कुछ लग रहा है क्या? Clean. Section. See, you have to wait for the hemostasis. I am under magnification. Even a micro drop makes a difference. See this?
Yes, sir.
Can we use adrenaline gel foam before this fenestration?
I generally don't use.
No.
This is hardly any bleeding, just a dry gel foam for a minute.
Such a dry, narrow field, you can't use a reverse technique.
Reverse, we have already removed the suprastructures.
No, otherwise we had to do it.
Yeah, no, this is not favorable.
Quite narrow area, right?
Yeah, this is not favorable for that.
Yes.
So since I am going to use a Kurz piston, I am going to use same Kurz, measuring gauge. Section.
First, please elaborate that point, that promontory drilling, if there is a very narrow oval.
Okay.
See, that is very important point.
Yeah, see this part of the promontory behind here. If you remember, I showed in the cochlear dissection in temporal bone dissection.
Yes.
This is the part of the ascending, limb of the cochlea.
Yes.
So here, this is closest to the foot plate, closest to the vestibule, 0.3 millimeter below. But here the bone, the itself bone of the cochlea, the promontory, is more than a millimeter thick.
Yes.
So if you drill posteriorly, you practically doesn't puncture the endosteum. Section.
Any comment about tendon preserving staphylectomy?
Not really. See, in long run, इधर ध्यान देना यार. It doesn't work.
In long run,
It doesn't work. In sense, though a lot of studies are done, it looks promising. But
yeah.
see, this tendon itself gets hyalinized in long-standing fixations, you know. Tendon gets hyalinized. So it no longer remains with same efficiency.
What is the importance of removal of mucosa over the foot plate?
Yeah, it's always good if you are doing a vein graft, always remove. But here the laser serves the same purpose.
Yes.
लो मेरे को नापने का दो. See, I am measuring with the gauge I showed you last time. Let me show you. What is this? This is parameter. Can you see the lot of parameters on this?
Yeah.
Yes, sir. Yes, sir.
This is 1 mm, 2 mm, 3 mm, 4 mm, 4.25, 4.5, 7.5, 5, 6, like this. So let me keep it at 4.5. Now, whatever it is, you know, see this much is projecting out. And this bar should coincide with the thickness of the incus. Then it would be 4.5. Suppose I make it 4.25, then this will remain out.
Yes.
So this gives you a very good idea, and that includes the thickness of the piston and 0.3 mm, what we are supposed to stay inside. So this is parameter, not the length. Okay?
Yes. Sir.
Give me. See, a little higher.
Yes.
Dr. Ashish Bhumkar has commented that this cord has created some notch on the incus.
Now this is good. See this?
Yes, sir.
This is 4.25. What he says, chorda has created a notch. Yeah, chorda is the optical, you know. Chorda is here to
Do you
create
think it is incus is comparatively shorter?
little. You can
Yeah.
say. You can say. Suction. इससे पतला दे. और एक छोटा ना, छोटा वो दे.
So you will add 0.25 in this piston, sir, for the foot plate?
No. I will use the same company 4.25 size.
Okay.
This is size, you know. This is size.
Okay.
हल्का सा लगा के दे, हल्का सा.
So some Patidar wants to know difficult to anti-crush.
Yes,
What
it's not
are the
common.
different types of?
Yeah, that day Ashish spoke about it.
Yeah, lots of.
And here the recording also, we forgot to show that. Difficult anterior crush is a big problem if it is there.
Yes.
It is uncommon, highly uncommon. But if it is, it can lead to problems, you know.
Yeah, sometimes we have acro.
आगे में technical introduction दिया. We welcome our young dynamic superstar of ENT, Dr. Rajeev. He has worked with many stalwarts of India. सबके नाम लिया, रामलिंगम का भी नाम लिया. बीच में भी लगातार मैं क्वेश्चन में इनपुट दे रहा हूँ. आखिर में क्वेश्चन पूछा कि very important and most valuable question asked by Udbhav. मतलब लगातार सही से चल रहा है, healthy discussion. YouTube पे साइकिल वीडियो कमेंट.
Can you see my laser beam?
Yes, very clear.
Yes, sir.
See now, I will focus it in the center.
ये जब स्टेपिलोटोमी होगी.
Center inferiorly. This is 0.5 mm. See this?
मनीष मुंडाब ये हैं, ये आनंद.
Udbhav, Dr. Udbhav Mittal.
Volume, please.
Yeah. Good afternoon, Satish sir.
Hello, Paramita. How are you?
Good, sir. How are you? Yes, I'm watching your surgery, sir.
Oh, you are here back. See now my beam? Can you see?
Yes, sir. Yes, sir. We can see.
The beauty of this laser is this shot. See that?
Yeah, single shot.
Can you see?
Yes,
I
sir.
got the fenestra at the side where I wanted. See this little.
Yeah.
This is exactly 0.5 mm. This is in the center part. And see, it is full of perilymph.
Yes, yes.
Now, if your vestibule is full of perilymph, this perilymph acts as a shock absorber, for the laser beam. This laser, CO2 has a, ability to get absorbed in water. And that is what protective here. Had this been a KTP or argon, any visible laser, they pass through the fluid. They're not absorbed by the fluid. And that can be dangerous. It can damage then the membranous labyrinth. And now see.
So what is the laser setting during the fenestra making?
Pardon?
So what is the laser setting while making this fenestra? What was the setting for the laser?
20 watts. See, I just my piston just rotated. What I did, I kept my piston at the fenestra, See this?
Yes, yes.
I will little bring it high up. See this?
Yeah.
It should be 0.5 mm from the edge of the incus.
Yes, sir. Yes.
See this? See right on the fenestra below.
Yes, yes.
And what then you have to do is gently. Yes. See my piston middle slot?
Yes, sir. Clearly seen.
The beauty of this piston, it is like a video game. So easy to apply. You literally don't have to fight with the piston, play with the piston.
Wonderful, sir.
So your fenestra is 0.5 and your piston is 0.4.
0.4. So 0.05 mm sort of annular ligament as the endoscale membrane forms will form all around.
Ideally, which is the best side? Which side is 0.5, 0.6 fenestra is the best? Which one is best?
Above 0.4 is good. 0.4, 0.6. Yeah, same, almost same. But it should not be below 0.4, number one. Below 0.4 will not be able to transmit the sound effectively. And number two, it should not be too big to create a sort of partial stapedectomy. Because the bigger you make, otherwise more you'll have, have a possibility of giving choice. SNHL at the higher frequencies. The beauty of these pistons, the smaller piston is to preserve the higher frequency. See the piston?
Yes, sir, we can see.
The best part is only less than 1/3 of the circumference of the incus is in contact with the piston. See that?
Yes, sir.
And it is holding so tightly like a clip. There is no play between the incus and the piston. No play at all. See that?
You don't use any tissue seal for fenestra? No.
Pardon?
You don't use any tissue seal for fenestra. It will automatically seal.
I will drop pour a drop of blood.
Okay.
I'm just checking everything.
Natural
I showed you last time.
Yes, sir.
See that fenestra, piston, everything in order?
Yep.
Yes, sir.
Yes.
The beauty of this piston is you don't need a crimping. Crimping is a, disaster sometimes. To have an accurate crimping, Ashish, if you saw the Ashish and Ashim's video, he uses 2 hands to crimp.
2 hands.
That is superhuman effort, I believe me. It is otherwise so difficult.
Or you should have very good quality of means so that crimping concept. Otherwise, a normal Also, just hold the piston and just
See?
sometimes you dislodge it.
Yeah, see, things are good. And
Yeah,
I'll just pour. See that drop of blood? Can you see?
yeah.
Yes, yes.
That itself will seal. Okay?
This is auto blood or?
Yeah, auto.
Yeah, it will. Somebody will close. So my associate will close it. See what you expect from a good piston. It should be extremely biocompatible with titanium is. There is no comparison to titanium. It should be stiff to transfer the sound energy completely. And third is there should be no play between the piston and the incus, which this piston offers.
Yeah.
I am not criticizing Teflon, but a Teflon need to be crimped.
Yeah, that's fine.
One more thing.
The Teflon need to be crimped. And that crimping process can be a disaster sometime. If it is too light a crimping, less a crimping, a loose piston will remain. And like sir gave an example, incus necrosis, a loose piston which is fixed below at the lower end and the upper end is loose. That vibrating piston is going to give problem at the upper end of the incus and can lead to incus necrosis. So loose piston can be a disaster.
So
and a tight piston, if you try to do a tight crimping, with a Teflon piston, that crimping process itself should be very, very calculated. Number one, that loop of the piston should not be circumferentially enveloping the incus. That is one of the factors which can lead to strangulate the incus and lead to necrosis. Number two, that process of crimping tightly can lead to malioinguinal joint dislocation. And that is more a disaster. In this piston, you just apply, the clip will open, the gentle opening of the clip, you push and the middle slot will take the incus tightly. Unlike a clip, only less than 30% of the circumference of the incus is in contact. No question of strangulating, necrosis, vascular supply, no play between the incus and the piston. Extremely biocompatible material. And
1 point
which you expect from an ideal piston. Yes, boss.
1 point of discussion is that when we should discharge the patient, means what is the earliest time we can discharge the patient after the step is?
See, if it goes uneventful, next day you can discharge.
Yeah, 24 hours is minimum actually.
Ideally you should, because you open an area, you may have some mild symptoms, because everything, even if it goes uneventful, you never know what can happen post-op. We discussed in detail last time. There are so many factors which are beyond your control to give problems to the vestibule, to the inner ear system, to the vestibular system. That's why, if you notice, at no point of time you should, try to aspirate over the fenestra. That is one of the most important thing to give problems. Commonest. Never ever try to suck over the fenestra.
Dr. NMK Raju is asking, do you encounter any post-op vertigo during these cases and how to manage them?
Yeah, sometimes we have mild vertigo. It is all because of operative trauma. Number two, you never know the status of the endolymphatic system inside. If there is some silent hydrops or something going on, you never know. There can be a big problem even in an uneventful stepes surgery if there is a hydrops inside. That's why I emphasized last time the value of MRI if patient is willing to be done. MRI can tell you the exact situation of the endolymphatic system. If you get 4 hours after gadolinium injection, IV gadolinium, and after 4 hours you acquire MRI, it will be taken up by the perilymphatic space and you can see the perilymphatic and endolymphatic spaces separately. You can exactly assess the degree of hydrops. If at all you find, you can defer the surgery.
Do you give post-op steroids in these patients?
Yes, for 4-5 days we give. 5 days, just betnesol, simple betnesol for 5 to 7 days. And this has been a regular practice I have been following what ABR sir used to do. and this is good once you open the inner ear, see some sort of serous labyrinthitis sets in. That is inevitable, serous. And steroid is something which is useful to control that.
Any other medication apart from antibiotic and steroids?
One day injectable ceftazidime, and that's it. That according to your convenience, you want, if you want to give something symptomatic.
When will you think of re-exploration post-operatively?
Re-exploration has certain indications.
Means a long piston or anything?
Yes. If your unusual symptoms which you are not expecting, like in this kind of a situation when you have an uneventful stapes, you have a properly measured piston, no question of an overlong piston or anything which has gone wrong. That is one situation. One is a person who is not experienced and by mistake put a long piston or something.
Yes.
So if you have post-op symptoms, according to the symptoms, if in a day or two, sometime all these symptoms settle down, sometime unusual symptoms settle down with a, conservative management for a day or two, with the vestibular suppressant and the steroid and all that. If it persists, then according to your experience, what kind of surgery you have done. Like this case I have done, I don't see any possibility of re-exploration. In case persists, you can take the help of radiology. Radiology in the sense that can tell you the length of the piston intravestibular. If it is, overlong piston or something, or if there is a persistent fistula, which may be symptomatic. Sometimes it becomes symptomatic even in the early phase. So few days you have to observe. You can take the help of radiology. If the gravity of the symptoms do not come down and radiology point out to something, and you are suspicious of that thing from your surgery as well, then only you explore.
You do intraoperative audiometry post-op as ABR sir does.
Ashim, ABR always. ABR sir, Ashim, they will always do.
Do you assess hearing in post-op period, like Weber or something?
Yes. After putting the flap in position back, we assess objectively.
But suppose the Weber gets lateralized after 3 days, 4 days, would you explore?
Yeah, that is something that will be associated with some symptoms, sir. If the sensorineural hearing loss is coming, immediate post-op period, there has to be something which has gone wrong. And there will be some sort of vertigo or also something which will persist. Tinnitus, some abnormal symptoms, sometimes abnormal sounds, whatever. And that is something which warrants at least radiology before the exploration. It depends upon the expertise what the surgeon has done and how you have realized. Like if some novice surgeon has done and patient has come to you, definitely you will explore. But like if some experienced surgeon has done, like I mentioned that if Ashim has done something and is not found wrong and patient has some problem, I will never dare to re-explore because there are certain regions which are beyond your capacity which can give problem. I mentioned I had a slide that time because the inner ear environment has totally changed. There could be some sort of high drops, there could be some sort of, the inner ear mechanics change, ionic imbalance change, so many things which is given to problem after ruling out the mechanical issues.
How about tinnitus? How do you reassure the patient? Many patients come with tinnitus and they ask whether it will go away or not. So what are the chances of tinnitus disappearing after procedure or they still persist? How do you counsel the patient about it?
See, counseling is different, but I tell you in hearts and hearts, majority of in pure conductive losses, majority of the low frequency tinnitus disappear.
Yes.
Patients who are asking upfront, you cannot reassure.
Yes.
Those are the patients that you have to tell what they are operating for is a conductive hearing loss. If the reason behind this tinnitus is a conductive loss, you may improve. Otherwise, you never know. The tinnitus is something which is, beyond control. Controlling tinnitus, and sometimes a psychological aspect is also involved. Some patients are too concerned. Some patients are too concerned and come to you for surgery only because of tinnitus, and those you have to be careful. They can drag you down to the court.
How much should be minimum AB gap? You will recommend for studies. Minimum AB gap.
Ideally, it should be 25-30 decibel.
Oh,
But
that's
I gave you reason that day, if you remember.
yeah.
Sometime patient present with even minimal AB gap, 15 to 20 dB, because initially where this foci starts at the fistula antefenestrum, it pushes the footplate behind. And as it pushes the footplate behind, it is not the true fixation of the footplate all around at the annular ligament. It is because of the pseudo fixation at the posterior vestibular joint. So the footplate is pushed behind to give some fixation, which is giving rise to 15 to 20 decibel. You have to be careful in that situation.
Yes.
I can do it with a laser in hand, automatically without mobilizing the suprastructure footplate. Still you can go ahead, but the patient will not appreciate that much of an improvement. But if you don't have a laser and if you try to do with that minimal airborne gap, it can be a disaster. You can mobilize like what Vishal was asking. If the footplate comes out, mobilizes, those complications happen to occur when the footplate is incompletely fixed. So best is to wait for at least 30 dB to keep your surgical life easier, the intraoperative life course easier.
There is an airborne gap, definite 30-40 decibels, but bone conduction thresholds are low, like 15-20. Is sort of a mixed element, but the conductive element is also there.
Yeah.
Rene is negative with all three. So would you still explore?
Yes. Before that, I will critically go through the radiology.
Okay.
These are the cases where the radiology can be game changing. There are so many
points
situations.
Would you analyze in this critical analysis? What points would you emphasize upon?
Yes. So number one, in such low frequency losses, you have to rule out, first of all, with a mixed loss, you have to rule out any inner ear pathology which can be associated, like any sort of enlarged vestibular aqueduct, any sort of third window lesion, any sort of, the cochlear involvement or anything. That you have to rule out. And this happens very commonly in young age patients, young individuals. So you have to be careful in those situations, otherwise you may get an intraoperative surprise. So radiology is essential in those situations. If you, file is corrupted, bola na mera laptop. Any question or we can continue? We can move. Go ahead with the next case.
Udbhav. Unmute. Udbhav, unmute yourself.
Like Dr. Mohan from Bangalore is asking, have you encountered any foreign body reaction with this implant? Piston?
Yeah. Any
foreign body reaction with piston?
Honestly speaking, I've been using this piston for years now, and I have never, found the reason to re-explore for the reason of piston.
Okay.
That is the beauty of this piston. What we see, that the piston is so well aligned to the incus. A loose piston is always a problem. Long piston is always a problem. Biocompatibility, sometime which is never with us. I mean, rarely with the Teflon. So this piston that way is something amazing.
I think so we have covered most of the things. We can go on with the next case.
Yeah. Why this file is not opening? This file. Ankit.
So what about facial palsy? Have you experienced any patient having palsy after the surgery? And if yes, then will you go and re-explore again?
Yes, I have for 1 or 2 times, because ours is a teamwork. So
yes,
we have faced in our team twice. ये कहाँ गई? खुल क्यों नहीं रही? Why is not opening? Restart करो. Restart this part. वो क्यों नहीं खुल रहा? Voice conservation वाला. खोल. Just a minute, Paramita. I am opening the next case file.
Yes, sir.
You see? Not accessible. Okay. वो कहाँ है? वो हार्ड डिस्क लगी हुई है ना, इसमें है ना, कहाँ है? Yes. Yeah? So your question was regarding the facial palsy. So intraoperatively, if you have happened to, poke into the facial nerve any point of time, unknowingly, like this was a, decent facial nerve at some place, and if your sharp instrument which is poked into can lead to intraneuronal hematoma or something which can compress and can give facial palsy. We have seen twice.
Okay.
So in that case, once your intraoperative course has gone good and some surgeon has done and not sure of giving any problem, yet the patient has a facial palsy, immediate post-op. Sometimes you wait for a few hours for the local anesthesia effect to disappear. But if it persists, then obviously is the reason to explore. And we have found twice this kind of a hematoma for which we decompress the nerve.
Okay.
And that decompression has, relieved the condition and improved.
Okay.
Otherwise, sometime a secondary facial palsy can come after few days or weeks after surgery, and that is mostly because of the reactivation of the virus, herpes virus. That is supposed to be because of reactivation of the virus. Why it is taking so late? So our next case is again an interesting one. It's a case of proven case of malignancy larynx involving one vocal cord, left vocal cord, and it is not involving to the anterior commissure, not extending to the anterior commissure. Cord is mobile, not extending to the arytenoid. It's a pure T1 lesion of the vocal cord, for which we have many treatment options, which I am going to discuss. What happened? Many treatment options, and what we are going to do here is we are going to treat that with a laser as a cordectomy. And this surgery, which I am going to discuss here, the principle behind the voice conservation surgery, how you can remove that particular part of the larynx, yet without giving any functional deficit, yet without compromising with the cure rates. That is the topic of discussion.
Okay, sir.
इसमें क्यों नहीं आया? Just Paramita, just a minute. I am restarting the computer.
Yes, sir. No problem.
I am surprised what has gone wrong with this.
What is the cost of this piston? And from where you can get it?
This piston cost 12,000 something to me. That is something a limiting factor. But the Teflon, a good average Teflon costs 100-200 rupees.
No, we're getting it's a bit expensive, 1,000 rupees, 1,500 rupees.
Maybe, because variety of Teflon pistons are available. But here this piston costs...
But it's a wonderful piston. I have seen in many cases, and all our cases doing very well.
See, this surgery where the patient comes with a conductive hearing loss, with a lot of expectations also as compared to the CSOM surgery. And here the margin of safety is very less.
Yeah, all or none, you can.
You have at every place, a lot of problems ahead, surprises, intraoperative surprises, anatomy, so many things. Everything good, everything went up well, and you find a problem with piston is something never acceptable. So,
Here's something about the Malleus staphylococcus, because we may not get the case, but what precaution you take in that cases when you have to put piston between Malleus and foot plate?
Malleus staphylococcus, we have already discussed the indication last time and just now as well.
Because we may or may
So
not
in
get
the situation when you don't have an incus available, then what you are left with? If Malleus is available, the next best alternative is the Malleus staphylococcus with a good piston. And if the Malleus is not available, then you may have to do a direct, staphylococcus with a tympanic membrane using TURP or something by means of sandwiching some cartilage or something in between. Yes, yes, yes. Now opening. What is that hard disk? What happened to it? कहाँ उसमें वो? Why it didn't come in the hard disk? Just bear with me. It is opening.
Yes, sir.
Yeah,
So
we
this
can.
webinar is special as we have today for the first time larynx cases. We'll be watching the larynx live surgical demonstration.
So larynx is a very interesting, the
Yes,
larynx
sir.
in itself is a complete science, and out of all head neck cancers, laryngeal cancers are very common. More fascinating because of the anatomy of the larynx.
Yes.
Larynx is not like other structures, embryologically, anatomically, it is a compartmentalized structure. There are various compartments in the larynx. We all know supraglottic, glottic, subglottic. They are not, divided by means of convenience only.
Yes.
Anatomically and embryologically, these are three distinct compartments. They have a distinct cancers arising from every different compartment as a different, pathway of spread, different prognosis, different treatment. Everything is different. And the concept of voice conservation surgery has come up only after understanding this pathological compartment, the pathology of the larynx, anatomy of the larynx, and this compartmentalization.
Yes, sir.
So like larynx has several compartments which are embryologically distinct. Every compartment is limited or separated from the other compartment by certain ligaments and membranes and spaces. So for a cancer arising from particular subsite, limited by various compartments or membranes or spaces from the other subsites, is an advantage, because the cancer arising from that subsite is going to remain limited to some extent by those barriers. Those ligaments and membranes are acting as a barrier to some extent. And if you found somebody having that cancer limited to certain compartment, you can remove that compartment before the cancer is spread to the other compartments, without giving much morbidity to the patient, yet preserving the function of the larynx. So larynx serves the function of phonation, deglutition, airway, and as well as a sphinctering function of the larynx,
Yes, sir. Yes.
What is your view on that age-old question that early glottic cancer surgery versus radiotherapy? What is your take?
Yes, that is what I was opening this presentation to explain you in the simplest way. We have many treatment options. Radiotherapy, surgery, microscopic surgery, open surgery, there are so many options, Particularly in the early cancers, the cure rates are almost same. When we have two modalities, three modalities, each having same cure rates, what other factors you need to take into consideration than function? I have the same outcome with the radiotherapy, same outcome with the surgery, with the laser or open, whatever, if laser is not available. The other factors I will take into consideration is the function like voice, the suitability, availability of the treatment. All those factors are then become more important, And if you see overall, what is not opening, I am surprised. Zero, slow. Just a minute.
How reliable is radiology in these cases? Or would you go for endoscopy? Do you prefer endoscopic examination more or radiology?
Radiology.
Yeah.
Radiology is very important. Radiology is very important in these cases. I have a MRI of this patient which I am going to share with you. Now it is opening. So slow. Yes, connect this. Connect the laptop, please.
So many files
Yeah.
on desktop.
But sir, I think in glottic cancer, CO2 laser is the gold standard. I think there is no substitute of CO2 laser for
See,
in
you
glottic
have to
cancer.
take so many factors into consideration. Why I am doing laser for this patient, I'll tell you the reason. Radiotherapy has almost same cure rates as compared to laser. Overall long-term voice outcome, if you see, is equal, but radiotherapy is marginally better. Now, if you see the treatment overall, for this laser, patient has to get admitted for a day. It's a daycare procedure. You don't need tracheostomy, you don't need anything. Next day you can go home. You don't have to come back like radiotherapy for weeks together. You know?
Yes, sir. Yes.
So that is the advantage. So for patients who cannot come for long distances, from long distances for this thing treatment again and again, this is the ideal answer. Number one. If somebody wants answer in one day with the same cure rates, with accepting a minimal marginally final lower quality voice, minimal marginally, and that too depends upon yes, connect, yes. Are you getting the slide now?
Yeah, getting.
Yes, sir. Yes.
I'll come to that point again. So what I want to show, because of the advancement in the technology, the difference what we have observed over the last few decades. Earlier, like we are discussing, for early laryngeal cancer, radiotherapy used to be the sole treatment. But now with the advancement in the laser, with this what I am going to show today, the radiotherapy and laser, we have now two treatment options and we have to choose out of them according to the stage of the disease and according to the other factors. You know, for moderately advanced lesions, earlier there was no voice conservation surgery, either do a total laryngectomy or solely radiotherapy. But now, with the advancement in the surgical sciences, with the development of new procedures, partial laryngectomy, laser, even I have been doing laser for even moderately advanced lesions with the same rates, 2, 3, even selected T3 lesions. And with the organ preservation protocol, with advancement in the medical, oncology science, with a lot of organ preservation protocols with good cure rates, which preserve the larynx, the moderately advanced lesions mostly are taken up by the CT-RT protocols. For more advanced lesions, earlier, the total laryngectomy with radiotherapy was the only answer. But now, there are so many other procedures, more advanced voice conservation procedures which have come in, and by means of which you can avoid total laryngectomy in certain chunk of people. Total laryngectomy means sacrificing the larynx completely, which is something nobody wants. What is the problem? Yes. So now we have options like near total laryngectomy, supracricoid laryngectomy, before taking a final call of total laryngectomy in most advanced cancers. So this is how the changing trends are. Near total will keep a case in coming time. For larynx, we have started today with the basic one T1 lesion. We'll have more and more T3, T4 and more advanced cancers, involving the surroundings. So near total laryngectomy is one which falls midway between voice conservation surgery and total laryngectomy. In voice conservation surgery, we conserve the voice for the patient, at the same time avoid a permanent tracheostomy, which is a inevitable something in the total laryngectomy. Near total is something in between, where we conserve the voice, but with a permanent tracheostomy, because we create a shunt. We'll come to it later. So this is how the changing trends are, and how it is possible. There is something wrong with this. आगे क्यों नहीं जा रहा? अंकित, इसको निकालो, हार्ड डिस्क में ले. Yes. How it is possible? Because of understanding of this better anatomy and compartmentalization of the larynx into different subsites. So that in voice conservation surgery, as I told you, there are certain compartments in the larynx which are bound by certain membranes and ligaments, and you can remove that particular compartment involved if patient has early cancer involving some compartment, preserving rest of the function of the larynx. Now, if that compartments are breached, the cancer which is arisen from certain compartment and has grown advanced to breach the compartment, it involves certain potential spaces in the larynx. What are those potential spaces? These three. These are the three potential spaces which serves as a natural compartments for the cancer to spread. Rhynchus space just below the vocal cord, just below the epithelium, paraglottic space on either side of the vocal cord, and the pre-epiglottic space anterior to the vocal cord. And through these compartments, the larynx cancer can spread to the various compartments of the larynx and become advanced. This is the normal pattern of spread of laryngeal cancer. Once they spread to go advanced. So this is like pre-epiglottic space. This is epiglottis, just anterior to the epiglottis, this space. This is the hyoid bone, thyroid cartilage, thyroid membrane, and just behind is the pre-epiglottic space. This is epiglottis, and how the cancer can spread from inside of the cancer to the outside. So these are potential spaces. Just to throw a light on this, what exactly they are, because it is important to understand these spaces to understand the concept of voice conservation surgery. So like these are vocal cords, and either side are the paraglottic spaces between the mucosa of the vocal cord and the thyroid cartilage. And this paraglottic space communicates with the pre-epiglottic space above and through the cricothyroid space outside the larynx as well. This is how the cancer spreading to the paraglottic space can spread to the various other compartments of the larynx and can become advanced. So in advanced cancer, it becomes difficult to conserve the larynx because of this reason. And that we need to know by means of imaging beforehand. And then these cancers of the vocal cord particularly, they have a tendency, it has been very well known now, to spread horizontally. Cancer arising from one vocal cord, it spreads horizontally from anterior part to posterior or posterior to anterior, whatever. And in the later stages, it can go up and down, mostly down towards the subglottic and up towards the supraglottic. That is how they spread, and once the paraglottic space is involved, this can all lead to how the advanced cancer presents with the vocal cords fixation. It can involve easily the subglottis, it can easily involve the cartilage or the extralaryngeal spread to the cricothyroid space. So that is how once the paraglottic space is invaded, all these things happens to occur. So in voice conservation surgery, what we are aiming, we are maintaining the basic function of the larynx by means of preserving the speech and swallowing with preservation of the sphincteric function of the larynx with removal of the complete disease. If it is possible, then only we will go with the voice conservation procedure. That aim should be fulfilled. Now, like I mentioned in the cochlear implantation, here, to ensure that the voice conservation surgery is feasible in that particular patient, a basic functioning unit should be intact. What is that? Two things. One is the cricoid cartilage. We all know, out of all cartilages in the larynx, cricoid is the only cartilage which is a complete ring on which the entire larynx rests. Cricoid is the rostrum on which the entire larynx rests. If the cricoid is required to be resected in any cancer, if the cancer has involved the cricoid cartilage or very close to the cricoid, which necessitates the resection of the cricoid, no voice conservation surgery is possible. As simple as that. Similarly, the second part of the basic functioning unit is a vibrating, functioning, innervated arytenoid with some part of the vocal cord. This should be there to produce voice at the same time to serve as a sphincteric function of the larynx. If both arytenoid need to be resected, if the cancer is involving such that both arytenoid need to be resected, that patient is never a good candidate for voice conservation surgery. As simple as that. Like for example, if any of the vocal cord tumor has gone down to the subglottis anteriorly the cricoid is 10 millimeter far down. Any cancer going 10 millimeter or beyond would necessitate the resection of cricoid. No voice conservation surgery is possible. Got my point? Posteriorly, the cricoid lamina is high up. Any cancer going more than 5 millimeter down, you need to resect the cricoid as the margin, and then you cannot preserve the larynx. I hope it is clear.
Yes, sir.
Similarly, in the arytenoids, if you have an interarytenoid region necessitating the resection of both arytenoids, forget about voice conservation surgery. So in voice conservation surgery, to be possible, you need to have a cricoid arch intact, a vibrating intact arytenoid with some part of the vocal cord, and innervation. The arytenoid should be innervated by means of a recurrent laryngeal nerve, at least on one side, for the voice conservation surgery to be possible. That is the basic functioning unit. And sometimes what happens? You have assessed by means of laryngoscopy, you have assessed the surface, now the third dimension of the tumor. Even if you have done imaging, which may not have elucidated the tumor properly, and once you open up the case, you find the disease is extending much beyond. And that is rendering that voice conservation surgery impossible. You may have to resort to a more radical procedure. For that, for any patient you are taking up for voice conservation surgery, you should have a written consent for a pregnancy with the radiation, all you can avoid. Number two, when you do resect with the laser, I tell you in other words, the overall organ preservation rate is highest with the laser. This is very, very important thing to be taken into consideration. What do I mean out of it? with radiation therapy, if it fails in long run, the recurrence is not easily picked up with the hidden under the radiation edema, and many a times these patients have to be salvaged with a total laryngectomy, and you lose the possibility of organ preservation. That is the reality. Once you have subjected the patient to the radiation, and if it happens to recur, most of the time these patients are salvaged with a total laryngectomy. In case of laser, even if the lesion recurs, you can use the laser again. Number one, you maintain the same prerequisite for the laser again. If not laser, if you don't have a laser, you can do a partial conservating surgery like vertical, partial or frontolateral, whatever is feasible in that particular recurrence. Or any sort of radiation therapy if needed in the post-op, that again the option remains open before going to the final total laryngectomy. So the overall organ preservation, final organ preservation rates are higher with the CO2 laser as compared to radiation, and that is the reason why we are little biased towards using the laser, except in the people who are professional voice users. That is the caveat, I would say, where the radiation has little superior overall rates. In laser, the final voice outcome, if you do a sort of, type 1 or 2 cordectomy, believe me, if you do a type 1 or 2 cordectomy, the voice quality is as good as laser, as good as radiation. If you do a more extended cordectomy in a more deeper cancer, the voice quality will be definitely inferior to the radiotherapy. Like for example, I tell you, I give you what I am trying to say. There is a classification by the European Laryngological Society. You can see this classification. The type of cordectomies which are defined as, and this is important to understand. In type 1, you just remove the epithelium, staying lateral to the, just above the linkage space. Type 2, when you remove the deeper, lamina propria. Lamina propria has 3 layers, the superficial, intermediate and deeper. Intermediate and deeper constitute the vocal ligament. So if you include your resection where you include the epithelium with all the layers of lamina propria, where the cancer warrants, that is subligamental. If you don't touch the underlying muscle and remove all this, still the overall voice quality is amazing. But as you go deeper with the removal of the muscle or removal of the total cord or extended to remove the anterior commissure, arytenoid, anything, supraglottic, subglottic, whatever, then the voice quality will be inferior. So the bottom line is, looking at all the factor into consideration, for this particular patient or majority of the T1A good lesions, limited lesions, the laser has an edge over the radiation therapy. Not in terms of cure rates are equal, but overall final quality of life is much better with the laser as compared to radiation. This is what the evidence says. And overall organ preservation rate are much more with the laser as compared to radiation.
So also we can give radiotherapy anytime after surgery, but we cannot do surgery anytime after radiotherapy.
I can use the same laser in recurrence if the recurrence happens to occur, but not radiation again.
Yes.
That is the issue. In radiation failure, most of the time you have to ultimately end up sacrificing the larynx.
Yes, sir. Yes.
That is something we need to know. So before our case is ready, I can take questions in case you want. Sir, any suggestions at this point of time, or your opinion, what you do in your practice?
Most of the things have been covered very nicely. For for limited cord lesions, we go for laser excisions. Otherwise, go for surgery in cases of where there is involvement of the cartilage. And in between, we go for radiotherapy, the organ conservation protocol. Because our institute, the protocol is decided by the tumor board, So individualized decisions are not allowed, and there are certain guidelines which have been laid down. We have to strictly follow that. But definitely for T1 lesions, radiotherapy versus laser is the best option. And,
yes, sir.
That is. Can you hear me?
Yeah. For the centers where laser is not available.
Yeah.
Yes, sir.
and still the surgery is your chosen treatment, you can do an open, simple laryngofissure and cordectomy.
Laryngofissure and cordectomy.
With the same cure rates, but yes, obviously the voice quality will be inferior to the laser.
Yeah.
So that is the third option.
Sir, cobblator, any role of cobblator in cordectomy?
Not really. We avoid using because of the margins. Because you cannot ascertain the margins as precisely as you ascertain with the laser. And this laser which I use is amazing. This again the luminous one, where you can see my beam size is a fraction of millimeter. And you can easily ascertain the margins. You was always in larynx the margin can be an issue. Though as compared to the other sites, I'm washing up. So in meantime we can discuss. As compared to the other sites, the larynx margins, as far as the margins are concerned, for vocal cords, even a 2 millimeter margin is considered adequate. But that 2 millimeter should be at least 2 millimeter. And with the laser, that kind of, the laser burn it gives, sometimes it is difficult to ascertain. And then like Udbhav mentioned in the beginning about the narrowband imaging can be of help. Because narrowband can give you the superficial idea of the lesion, not the deeper one. And you can at least include that surrounding, which may not be visible obviously with your microscopic picture. So that enhance your margin control.
And you will send this for frozen section during the surgery, the margin?
If you are in doubt, you can sometimes know what happens. You are doing some extended laser procedure, like you are involved anterior commissure, and you are not sure about the, your exposure is not very good, not sure about the margins. You can certainly take the help, and then keep your specimen particularly oriented, because otherwise pathologists will not be in position to give you anything.
Yes, sir, yes.
So that is important. And see, this science of laser surgery is, extensively, propagated by Steiner and his team. They have done thousands such procedures, and most, extensive one. Even Steiner has done for the T4 lesions.
Yes.
Okay.
The issue with the laser radiotherapy is that we don't have very good machines at every center.
Pardon?
The problem with the radiotherapy is that we don't have very good machines at every center. So sometimes surgery is, I think, better option. That is one more reason.
Yes. Now I will give you the inside picture. Yes. Yes. ऊंचा करो टेबल. Table up. हाथ लगा. Table up. Table up. Microscope. Connect camera. Are you getting the microscopic picture?
Yes. Now.
Yes, sir. Now.
More up.
Sir, is age is a factor? If you have an elderly patient above 60, 70 years, can we tell him to go for radiotherapy instead of surgery, maybe? Or you will prefer surgery in early cancers in them?
According to the age, you mean to ask?
Yes, sir. Like in elderly people, like 70, 75 years, what will be your choice?
Yeah. 75 years, see, again the same factors need to be taken into consideration. For surgery, fitness is a big factor.
Yes, sir. Yes.
For elderly people, and their choice. If the patient is fit and wants a good quality of life, laser is much better, no doubt about it.
Yes, sir.
See, are you able to see the lesion on the left cord?
Yeah, very clear.
Very clear.
Now what I am trying to show you.
What was old instrument in this surgery? For this surgery?
Old instrument cannot match the laser, sir.
That is. But
Cannot match. I'll tell you. Laga हाथ लगा. The laser has a significant advantage over it. Now see, my anterior margin of lesion. Can you see?
Yes, sir. We can see.
Very clear.
Very clear.
all around I'll take at least, see, I'm using the, first of all, the laser tube. Hello?
Yes.
I am using the laser tube. Laser tube is a flexo-metallic tube, and it has two, cups. It has two cups, and the outer cup is a saline and inner cup is a methylene blue. Am I correct? Oi, बाहर वाले में क्या डाला है? अनुपम?
Saline डाल, बाहर वाले में saline होता है, means outer one.
So that it warns you, once it ruptures, it warns you.
Could you centralize the picture, please?
Yes, I will. Anupam?
For the audience, please also tell what to do in case of a laser fire if we encounter.
Yeah, first of all, prevention. First of all, prevention. Use the laser tube. What is the, what have you put in the outer cup?
Diameter 5.
White nitrous.
Cup में क्या डाला है?
Cup में methylene blue.
Outer.
Outer.
Outer one is methylene blue, the inner one is saline.
Okay.
Hello?
Yes,
Yeah,
okay.
Is the picture good now?
Yeah.
Yes, clear, very clear.
Can you see the anterior margin very well?
Very
Yes,
well.
yes.
Very well.
See now, my laser now. And here I am using the AccuPulse.
Yes.
This laser has the ability to cut very precise, though it is not very, a good.
The voice is
The
getting.
laser uses the color. They are good at hemostasis. Here we have other maneuvers to do in case the hemostasis is required. I hope the picture is in center. Dekhna.
Picture is okay.
Voice is breaking in between.
Yeah, voice is getting break in between.
Voice is breaking.
Yeah.
Okay, let me know if it happens again. See this anterior margin?
Yeah.
Yes.
See my laser beam, can you?
Yeah.
We can see.
ओए करना उसको कंटिन्यूस इधर सेक्शन उधर Can you see how it cuts?
Yeah.
Very nice. So using in the pulse mode, I think.
It is continuous.
Continuous.
Say this.
It's just in the submucosal plane
Yes.
of the muscle, right?
Yes. I went a little anterior to my lesion.
Yeah.
That's how I am marking my lesion. See my, the laser beam I can rotate according to the need.
Yeah.
I can change the direction as well.
Vertical unit. Now it's okay.
And see, you can see the subtle tissue.
Yeah. Yes, sir.
Absolutely. See, छोटा. See,
What are chances of post-op test?
oozing, and we use an insulated section. Could you see?
Yeah.
Yes.
Yes.
What are chances of post-op aspiration, etc. in these cases?
Not really. In single one side, cordectomy, we have a complete system there to stop the aspiration. This is, a single cordectomy cannot give aspiration. Aspiration is the failure of the sphincteric system. And for that we have a section.
So you are going for type 3 transmuscular.
Yes. This is to the muscle now. See this?
Yeah.
I am taking margin.
Yeah. Yes.
You cannot take a chance. See, even if with this type 3, you get, reasonably good voice as the pseudochord forms. Not as good as type 2, but still very good voice as the pseudochord forms.
Yeah.
See the lower margin?
Yeah.
Absolutely clear?
Yeah.
Yes.
Because we had assessed during the primary, biopsy time. See, primary biopsy under general anesthesia of these patients is, I would say, essential. Even if you can take the biopsy under local, hello, I would suggest to take biopsy under GA. See the reason behind? You get to know the feasibility, access, whether the larynx is favorable or not. During the biopsy time, you can assess all the dimension with the endoscope also that time. Otherwise, you may have to cut a sorry figure when you come for final surgery. See this? I have a good margin all around.
Yes, sir.
Dr. Satish,
yes.
Do you have any tricks to suggest for difficult larynx like interior larynx, and you are not able to access both the commissioners because of
what we are doing, sir, yes, sir, that is a very difficult situation. Even we get some time, and what we are doing for that, we use endoscope sometime, we have anterior commission laryngoscope, niche karo table, and then we have malleable scopes,
Okay, malleable scopes.
Malleable scopes, malleable, niche. See now.
Laser would be difficult over there because you cannot.
We have a full set of malleable instruments that are wonderful from Carl stores, and those are for difficult situation. See this now, I have come posteriorly.
Yes, sir. Yes.
Forceps. My anterior limit I have already taken down. See this?
Yes.
Hope the picture is good.
Very good.
See, sometimes you have to, remove the false cord for the visualization. False cord is not our goal. Removal of the false cord is not our goal. This is for visualization.
Right, sir. Yes.
See this?
Yes.
The only reason to remove the false cord is for the access, section. Section there. So I am removing the false cord to see my lesion, underlying lesion. Okay? See, this will give me lateral access to the lesion.
Yeah, hidden access. Because
So what is your post-op protocol after this cordectomy surgery, like voice rest and those things?
Nothing, boss. This will heal by, secondary intention
in 3 weeks, I think.
in few weeks, and a good pseudocord forms, and you literally see the normal muscle.
Yes.
This is possible because I removed the part of the false cord for the access. That's a very important maneuver.
That's a good point, actually. Otherwise,
yes. Otherwise, sometimes it doesn't give you access. See, every time you need to change position.
Yes, sir.
Position of the microscope, position of the laser.
So, visualization of the normal tissue is the key.
See how the visualization is.
Yes, sir. Very nice.
Under high magnification. Our laser is mostly used either in the stapes or the larynx, except for some other indications, but mostly the major indication lies in these two.
Cobbleter means we could have used for those who don't have this quality laser. Cobbleter is one more option.
See, see my beam, so precise in margins.
That is ultimate.
Cobbleter is a good tool, but you have to understand the value of every tool at every particular place.
Sir, any experience with KTP or laser in larynx?
No, boss. For here, this is the ideal thing. See, What a tool it is. It's cutting like butter.
Yeah, sir. Very nice. Very
Under
nice.
good, see my muscle layer all around. See everywhere the margins.
And so very little charring and very little bleeding.
Yes. See, as I'm going behind, I will keep changing my focus, the microscope, laryngoscope, my stool which I am operating through a pedal myself. Everything is important in laryngeal surgery.
Yes. You have to control everything.
Suction. Every time you have to change the focus of the laser at every corner. See, this is how I'm reaching behind the lesion.
Yeah.
See, that is normal muscle. And behind is my laser tube, you can see.
Yes, sir. Very clear.
So no fear of laser fire with the laser tube in place. See, this is not a small lesion.
Huge, yes. What will be a post-op protocol to assess the lesion or any radiology or endoscopy examination? What?
See this vessel? Immediately, see this?
Yes.
See this? Immediately you have to use the insulated section. You see that?
Yeah.
Cauterize the vessel.
Yes. Everything should be ready. Little more behind to see the posterior margin because the tube is in place. Sometimes makes life difficult,
Yes, sir.
You have to elevate it section. See the tumor?
Yeah.
And see the posterior margin so clear. Suction.
So it is a metallic tube and two bulbs. Upper bulb is filled with the methyl blue, lower one with the saline. That is it.
Yes. Outer one is, methylene blue.
Yeah, methylene blue.
See now behind my limit of the tumor. See this?
Yes, sir.
Suction. See, this is how you ascertain your margin.
No bleeding at all.
No. Yeah, this laser is not as hemostatic as other lasers, but still it is good.
Yeah, there is no such no bleeding.
The best beauty is so precise, so efficient. I have done even many a time T3 lesions, removing the thyroid cartilage through this laser only. It cuts the cartilage like butter if it is not ossified. Ossified, you have to, increase your intensity. You have to increase your intensity. You can cut through that. You can cut through the bone also.
Yeah.
In high power, I can cut even the femur bone with this,
So the adequacy of the margin, how you assess?
Every point of time under high magnification,
Yeah.
See this everywhere.
Will you send something for frozen as well? No.
No, not required. I told you in case you have doubts, you can. Now the important thing is everywhere I am, keeping an orientation because we have to label it. Which side is what? छोटा वाला दे, छोटा वाला दे, थोड़ा पानी डाल, सेक्शन कर. Give me a wash. Give me a wash. रुक जा. एक ऊज़र है. Yes, now. Yes. See, there was a oozer.
Yeah. Usually we get it.
Touch. Yes. See this? Absolutely dry. Hope the picture is good.
Ultimate, very good.
See, this is a huge lesion which I am trying to remove one piece. Sometimes you have to divide it to remove piecemeal for a deeper margin. Doesn't make any difference as long as your final margin is. Yeah, where is the beam? Beam किधर है? Yes, देखना beam देखना था.
Sometimes it becomes difficult to find the beam in right.
Yeah. You have to orient. Now see, sometimes your hand, your instrument may come in the way.
You're doing 3-hand technique. One more is there.
Pardon?
The 3 hands are working right now. 3 or 4. Someone is doing suction. Someone is holding it. You're holding it, I think.
हटा. See the lower margin?
Yes.
See, absolutely supple. Away from the tumor. See this?
Yes.
Very sir.
And finally, we'll turn around. See, I was doing under high magnification.
Yeah.
So that I can show you a better picture. Now see through the muscle. This is type 3 transmuscular cordectomy. See this?
Yes, sir.
Weber, you must have seen Nupur's place.
Yes, sir. So almost like very common cases, service cordectomy cases.
Yeah, she's too good. See this? This is classical. I am showing transmuscular.
Yes, sir. Very nicely done.
What about the contact laser, like the diode laser at this place?
Contact laser. ऊंचा करना.
More trauma, more burning.
These are not so precise, boss.
Yes.
They are more like cautery.
Yes.
See this?
Wonderful.
Absolutely clear. And now we'll orient it.
Second, one piece we have taken it out full. Lovely.
Section. See, one piece.
Very nice, sir, and very smooth margins.
Section. Go forceps. And there is no bleeding. Number one. We have under vision. This is the muscle, underlying muscle.
Yeah.
Very nice, sir. It's a very beautiful picture.
And it is all supple, and this will, result in a pseudocord very soon in no time. Give a good wash.
Excellent.
See, this is wash.
Complete removal.
And sir, the best part is so little charring after whole this removal.
Yes. This is the beauty of this laser.
And so we can see the supraglottic epithelium intact. We can see the
subglottic epithelium.
Yes, sir.
Yeah, subglottis. You can see this.
Yeah, very
subglottis under vision, supraglottis under vision. I removed a part of the false cord for the visualization.
Yes, sir.
And that is what the cordectomy is.
That was the best step. Otherwise, we struggle for this claim.
Yes. So one piece. This patient will be discharged tomorrow morning. In 4 weeks' time, you see his voice. In few weeks, his voice will come close to normal. Even after this type 3 cordectomy. Type 2 would have been absolutely normal, I would say. Type 3 definitely will be some scarring, but still the way pseudocord forms. Wash karna 2 minute देख के भेजना ना, हटा ले. इधर लिया. So this is type 3 chordectomy, and this is the final answer, rather than subjecting this patient for 6 weeks for radiation. Radiation is so mutilating. Radiation is not something free of side effects.
Yes, sir. Yes.
6 weeks, it makes sometimes the upcoming recurrence identification so difficult sometimes because of the ongoing edema. And then salvaging the radiation failure is very, very difficult.
And so with good speech therapy, he will definitely will have a very good speech.
Yes, yes. So this will be as good as normal, you know.
Satish,
Yes.
Satish,
Yes, sir. Yes, yes.
Satish, supposing intra-op you find this going on to the anterior commissure tendon, then how would it be changed, your line of administration?
Yes. Anti-commissure, if it is extending, I would have to, you know, first of all, ensure my exposure to the anterior commissure. I may use an anterior commissure laryngoscope. I may use, you know, angled laryngoscope. I may use angled scope, and first I will take a rehearsal during biopsy whether it is feasible to do with a laser or not. In feasible situations, it would be a type 6 chordectomy. I mentioned there. Eva, connect karna?
Yeah.
See this. On the slide, I mentioned the type 6 laryngectomy. This chordectomy is primarily for the lesions involving or arising from the anterior commissure. Because these lesions arising from the anterior commissure, they have a propensity to give early invasion into the thyroid cartilage. They invade early into the thyroid cartilage at where the Broglie tendon is attached to the cartilage, because that area inner perichondrium is absent. They have a tendency to go supraglottic subperichondrial through where the petiole of the epiglottis is attached. They have a tendency to go subglottis. The hidden component is very high. So first of all, assessment is very important, assessment of the third dimension. And for that, a good CT scan is must. Good CT scan is must to assess the third dimension of, you know, the involvement. I tell you, see what happens, the mistake. Can you see the scan?
Yeah.
What is that? This patient had an absolute normal bilateral mobile cords. What stage tumor is this? Normal mobile vocal cords.
Going beyond the thyroid.
This is through and through at the anterior commissure through the cartilage, and it is T4. It is T4 lesion which appears like T1. Endoscopically, you see a lesion with a vocal cord mobility. What do you call it as a T1? Which in reality is a T4 lesion, the way it upstages, because it has gone through the anterior commissure so easily into the cartilage. That's how this hidden component need to be assessed. So in anterior commissure, you have to be careful, number one. In case you have finally assessed through the scan, three-dimensionally, that it is neither going to the supraglottis nor going to the subglottis, beyond your visualization, the patient on laryngoscopy is feasible with the exposure, then you have to do this type 6 chordectomy. Type 6 chordectomy is what? Type 6 chordectomy.
Anterior commissure.
Yes. Complete anterior commissure, removal of the petiole of the epiglottis, part of the subglottis, and both anterior parts of the vocal cord to give a complete clearance. So you have to have a rehearsal of this patient under GA, first for the feasibility. Second, third dimensional assessment by means of imaging, and then you can think of doing it. Otherwise, these tumors require a more radical procedures. Earlier, people would recommend a frontal laryngectomy, frontolateral laryngectomy, removing the part of the, you know, thyroid cartilage. But to me, for such lesions, the best conservation procedure you can think of is a supracricoid laryngectomy with supracricoid laryngectomy with cricohyalodopexy or CHP. If the epiglottis is involved, then cricohyalodopexy directly from the cricoid to the thyroid. That includes bilateral complete paraglottic space and the preepiglottic space removed, along with the complete lamina of the thyroid cartilage bilaterally. That is a major yet voice conservation procedure. that is supracricoid laryngectomy with CHP. It has its own indications, limitations, because the chances of aspiration are high, so you can't do in elderly people with poor pulmonary reserve, so many other things. We'll discuss in our upcoming webinars when we keep the advanced cases for voice conservation surgery. So that is super.
Sorry, sir, go ahead.
Yes, sir.
Would you not prefer MR over CT scan in assessment?
MRI. Even this patient, I tell you, this patient's MRI, why I was so sure that the anterior commissure was free and the cartilage was free, because you don't know the third dimension. On endoscopy, what you see on surface is not everything. That is just tip of the iceberg sometimes. That is revealed on MRI. Let me show you. You have to take into consideration some combination of sequences. See this. This is T2 weighted image. Can you see this vocal cord?
Yeah.
Yes, sir. Yes, clear.
Yes.
Left cord, what we resected. This is left side. Can you see as compared to the right one?
Yeah, thick perimeters.
This is the cord which is involved. Now, where is the cartilage? See this hyper intense cartilage. Patchy hyper intense cartilage, which is, how would I say the cartilage is involved? Simple 100% sign CT scan may not pick up in early invasion of the cartilage. When you find this intensity of the lesion of the vocal cord in continuity involving the cartilage area, that is 100% sign. Got my point? The same intensity involving the vocal cord had been extending to the cartilage region, the cartilage is involved. As simple as that. Same intensity involving going to the anterior commissure, same intensity of the lesion, that means the cartilage is involved. This is the way you can find the cartilage involvement. You can take the help of diffusion, you can take the help of contrast. This is contrast sequence. See this sequence. See, I am just first showing the cartilage. See the cartilage dark?
Yes.
Yes, sir. Yes.
See the cartilage. This dark cartilage. And see the vocal cord. This is different intensity.
Yes.
Involvement of the cartilage you can easily ascertain by only one mean. Wherever the lesion is, if the same intensity is extending to the cartilage, that means involved. If it is hyper as compared to the lesion, that means it is not involved. Simplest way.
If it is involved, then still you go for a laser excision.
Yes, in certain favorable conditions, I tell you, for like T3 lesion, you have a fixed vocal cord.
Yeah.
It's a lateralized lesion with involvement of the paraglottic space.
Yes.
You know, no subglottic extension like I mentioned the parameter earlier to pass through the voice conservation surgery. No supraglottic extension in the well lateralized lesion. I will remove along with the cartilage with a paraglottic space in between and block without issue.
Endoscopically.
Yes, microscopically, the same way that I removed now. So that is possible. So in selected cases, not all cases, if you have a lesion going supraglottis, involving supraglottic part, involving subglottic, close proximity to the, the cricoid cartilage, or involve the preepiglottic space, breach the conus elasticus to go out of the larynx through the cricothyroid membrane, those hidden extension, if you are not sure about, better not to do that. And in case those are involved, yet it is lateralized lesion, I would do a near total. Near total is as radical as total. As radical as total. Even if the lesion is going out of the larynx, even if the lymph node metastasis, will do like same totalectomy, will deal with them. Remove thyroid if the thyroid, everything same. Only thing is one side of the vocal cord and the retinoid innervated, if left intact, with part of the cricoid, even in the cricoid cartilage we remove, and we make a tube connecting into the trachea in place of the cricoid cartilage, and that is amazing procedure. You don't need a voice prosthesis. You make you develop or you reconstruct the neoglottis, but yes, a permanent tracheostome. And patient preserve the voice, retains the voice with the own neoglottis, sort of a neoglottis, because when the patient closes the tracheostome, air is directed through that tube into the pharynx and that produces voice. So lung-powered voice is produced with the own tissue without the need of prosthesis with a permanent tracheostome is near total laryngectomy. Was initially described by Pearson, yes, known as Pearson laryngectomy. Any questions?
So when you recommend, suppose it is involving antecommissure and going out, then you will recommend neck dissection.
वो पैड पड़ा था ना, उस पे लिखा था मैंने. Pardon, boss? Yes. Yeah.
Suppose it is going out of antecommissure involving cartilage, then when you will recommend a neck dissection in this case?
Neck dissection in glottis, purely glottic lesion is, we never recommend as an elective procedure. It is unlikely to have metastasis. Yes, supraglottic is different issue. And here, if it is a lesion is T4, then obviously you take into at least into sampling level 2, 3, 4 with the paratic, at least on the same side.
Yes.
Madhusudan sir from Nandyal is saying no words to describe. Wonderful feast to watch this beautiful surgery.
Thank you, Madhu.
And sir, Dr. Vijay Chaudiya from Indore, he is also saying excellent skills, no words to describe.
My regards to both of them. They are very senior people and their blessings are always important.
Good evening, sir. This is Sonali Lohar from Thane, voice therapist.
Pardon?
Sonali Lohar from Thane, voice therapist, sir.
Yes. Yes, madam.
Excellent surgery, sir. Got so much to learn. Sir, post-cordectomy type 3, which we just saw, what would be the ideal time according to you for starting voice therapy?
After 6 weeks.
6 weeks.
Such patients, for them the voice therapy has not a primary role. They develop pseudocord very well. And see, this is a radical treatment for them. This is not something which is going to be followed by radiotherapy. So whatever cord forms is going to be final. Sometime, because I have removed the muscle part, sometime because the volume is gone, they need a voice therapy for better approximation. Many a times, and obviously with the supplemented voice therapy, there are a lot of compensation mechanism work. 5 types of compensation mechanism happen to occur. The compensation from cord to cord, compensation from cord to false cord, compensation from false cord to false cord, like that, and voice therapy, potentiates that. So those patients who do not develop good voice ultimately do not achieve. Voice therapy definitely helps them to achieve this compensation. That is the rule. But we have to wait at least 6 weeks for this pseudocord to come in action.
Sir, Dr. Fukam from Guwahati is asking, if you have a positive margin, will you go for surgery again or post-op radiotherapy?
Here in larynx, don't give too much importance to the margin. First of all, I tell you. Number one, if you have a slightest doubt, see, I was doing a very high magnification. If you have and with the imaging backup, I know where the lesion is going to. First of all, if you have a slightest doubt, you can get a frozen section done, number one. And you can take a call immediately to exercise more. Number two, even if you have 1 millimeter margin, just wait. This laser, particularly in the glottic lesions do not invade the lymphatics. Number two, you can see on the surface if any recurrence is there. This is not hidden. That's how the glottic lesion presents so early in the course. Why supraglottic lesions present late? Because in glottic lesion, hoarseness is the predominant symptom which comes early in the course, and majority of the glottic lesion patient, present in stage 1 or 2. Majority.
Yes.
In contrast to the supraglottic, majority present in advanced stage. So even if there is 1 millimeter margin, you don't have to terrify, wait. Because the laser itself takes a fraction of millimeter as a margin by the energy, And number two, even if there is recurrence happens to occur in close observation, you can go back again with the laser. This laser maintains all other treatment options intact. I can do the same procedure again and again with no, change in any situation like primary situation, with the same comfort.
Yes, there's no lymphatics there.
Yes, sir.
Yeah. Yeah. Yeah, very small. Yes.
Yes.
Satish, Satish, wait. Dr. Satish, wait. The sound is not there. 1 second. Dinesh, there's no sound from Dr. Satish.
It is coming. It's there.
There's YouTube, there's no sound.
Acha, okay.
No. On YouTube, not audible. Dinesh, so many queries are there. No audio. 1 second. Let me talk to Dinesh. No. On YouTube, no audio. I change the battery, I think. Now. Yeah, I think sorted out. Now it's okay. Now it's okay. Yeah. No, no, no. Hello? Yes, bilateral.
Nice, sir. Nice, sir. Very different case. Many people want to see that.
Wait, Dr. Satish, I'm on YouTube, right? Please give me that.
Wonderful, sir.
Vinny. Waiting. Not yet. They can hear my voice, but not yours. YouTube, something is wrong or at you, or I think your mic or something.
सर ओटी में एक्सटर्नल कैमरे का माइक ऑफ है शायद सर. ओटी में एक्सटर्नल कैमरे का माइक शायद ऑफ है. वो कैमरा के ऊपर माइक जो है. में एक्सटर्नल कैमरा का माइक ऑफ है शायद सर. ओटी में एक्सटर्नल कैमरा का माइक शायद ऑफ है. वो कैमरा के ऊपर माइक जो है.
On YouTube, others' voices there, but not yours. Yeah, mine and other voices are going. Everybody.
Good evening, sir.
Zoom has come. YouTube, others are there, but not yours. Yeah, mine and other voices are going. So all the listeners, we have 4-5 more cases. One is vagal paraganglioma, one is CSOM with facial palsy, next is exteriorization CSOM, and then we have parietal periauricular sinus, and hello.
What's wrong with the audio?
Maybe some technical point. We'll just be correcting it. No problem.
Hello?
सर अभी आ रहा है आवाज.
Harsh, my voice is going?
Yes sir, yes sir.
How? How are you? Okay. Okay.
Yeah, आगे sir.
Okay, so what I was trying to say about the CT scan in relation to this patient with cholesteatoma. So we need to look at certain, we have already discussed in detail last time. Certain points need to be seen thoroughly, which can be important in decision making. Number one, the pneumatization pattern. See this particular side which is involved by the disease is hyponeumatized. See my anterior border of the sigmoid sinus, pneumatization is not going beyond that. So it is hyponeumatized. Number two, what to be seen, you can reconstruct in 3 planes. See, the pneumatization is very less as compared to the normal side, normal situation. Number two, the disease part. We all know what we can see on CT scan is just the opacity. We cannot differentiate. MRI can differentiate what is cholesteatoma, what is other lesion, cholesterol granuloma or whatsoever. What all we can see is the opacity. Third thing, the most important thing I told you last time is the curvature of the tegmen. See this, that is most important. See the curvature of the tegmen. What is this level? This is the level of the semicircular canal. Let me reconstruct a better one. वो लगाना है इसकी सीढ़ी कहाँ है? Give me the other one. Let me change it. Pin. CD. Sir, I'll show you a better picture. Just a minute. Pin. Middle लाना. Just a minute. 2 लास्ट वाली सीढ़ी थी ना? 2 लास्ट में सीढ़ी आई थी ना, तुमने कॉपी करी थी. कहाँ है वो? Difficult.
When you recommend that this patient should go for exterior and interior IC.
Yeah, that's why I mentioned last time there are so many decision making factor बड़ा लाना है, need to be taken into consideration. So it's a complex decision based on so many things. मोटे लाना needle. वीरेंद्र क्यों हैरान कर रहे हो?
So what is the value of culture sensitivity in all the cases, chronic cases like cholesteatoma?
Yeah, now it is coming. Value of
culture sensitivity in your cases.
Culture sensitivity is always, you get to know if it is done properly, the bacteria involved, and that will really help you giving an proper antibiotics. So now it is coming. Now the picture will be better. Yes. Let it load completely. The CD is loading.
This is a dicom you use in all the cases, and I think this is wonderful.
Yeah. See now, what I was trying to say, you need to see a lot of things. First is pneumatization, and you can see this patient is not fully pneumatized. Number two, what all you can see on the axial finding, the status of the facial now. See the facial now the way. Horizontal facial now, which is we are concerned with. This is labyrinthine, it has to be okay. Horizontal, and now this is vertical. See vertical facial now completely protected. There is no issue with the facial now.
Yes, sir. Yes, sir.
Okay. Only at one portion in the horizontal could be dehiscent here.
Yes.
That's it. Inner ear, everything is normal. Nothing. Regarding the ossicular part, I don't see. I see the remnant of the, incus over here, or part of the stapes over here. See this. This is part of the stapes. The incus is necrosed in this patient. And see the opacity completely going in the extraordinary canal. See this?
Yes, sir.
And then the entire mastoid system. Now the lateral semicircular canal, can you see intact?
Yeah.
Yes.
This is important to see. If there is a fistula, you have to plan accordingly. Because the fistula management is equally important and that depends upon the situation. Now, the important thing in the upside down picture. See, now this picture will be better. That's what I was waiting for. See now the tegmen curvature. Can you see the level of the labyrinth?
Yes. Yes.
With all semicircular canals in place, see this? Now see in the mastoid at what level I am talking about. Behind. It is not at the middle ear level, it is at the semicircular canal level. And at this level, look at the tegmen. This is lateral, this is medial, this is tegmen. And tegmen looks flat and thinned out. Can you see?
Yes, sir. Yes.
Tegmen looks flat and thinned out. Now, if I see the tegmen, see carefully. Now at the level of the cochlea, see this?
Yes.
Now, what is the tegmen? This tegmen has certain curvatures, you know?
Yeah.
Yes,
This
sir.
is lateral, this is medial. That means when we are operating on a patient from above downwards, what we see lateral to medial, you see the lateral to medial, these curvatures. You have to keep in mind tegmen curvature. In case you are not aware of, unusual tegmen curvature can take you to a difficult position. Sometime I have seen people injuring the facial now because of, not knowing about the tegmen curvature and danger the facial now. So this is about the ossicle we have discussed. See here, this is the atic. See this?
Yes, sir.
And everything is good. Otherwise, this is the level of the atic canal wall. And see that this scutum is completely gone.
Gone.
Scutum is gone. Atic is full of disease. There are hardly any ossicles remnant. Inner ear is good. Everything is good. The facial nerve is good. Pneumatization is poor. That's why, because of the pneumatization and the patient choice, we are taking up for exteriorization.
Any comment on the jugular bulb in this case?
In this patient, the jugular bulb is not, low.
Yes, sir. Yes.
I will show you. Last time, just to remind you, I told you there are several factors need to be taken into consideration for decision making. See these.
What's the audiogram?
Audiogram is a mixed hearing loss, around 20 dB airborne, the bone conduction loss and 40 dB airborne gap. So out of these factors, the pneumatization is one of the important factors need to be taken into consideration to avoid, cavity issues. So now, this patient, as we have planned the exteriorization, the goal will be to minimize the cavity, whatever it is, to give a good meatoplasty, to excentrate all air cells thoroughly, and not to leave any raw areas in the mastoid, will line with some vascularized tissue. There are ample of vascularized tissues around the ear, and let's see what all we can give best to this patient.
Yes, sir.
Any question before we start? Yes, sir.
Looking at the scan findings in a contracted mastoid, would you like to approach inside out or still prefer to go from outside?
See, once you have to bring it down, it is up to you how you are used to. It's not finally, it is not finally going to make any difference. Because whatever bone work is required is going to be same finally. You go from any side, it's not going to matter anyway.
Sir, Dr. In Malaysia, many people are saying that they are seeing kind of fistula in horizontal semicircular canal.
In this patient? In this patient?
Yes, in the coronal cut.
Okay, let's see. I'll show both. Number one, let me first show in the axial. See this?
Yes.
Okay.
Yes,
and now I will show in the coronal as well. See, this is the vestibule.
Yes, sir.
This is superior canal. And this is lateral canal. See this lateral canal. See this thick bone.
Yes, sir. Yes, sir.
See all the way. See all the way again.
Yes, fine.
One point it is close to, but it is covered.
Yes, sir. Maybe this thing they may be saying. Yes.
Let's corroborate intraoperatively how it is. This thin bone here, and if it is really blue lining or something, it may be.
Yes, sir.
So we are all set for the case now.
In the previous case,
yes.
Any protocol means what will protocol for checkup, regular checkup? Will you go for endoscopic examination or CT or any or chemotherapy in that case?
After the cotomy?
Yeah.
Just our first visit will be after 10 days. Until then, we'll have our full histopathology report. And looking at the report, generally we call after a month or so, 3 to 4 weeks until it heals.
Or other patients are doing, those who are operated in last 40 days? Satish?
Huh? Hello?
How are other patients are doing now? Means those who have operated in last 40 days?
Oh, touch wood. All well. Touch wood. Do I call the acoustic patient? He is upstairs.
Yeah. I mean, just for review for all these people regarding the follow-up and everything.
Okay. Call the acoustic patient.
ACL one and so many cases been operated.
Yeah. All discharged, all doing well. So this acoustic patient is still here. He's doing well. His normal routine, he's walking, he's having food, regular breakfast, lunch, dinner. His facial is just grade 2-3 because of, handling. And just grade 2-3 and I will show you. And that is bound to recover because it was completely intact.
Yeah, intact. Just only stress.
Yeah.
So we should put a caption of fasten your seat belt during those surgeries.
Pardon?
Sir, fasten your seat belt during those surgeries. They are so fearful surgeries that many people are like over the edge.
Are you getting the picture?
Yeah.
Yes. Very nice.
It is full of cholesteatoma.
Yeah. This is right here. Okay.
Right here.
Zoom out a little bit.
Say this completely destroyed.
Yeah.
See that? Shoulder. Okay. Knife.
Can you orient? Hello?
Yes.
Sir, can you orient?
Yes. See, this is right here. This is anterior, this is posterior. Okay? This is anterior, this is posterior, this is superior, this is inferior. Okay? And what I am going to do or doing is, see this atic completely destroyed. See this atic completely destroyed and we have planned exteriorization. I will preserve this entire, skin. That is going to be very useful at the end for the lining. See this? Whatever skin I preserve proved to be diamond. So whatever bone I am going to remove this, I will first elevate this skin and save this.
Yeah.
Circular.
Anything specific for giving the incision, sir?
Nothing. Now this area of the bone which I am going to remove is exposed, uncovered, and that much of the skin is, preserved.
Hello?
Yes.
Do you elevate this musculoparietal flap superiorly as far as is shown in this picture? Or
I didn't show you. It was already elevated.
No, but this much exposure is required for root surgery or that is it?
Pardon?
Above the temporal line, this much of bone exposure is required?
Yeah, because, it's not, it is just retracted.
Okay.
And see, this is flap we have taken.
Interiorly based flap?
Yes, as usual.
Yes,
See this huge one.
For obliteration of the...
Yeah, so this will go inside once we do, exteriorization. And for that we need to remove the tip of the mastoid as well. So having preserved this, flap, cotton ball there, I can make it free as well. And hardly any difference. Sometimes I make it free. Now you have a full area exposed for drilling.
Yes, sir.
Quick. Udhar. Yeah. Is the picture good?
Very good, sir. Yes. Crystal clear.
Yeah.
So again, this fast-cutting conical bug of yours.
Yes, this is my favorite one. It saves a lot of time and it gives good control. Short length work gives good control as well.
Yes, sir.
पानी डाल इसमें डाल जोर से. See, you can save a lot of time using this bar.
Yes, sir.
This is just initial sausagation. What I'm trying to define here is segment.
Yes, sir. Yes.
Find out. I can see that segment very well now. Can you see the segment?
Yes, sir. Yes, sir.
Change in color.
Yes, sir.
See the change in color. थोड़ी देर बाद पानी डाल यार. मोटा दे section में and give me a diamond. See, I knew this part can be done faster, so I was just saving little bit of time.
Still out of focus.
मत डाल थोड़ा सा डाल.
A small mastoid.
Yeah, it is not big.
Your tips for juniors to... Hello?
Okay.
Your tips for juniors while you're drilling a small contracted mastoid so as not to damage the facial or semicircular canal.
Point out. So always keep taking the landmarks in consideration. That's why first of all I open the tegmen. I define the tegmen. Because once you define, you know your limit. Not to cross that. That's it.
And here, not to use monopolar cotton.
Yeah, monopolar is dangerous.
Yes.
Regular cotton ball. And see, this is your cholesteatoma.
Yes, sir.
Yes, sir. Yes, sir.
वही भर देते छोड़ दे बड़ी वाली था. I have to remove this tip to bring my flap in as well.
Yes, yes.
I told you this is required for this flap to come inside the cavity with maximum length. This tip has to go.
That's it.
All these marrow cells, these are not air cells.
Yeah, yeah.
These are all marrow cells. See, while using the cutting bar, never use the pressure. Beauty of this cutting bar is, it doesn't require pressure at all. And you can use all the time the side edge for the cutting.
Yeah.
All the time the side edge for the cutting.
So it has a huge surface area, this bird.
Pardon?
It's a huge surface area of the bird. Like it covers lots of...
Yeah. पानी डालो जोर से. No, diamond. This is the dome for the sigmoid sinus. See, this cavity is not going to be big at all. दूसरे को लाए किसी को. मोटर ले पानी डालने को गुरु.
From where you get all birds? Because they are very good quality birds.
Yeah, I don't know where our storekeeper, but some of them were brought from, I remember, we bought from Sembros.
Okay, Sembros.
You know Sembros?
Yeah.
See, this is sinus. See, no air cells here all around.
क्या सर ये वीडियो पे लाइव चल रहा है? Nothing sir, nothing.
See, once you are doing externalization, you have to remove all air cells.
Yes sir.
That is something you have to ensure. Now my tip is going. This is my digestive ridge. See this?
Yes.
I will break the tip and my flap will easily come inside. Bipolar.
We are planning to have one more webinar in last on. There are so many questions in starting. So how, where are you schooling from, how you learn everything, where you got trained, and then how you did everything, so many things. I think that all the questions we can cover in one webinar. Means how the Satish got up to this level. There are so many
Journey of Satish sir up till now.
Because these are few points we can share with all.
That will be also like over 12-13 hours webinar.
Meaning how to get all the things. I remember we were together at Mumbai in 1999.
Yes.
We were at same place. Hinduja, I used to come from KEM. I used to go to so many things were there. From there, right now he is on. All the things we can share.
That will be very nice. I think many people will looking forward to that.
See this part of the tip now finally, which I mobilize.
Yeah.
This tip I have removed. See, my flap is now ready to go inside.
Yeah,
there is no obstacle. So now this entire length of the flap will come.
Yes, sir. Freely falling in the cavity.
Yes. And see, all around I have gone beyond the sinus and the tegmen, everything, so that the tissue will fall in ultimately. ये देख. Now finally, this for the mastoid part. Give me cutting bar. See, such plant cases are the simplest of the cases for mastoidectomy, where you know what exactly are your limits cotton ball.
But I think cavity obliteration is one of the challenging subject and still most controversial. So best cavity obliteration people wanted to see.
Yeah, there are variety of situations. We will keep on showing every time something different. There are so many flaps in vicinity of the temporal bone. So many. Only the temporalis muscle, by means of the temporalis muscle, you can make variety of flaps. इसको हिलाए मत. मेरे को मोटा सेक्शन था. धीरे धीरे. Now I am taking my
canal wall,
ridge, bridge, canal wall, whatever. See, control on the speed of the burr is important. See, this is all it was the cavity, like this. See, so far, the same burr is working.
Yes, yes.
This is how you can save a lot of time. Look.
Dr. Rajeev is asking from Bhilai, if you have got a slight tegment here while doing this drilling, how to manage?
What question?
So if there is slight tegment defect while drilling, how to manage that?
Tegment defect?
Yes, sir.
Tegment defect, see, depending upon the size of the defect. Anyway, next Sunday, Ajay, rakh liya na? Next Sunday, tegment wala. Next Sunday, we have a case, we are keeping, diamond, of a tegment tympani defect post-traumatic. Patient has a CSF autoria. So, in tegment defects, depending upon the size of the defect, you have to take a call. The best way is, if you have a bigger defect, go by middle approach. See what is that simplest. Suppose you have a 1 centimeter defect here. Okay? Go above and beyond the size of the defect. Like if it is 1 by 1 centimeter, you go 1.3 by 1.3 all around and harvest this bone. Harvest the middle canal fossa bone flap. Separate it. Then from above, elevate the dura. Above the tegment, elevate the dura. That bone flap, after channelizing it, furnishing it, you can place it from above.
Yes, sir.
And that will be a short kind of a closure in those situations, Smaller defects, you may have to do whatever you can, but this is something a short way. A lot of people are using cartilage from below, fat, whatever, like any CSF leak. You can reconstruct. But the short way is you go from above. This is cholesteatoma.
Yes.
Now this labyrinthine cells, this is something that you need to remove thoroughly. And a lot of people, because if you are not sure about the perilabyrinthine pneumatization and all that, they include this in the middle ear. If I include this area in the middle ear and rest is out and reconstruct a canal here, that is soft wall reconstruction. Okay?
Yes, sir.
Give me circular. Patla de. Let me show you how you can.
Very well accepted till now, the soft SWR.
Yeah, for the indication. It is a very good technique. It's a very good technique if you do it properly for proper indication.
Properly. You have to everything from.
See, this is the region over the semicircular canal. See, there is blue lining.
Yes, sir. Blue lining.
I told you that one part is thin over there.
Yes.
And see, that is blue lining. Could you see?
Yes, sir. Yes, sir.
See, this is all mucosa, epithelium, everything. That is facial nerve.
Yes, sir.
See there, a dehiscent in this region. Dehiscent in that region. This face, yeah.
It can also.
See, this part is dehiscent.
Yes, yes.
Patla.
Hello. Hello.
Yes.
Now, would you reconstruct the hearing part as well in this patient?
Yeah, we'll see.
Yes, yes.
So, what things you keep in mind when you have a dehiscent patient now while you are putting the
cartilage you can use if you use properly. Cartilage will not bother you. If you use a vertical cartilage,
you ensure that it does not fall on the facial. That is.
Yeah. It doesn't.
That can we cover the dehiscent part of the facial nerve with some fascia or something?
No.
Or no?
Pardon?
So can we cover this dehiscent part of the facial nerve with something like any soft tissue or any
No,
fascia?
not needed. Not needed. The periosteum is always there.
Okay.
Hello, if it was like proper fistula in SC or CT scan, would your approach be same like elevating the mucosa?
No. If I am committed here for a canal down, if I am committed here for a canal down, why would I elevate the epithelium over that?
Okay.
I will include it in the chota. Yeah, I will include that in the cavity only. See, these are some cells in the perilabyrinthine region.
Yes, sir.
Though I saw on CT scan there is no retrofacial pneumatization, no petrous apex pneumatization. This is all marrow area. See this? You have to literally remove all this.
Please centralize this.
Centralize. No?
Yeah, it's okay.
If you get a pigment defect of less than 2 centimeters.
Pardon?
If the defect of pigment defect is less than 2 centimeters, 1.5, then what would be your approach? Means you will go same approach or with?
Same approach. That is 100% short approach because you close from above.
Or you can just from down you can put cartilage and.
No, but it can give, it may not sustain the pressure of the brain. Brain pulsation may push it out. Brain may herniate.
Yes.
So that is a short way. When you put something from above the tegmen, that bone flap, it contains the brain itself. It will not transmit the brain pulsation at all. See how these perilabyrinthine cells have been drilled away.
Satish?
Yes, sir.
For the benefit of PGs, could you tell about the retrofacial clearance and tip cell clearance? That is the area where most of them are caught.
Retrofacial clearance is the area. Yeah, tip I have already removed, no tip. For retrofacial, yeah, retrofacial area is the area underneath the facial nerve. That is bounded laterally by the facial nerve and medially by the presigmoid dura. Then inferiorly it is bounded by the jugular bulb. And superiorly, the region here superiorly bounded by the posterior semicircular canal. This narrow space, this is retrofacial space. This is towards the retrofacial area I am going. See, this is posterior canal.
Yes, sir.
See that? Now, in this retrofacial, let me show you.
Yeah.
Yeah. In this retrofacial, my superior limit here is the posterior canal. Inferior limit here is going to be the jugular bulb. See that? Here. Like we saw in the acoustic case. Lateral limit is going to be the facial nerve, medially is presigmoid dura. See this complete skeletonization of the air cells in that region.
Yes, sir.
Now, and they communicate freely with the infracochlear area. Now, my next thing to be seen is the facial nerve and lowering this ridge. See that?
Yes, yes.
That is the middle ear.
Yes, sir.
Satish, the lining flap which you have retained, where is it attached now? Anterior wall?
Yes. Scissors. Fine scissors. Then, what are the iris? Yes, the middle ear mucosa is a little inflamed. Not so bad. I can see the facial. This is the region of the stapes, you can see.
Yes, yes, stapes we can see structure.
Some granulation, I don't want to mobilize it. See this. This middle ear mucosa I am going to preserve. See this mucosa is good. Now, this is for my reconstruction, all this. I will just put a graft and it will reconstruct everything. See this?
Yes, sir.
If I put a cartilage here, I can make this soft wall reconstruction. Like this. See that? So anything can be done. Now my goal is the classical exteriorization will include this facial ridge management. See this facial is here, you can see. See the genuine facial now.
Yes, yes. Yes.
And this is the overhang. This is all overhang. Above is the lateral canal, blue lining. Now, in order to do a good canal down, I need to take away this completely, I showed you on CT scan, I could see some suprastructure. And it is here. See this?
Yes, sir.
Stapes. See this? And we'll take the advantage of that. This side cutting there. Just take this ridge and then reconstruction, that's it. And in reconstruction, we have to do a lot of this. We have to cover all these funny spaces all around. See this space? See this retrofacial space? I will take this down till the level of the facial now. My facial would be here. See the level of the ridge?
Yeah.
Gone down significantly. Now I have to see the facial now and then go further.
It looks like grade 1 fistula.
Looks like?
Grade 1 fistula.
No, the
How you manage
period.
different types of fistula, little canal fistula.
Yeah, that I will tell you. See the facial now going posteriorly.
Diamond.
Yeah. See the facial now?
Yes, sir.
Yeah.
See this facial now? Now I can remove all this bone anterior to it. See this?
Yeah.
Once you know the course, this is exposure of the periosteum, nothing. Now this is behind is the retrofacial area.
So please centralize.
Yes. See the facial now as a bridge.
Yes, sir. Yes.
See, this is how the complete pneumatization is taken off. Exteriorizing means completely. See, this is digestive ridge. This is digestive ridge.
Yes.
And this is leading to the facial now. See this?
Yeah.
Completely.
So in this case, there is very narrow sinus tympani. Usually sinus tympani, the deep sinus tympani goes medial to the facial nerve. But we have lots of bone anterior to the facial nerve.
Yeah. So, diamond. See now the hypotympanum is completely, when you do myotoplasty, it will become draining, you know?
Yeah.
Yes, sir. Yes, sir.
Completely flattened. See this area. This is very important. अरे ले यार ये क्या? इसको बाहर रख दे. फैला दे.
Diamond.
No, we'll use it as a free. I was about to remove it earlier, but I thought let it be. रख लिया इसको. We'll use it as a free graft, okay?
You are using cutting for hair.
Yeah, it doesn't make any difference.
This
The diamond.
Only for you. For us.
No, it doesn't make any difference. तो बड़ी देता ना इसको, एक size बड़ी. Now finally I have to this finishing. These are some marrow cells. See below the jugular bulb.
Yes, sir.
All this is marrow cells, you know. These are not true hair cells.
Yes. This case requires 100% obliteration. Otherwise, if you don't obliterate, you will have no traveling for the disease.
See this completely clear. No, one side shorter. See this. See the plate of the sigmoid sinus.
Yes, sir. Very.
And see the facial nerve in the middle.
Yes.
The flap I should have removed earlier. I will cover everything with a vascularized flap and the fascia over it. See this, so nothing will remain, you know, the bone will not remain exposed at all.
Okay, sir. Okay.
That is the whole game. Discharging cavity remains if the bone remains exposed. It should be covered by the vascularized tissue.
When do you prefer putting
Pardon?
cartilages to fill up these bones?
When do I?
When do you put pieces of cartilage to fill up these crevices?
Piece of cartilage I can keep in this cavity. See, this is a recessed cavity here. I have to fill up something there. You can use bone dust there, you can use cartilage. Because ultimately I am going to cover that with a vascularized flap. You can use anything there.
Free musculoperiosteal also.
Even free you can put in that, because ultimately above that is going to be the vascularized flap.
Yes.
Diamond. I have a full cavity now for the reconstruction. See, this is your facial now, horizontal.
Yes.
Circular. My bone work is done all the way. I have a stapes here. See this? I am going to use some cartilage over it, that's it. And that will be the simplest of the ossiculoplasty. At one end on this stapes and other end here on the inferior annulus.
Okay.
To keep it stable. Now the thing required is it should not remain a discharging cavity.
Yes, sir.
What best we can do to reconstruct this? So my reconstruction will require a cartilage from here to here. That is the hearing, and the rest of the cavity. I have a flap. I will bring some more tissue, and then I will put the fascia, patli. So now the reconstruction part, I will harvest the cartilage, fascia and some bone dust. Some bone dust.
Is it necessary to remove all the bone marrow cells in this case?
Not really.
Not really.
Not really.
And will you...
Marrow cells are not mandatory to be removed, you know.
Okay.
Just I wanted to show you the, you asked for the retrofacial area.
Dr. Abdullah from Iran is asking what is the status of eustachian tube in this case.
Eustachian tube, you can assume supposed to be good. The reason is, you have a good middle ear. Cotton lag there. You have good middle ear, the mucosa is healthy, eustachian tube is healthy. Once we reconstruct, it should work. See the marrow.
Dr. Abdullah from Iran. He is from, I think he trained AIMS, India. And I think he's in...
He's in?
He's in Iran, but he is trained at in AIMS, India.
Oh.
And Dr. Ravi told me on that day, he is a very wonderful guy. He knows Hindi also. He speaks very well Hindi. Very good Hindi also.
Oh, good.
Abdullah.
See the overall situation of the cavity now.
Yeah.
Yes, sir.
And now reconstruction, the most important part now. This should not be a discharging cavity. So first of all, I have to harvest the cartilage, a little bit of the bone dust I will harvest here. My bone dust, I will never leave it exposed to the cavity. You know, if you leave the bone dust exposed to the cavity, it will get infected.
Yes.
If it is buried underneath the vascularized flap, away from the exterior, it works. That's my point.
Yes. Yes.
Do you always use punctal cartilage?
Tragal. Lisa. See, this bone dust are taking away from the mastoid area, which could be part of infection otherwise. See this?
Yes.
This is away from the infected area. Okay. This is very useful.
Yes, sir.
Wash.
So in these cases, you rule out history of any rhinosinusitis, go for CT scan, PNS, or was it that you...
See, adult once develop the cholesterol at this level.
Yeah.
Now what is there in the sinuses or not is not going to change this management.
Yeah.
That you have to take care. What we give these patients, some long-term nasal sprays, you know. We give them whether affected or not, and it is something which can improve the use second tube. So long-term nasal sprays we give. Now this cartilage, this is the simplest cartilage you can think of for the reconstruction here, where you already have a not a complete stapes, but yes, you have some suprastructure. Not complete. But still I will augment with this cartilage. And this cartilage will remain all the way in contact with the drum.
Yes, sir.
So you made a groove in the anteriorly at exactly what level?
Anyway, you can make inferior, antero-inferior.
Yeah, everything.
Yeah, just across the length of the middle ear, so that it remains in contact with the tympanic membrane maximum. Right.
Put the entire width of the cartilage or just a strip?
A strip, yes, see this.
Okay.
Just strip. Suture maar dena. Just a strip.
Many people use cartilage shield tympanoplasty. The entire piece of cartilage is kept over the. What is your opinion about that?
Boss, I've never done an. Our tympanoplasty, I have already demonstrated interlay. That is most physiological, I believe. That's why we are following that in interlay, and we use the temporalis fascia for making the neodrum. And that too, the fibrous layer interposed between the epithelium and the... Yes, and it works. Now see this triangular cartilage.
Yes, sir.
See, simplest. The beauty of this cartilage is it will maintain the middle ear space, number one. See at one place there. See this. See, this will maintain the middle ear space, number one. Hello?
Yes, sir. Yes.
And this will be a big support to our graft as well.
Yes.
Not bother the facial at all.
Yes.
The dehiscent facial.
No, it will not affect.
Is it touching
Slightly longer, I think.
Yeah, longer. I'm taking intentionally little longer. So this cartilage is coming on the, lateral semicircular canal. But touching my facial now, see this below, this stapes.
Yeah, yes. Movement.
And this is malleable. See this? It will never create harm. The entire length will remain in contact with the drum.
Sir, can we make a groove for stapes head in this?
Yeah, you can make additionally if you have a doubt about the stability.
Stability, yes.
Unnecessarily, it is not required. It's not essential, I would say. See this broad end, that's why it's on the stapes head. See how it will go?
Yes,
it is so stable. It is so stable. Okay?
Yes.
Now I need my fascia quickly, the big one, and some soft tissue. We already have some bone dust. I'll have some more soft tissue through my meatoplasty because I will create a little bit. Not a big one here. No. See, I'm not creating a big meatoplasty. This way I will get some more tissue.
Yeah.
Just for the discussion, can we go for any other type of osteoplasty in this particular case?
What else will be appropriate with this? Tell me. You suggest, Vishal?
Any titanium or something?
No, boss. Why?
No.
In this, such area with the shallow middle ear, with your partial stapes head. See what I'm acquiring?
The floor cartilage.
Yes. I will use underneath my flap. This is the tissue.
Please explain how to suture them, these, after
Meatoplasty.
Because many people are asking about the meatoplasty.
Meatoplasty is what? You see now, we'll suture one end this side, one end this side, and this on this side. So it will be a round meatoplasty. I told you this is simplest of all meatoplasties.
But this step which you are doing, removing the floor cartilage, this is very important. Many people just
this is conchal.
Conchal.
Yeah. More conchal you remove, then only the meatoplasty will be bigger. Here I don't need to remove much. See, all this soft tissue will be useful. If I remove this tissue, my meatoplasty will be simplest.
बंद है? वो देखो ये बाहर पड़ा हुआ है.
Sir, Dr. Vikas Kakkar is saying always treat to watch Satish operating and you always learn something new from him.
Nothing new, boss, here today. Plate the blade. Thank you.
सुंदर फोन किसका?
पकड़, इसको पकड़, इधर से पकड़.
तो बोलो सुबह 10 बजे फोन कर लो.
See this suturing of the meatoplasty. See this. This will open up. This will widen my meatus like anything. See this?
Yes.
This, and this we will suture like this, everting. it will be this big meatus. See this goal? Absolutely rounded.
Yes, sir.
All around. The suturing will be all around. Not on this side and this side. Then it will be a diamond shape. It should be rounded.
Cartilage should not be exposed.
Cartilage should not be exposed, yes.
Yes, the cartilage should be covered completely inside. And now all this soft tissue will fill in. Give me. Let me show you how my flap is going to come. Hello?
Yes, sir. Yes.
Yeah, now what I am going to do now, only thing I have not acquired forceps is the graft.
Yes.
That I will acquire in the end.
Fully fresh.
Yes.
So Dr. Yusuf Salih is asking how you correlate tympanosteroid suture with facial nerve. What is the relation?
The facial nerve is medial to it, where it ends. Give me bone dust. See now this marrow area.
Yeah.
I will obliterate with the bone dust. There.
Dr. Palani Appam from Teguchapalli wants to know about your comments on torque for.
No, wo back end. Torp and por we use in fresh situation, intact drum situation.
Okay.
Sterile cavity.
Yeah, as sterile area it is. See this area, what is for marrow space.
Okay.
There. I will just bury it underneath the flap. It should not come in contact with the exterior. See this?
Yes, sir.
और दे वो फिश था ना कुछ वो था ना निकला कार्टिलेज वगैरह जो भी था
Bone dust is just plain bone dust. Sometimes you mix it with the
PRP. जो भी है तेरे पास. Pardon?
Sometimes you mix this bone dust with PRP to get it more.
Yeah. Okay. See all these cartilage, fascia, everything I used in this space.
Yes.
Okay. और दे कुछ है.
There will be hardly any cavity.
Yeah, and now
zoom out a little bit.
See this?
Zoom out.
Yeah.
You put a graft on the muscles.
Yes. That will be taken up with the vascularized tissue inside.
Yes.
See this. See without any tension. And now I will harvest graft and place the graft. No problem. Now will be the graft, lastly. And that will be a fresh one. We'll harvest a little bigger graft to cover the entire region. Okay. I can harvest a vascularized graft also.
Yes, sir. Wonderful. That is ultimate. Let's show them because it is wonderful to clap. I think everybody should know it.
Vascularized graft?
Yes.
See that vascularized graft? Yes.
Zoom out a little bit.
The vascularized graft can cover everything, and once there is a vascularized tissue, you don't need any. You don't need to wait for the healing. The vascularity itself will result in healing. You want me to show?
Because long time, it's wonderful flap, and I think everybody should know it, how to harvest it.
Okay, that is a middle temporal artery flap. Let me show you. I have to extend my incision little bit high up.
Yes.
See, suction karna. See that?
Yes, sir. Yes.
Just to show you the vascularized middle temporal artery based periosteal flap. Now, you can take a part of little bit of the muscle as well if you want. See now, I am at the posterior edge of this muscle. Can you see?
Yes, sir.
Center.
Yes.
Center.
Yeah. See this?
Yeah.
Posterior edge of this muscle?
Yes.
This is temporalis.
Yeah.
This is superior temporal line. See this?
Yes, sir.
I use this flap many a time for different purpose, but one should know this. Pachauri boss is right. See how to use this. Now see, I am elevating the muscle, leaving the periosteum intact. Can you see below?
Yes.
See the vessels in the periosteum.
Yeah.
These are branches of middle temporal artery, which go across the thickness of the muscle into the muscle also. If you want to take, you can take a partial thickness of the muscle as well. See this?
We have used in our revision cases, second, third time cases.
Yeah.
Wonderful. Almost 100% purity.
Yeah.
We use it as a free graft.
No, vascularized, man. Free graft is no value. This will be pure vascularized. That's what I'm showing. This is vascularized. See the branches of middle temporal. Middle temporal is a branch of superficial temporal, and from there keep oriented. If you have a doubt, you can ask. See how I am going to raise this flap. You look. The muscle I am going to repose it again.
Okay, sir.
Now, this is my main vessel here.
Yeah.
Here, going from below here on the middle temporal. Choda. See this? Non-tooth. This is tethered right on the bone. See this vascularized pericranial flap.
Yes, sir.
Retractile. Little bit of the bleeding from the muscle is acceptable.
You showed this in that facial nerve temporal bone dissection workshop also, this flap.
Yes.
In that workshop you showed.
Okay.
Satish?
Yeah.
Dr. Satish?
Yes, please.
Hello?
Yes, sir.
Satish, this sort of flap, we've seen sometimes it shrinks in the cavity, and second is you have a dip in the temporal region. So that.
Sir, first of all, First of all, it is not a free flap to shrink. This has a vascularity along. Free tissue may shrink, you're right. Free tissue can shrink. This is not a free tissue.
Because then how does it change in your pediatric age group, where we are put and after 15 years of age, we find that all those old cases, they have a cavity.
Yeah, because those are not vascularized flaps.
Like the same temporal flap which has been used, it's the inferior one is good, but this temporal one, sometimes we have a
See, this is to cover. This is to cover a lot of areas.
yeah.
I will rotate this.
It's wonderful that we use the temporal fascia also.
Yeah, this is to give additional vascularity. See this?
Yes, sir.
This is vascular. See, pure vascular flap. See what we want for healing vascularity.
Yeah.
See this? And on this surface, on a vascular surface, you put anything, it will be taken up. In the sense, you put a skin. You put a skin, it will be taken up.
Yes, sir.
You put fascia, anything, it will be taken up.
Centralized.
Yeah. See, one flap coming from above, one from below.
Yeah.
And this is something important for my graft.
Yes.
अब उसको लिया वापस ला इसको वापस इधर
Using since I think 5-6 years. I'm using since 5-6 years. Wonderful flap.
Yeah, this is amazing flap, boss. It can never go. Pala. Now my final aspect is grafting. This flap, see this? With a huge flap, I have done many a time this thing. Vascularized flap tympanoplasty also.
Yes, revision cases.
Rather than a free graft for tympanic membrane, you can use a vascularized flap as a short.
Yeah, you can take out the temporal.
Now I will harvest a little bit of the fascia. See that? Jaldi. Pani dena. Retract. See, this muscle will come back in place. Needle laga ke. Hello?
Yes, sir.
Yeah.
This all exercise is to give a good healthy cavity, Just for healthy cavity. Knife. Quickly, just last part is left. Hello?
Yes, sir.
Now I have no concern regarding the graft take-up as I have a vascularized flap underneath. Got my point?
Yes,
sir. Yes.
Whatever graft I will take, it will be taken up. Because it is going to acquire the vascularity from the underlying vascularized flap. That's what I am not concerned about the quality of the graft now. Everything I will put, it will be taken up. This is last part. I will place the flap. I will fix the flaps later. First I will place my graft covering the middle ear. See this?
Yeah.
This one. This will cover everything. From canal side when you see, there will be narrow area. Got my point, what I am trying to say?
Yes, sir.
Patla. idea is, patient should not have a discharging ear now. My hearing cartilage is there in place.
You will not touch anteriorly, elevating the flap because it will survive.
Pardon?
You take your anterior canal wall incision and take it inside or it.
Yeah, already elevated. See this one.
Yeah, okay.
Yeah, with the skin line.
See this. See that.
The entire skin has been elevated. Anterior superior.
That's already elevated.
Yeah. Take up.
See this will come like this. Can you see?
Yes.
Yeah. Wonderful.
And this will cover. I don't want my cavity to be exposed from outside. So वो देना कोना flap का part था ना fascia.
Yes.
You know this skin.
Yeah.
Which we made free.
It will work. It will take
Yeah.
up the right.
Yeah. I will keep it. Keep it superiorly towards the atic to completely cover it.
Yeah.
See that?
Yeah, wonderful.
This is a ready-made skin. See,
So
this
your
is
infrared flap will not be used.
Dr. Pradeep from Nasik wants to know about Palwas flap.
Palwas flap is anterior base when you raise the postauricular tissue. That we can show from beginning if you want. See this now, what I want to say. Keeping this skin in place. Now see. See now it is covered all around?
Yeah.
With the skin. This is my cartilage here. This is the skin all around. See in the atic? That flap, initial flap.
Yes, sir. Yes.
See the atic and see inferior part. Everywhere this is the skin. And this is under this flap. And this flap is over the vascularized tissue.
Sir, can we put PRF over this free skin flap? Maybe better than FGel in this case?
Yes. See this. I am introducing this flap underneath this fascia. All the way. See this flap?
Yeah.
Yes, sir. Yes.
This is middle temporal artery flap. Such a wonderful flap. See now.
Wonderful, sir. Everything is totally covered. Well vascularized.
Vascularized, and this is going to cover this vascular tissue. The skin is over here, and see the medullary space.
Yes, sir.
So my area is, my mastoid is no more existing to give problem. This is good vascularized tissue.
Yeah.
Vascularized tissue is not going to shrink so easily.
Yes, sir.
Free tissue can shrink. This is blood soaked gel form. Blood contains fibrin.
Yes, sir.
So now once I put my meatoplasty in place, when you see from the side, you will graft and the skin, cartilage and it is taken care of. No more cavity, give cavity. But this you cannot do if you are not sure about removal of the cholesterol cells.
Sir, in these cases in which we have completely covered the cavity, can we omit meatoplasty? Like, can we avoid meatoplasty in these cases?
This is a big meatus than usual now. See this.
It looks normal, small, but it is a big meter.
No, it is not small. See this meter size is quite big. And see what happens once I have additional skin to cover. Now the skin will come over it.
Yes, sir.
This skin will come over it.
Okay, okay.
This myotoplasty skin.
Yeah.
See this? This skin is going to come over it to epithelize from above.
Fine.
See this and this.
Okay, sir.
See now, everywhere it will remain epithelialized. See, this myotoplasty is adequate for this patient. See this?
Zoom out like it. Zoom out. It will be more.
See now. This myotoplasty flap here and myotoplasty flap here. Okay? See this flap? Now to keep them in position, I will suture this. Give 2 sutures and they will be fixed. So finally, from behind, see this? From behind my cavity is reconstructed. What you see from outside, no bone area. See this myotoplasty flap, I will stabilize it.
You didn't put anything in the attic area, any cartilage, anything in the attic part?
No, I covered with that.
Bone, that skin?
Yes. Sure, no? Some cartilage was there to augment the height.
Yes, sir.
Sure. See, this will keep this. What I want my myotoplasty flap to remain in place. This myotoplasty flap. See this? This is a big source of epithelialization. Epithelialization. And here this one, this I will fix on this side. Now everything when you see post-op from inside, only thing you will see is the fascia. Covered with the skin. See this?
Yes.
I hope you got the idea.
Yes.
So this patient will have, will not have a long, suture maar dena, extra cut gaya. Idea is this should not discharge in the post-op.
Yes, for this age and for this thing. Yeah.
This patient should not discharge. That's it. We'll put one more suture here for this flap and then we'll close it. Okay? Thank you. This will have this is exteriorization with partial obliteration.
Yeah.
So we saw many things in one surgery, myotoplasty, so many flaps, things.
Absolutely mesmerizing, spellbound.
Osteoplasty, everything in one surgery. Total obliteration of the cavity, everything covered.
Bone dust can we mix with the rifampicin, etc.? As the bone dust was taken from a sterile part, I think no need to mix with anything. Hello.
Now I'll show you the acoustic neuroma patient before we go into the pre-auricular sinus.
Yes.
Let us see how is he doing.
So one last thing, Dr. Venus Patel from Surat wants to know that blue lining fistula, anything has to be done about that? Or?
Nothing. As long as the thin bony covering is there and the cavity is obliterated now, there will be no stimulus going there.
Okay.
That is already taken care of. Come. Hello. What's camera lao? Camera चालू करना इधर. Hello dear, how are you? Yes sir, fine. Good. So, are you having something? You had your breakfast, dinner? Just a minute.
Yeah, I'm fine, sir. Thank you.
Good.
Breakfast or
Yeah,
Yes, sir.
breakfast.
Are you eating everything?
Eating everything, sir. Coconut, water, chai, milk.
You're walking as well?
Walking as well. And bathroom also.
All going on.
Yeah, yeah.
Okay. Show them. See the face on without any see the still face. No obvious deformity, nothing. No
Yes,
obvious
sir.
deformity.
Yes, yes.
Yeah. The still picture of the face. See this? Nobody can make out. Now.
Yes, yes.
Yeah. Close your eyes tight. Close your eyes.
Yeah, grade 2.
Grade 2.
Close your eyes tight. Now open
Very
your
nice.
mouth. Open your mouth. See this little bit of the deviation.
Yeah, little deviation.
Since we kept the nerve intact, this is just because of the handling, this is bound to happen. Once you have a thin facial nerve, you are separated. And this is going to recover.
But sir, remember Morwani sir was expecting at least grade 5 facial nerve palsy post. And this is just grade 2.
This is grade 3, you can say at the most.
Yes, sir.
2, 3. Thank you, boss. Thank you. Hello.
Yes, sir.
Yeah. Next case is a young girl with bilateral preauricular sinus. Preauricular, see in the neck, we'll see in the upcoming webinar the variety of fistula and sinuses which make the life difficult sometimes.
Yes, sir.
So one of the group is preauricular sinuses. This is absolutely different from the bronchial sinuses and the thyroglossal fistula and sinuses. This is a different pathology altogether. This happens due to malfusion of the auricular tubercles, you know.
Yes.
In the 6th week of embryo, there are 6 tubercles which comes out from the branchial arches, first and second branchial arches. Upper 3 from the first branchial arch, caudal part of the first, and lower 3 from the cranial part of the second. And that's how these 6 fuses, all these tubercles fuse to form the auricle, the external ear, helix of his. So if there is any malfusion during the development, may leave this dermal cleft inside, is present as a periauricular sinus. Just it comes just in front of the anterior helix, right on the ascending anterior helix. Many of them are asymptomatic, nothing is required to be done. But if they start getting infected again, they need to be removed, otherwise they create problem, cosmetic and other issues. So this patient has one side infected sinus which is ruptured beyond the original site, and the other side is a regular sinus without any infection. So I'll show on both sides, they want to get done both sides. There are many techniques. The issue is these problems are complicated by their nature. They are notorious to recur if you leave a part of any skin anywhere. And sometimes it is difficult to appreciate where the sinus tract is going. It's not all that easy, which looks fascinating, that you follow the tract and remove it and come out. It is not a single tract. As this tract deepens, this arborizes into many of the fine tracts all around, and you cannot pick up every tract. That's how one of the publications from Dr. Prasad, who described the supraauricular technique, is a technique of choice. In the sense that is based on the fact that it doesn't go underneath the temporalis fascia. The limit above is auricular cartilage. And if you work in between these two, remove the entire tissue and block, taking the part of the cartilage which is must, because this tract is very in close proximity to the cartilage. If you remove everything, you can prevent the possibility of recurrence, because this is not bronchial fistula. There are a variety of bronchial fistula situations. Type 1, 2, 3, 4, we'll take one by one all. So one is in relation to the parotid gland and the facial nerve. 1A and 1B in relation to canal 1A and 2 more complex. Most complex of all branchial fistula is 1B in relation to the parotid gland and facial. Now, and you know what mistake a surgeon does when you see that branchial type B fistula? Many of the surgeons assume as a post-auricular sinus and they take up for mastoidectomy sometimes. But that fistula is little below the auricle here, below the lobule, not little posteriorly, but not in the classical position of a post-auricular sinus by cholesteatoma. And that sinus, if you follow, deepens right around the facial nerve in the depth of the parotid. Both superficial and deep parotid. Imagine how difficult it is to remove that with preservation of the facial nerve. And it deepens and deepens, and you have to remove each and every part of it. For that you need a good MRI to see the tract completely and remove it. So those are branchial. Why I am saying so? These preauricular are classically away from the parotid, away from the facial nerve. Their limit is parotid below. So the medial limit is temporalis fascia, inferior anterior limit is parotid. Wherever the parotid comes, you have to stop. This will never go. Because their embryology is different, the parotid development and the facial nerve development is from a different branchial arch. So, classically between the temporalis fascia and the cartilage of the helix, these 6 cartilage which makes the pinna, the second forms the ascending root of the helix, in front of which this fistula forms. Third forms the superior, 4 posterior, 5 inferior, and the 6 forms the lobule. This fistula is just in front of the tragus, which forms the second cartilage, second prominence, and this is the ascending helix where it forms. So we have to remove the part of the cartilage en bloc in the depth of the temporalis fascia, staying just above and lateral to the parotid. And if we take it en bloc, this is classical supraauricular approach by Prasad. This leaves hardly any possibility of recurrence. Now on the other side, what will do? They follow the tract. Now, first of all, how to follow that? You put methylene blue, many a time it doesn't go inside the tract because they are full of squamous material. Even if it goes, it may go in the surrounding tissue as well and then spoil everything. Everything will be like infected tissue then. If in methylene blue you inject, if it goes out of the tract, this is waste. Then it will complicate your removal. You may remove even normal tissue unnecessarily, which is stained by the methylene blue. So the best way, you cannot trace each and every part of the tract, to stay in this compartment lateral to the temporalis fascia and between the cartilage, and you can easily remove this. We have both the situation. On one side, non-infected level 1 fistula, sinus. Level 2 is when there is minimal infection and edema and sort of an abscess around this opening. And grade 3 is when the opening, it bursts beyond the original fistula. So we have grade 3 which has burst beyond the fistula and infected the skin. That is complicated one. So on one side, I will show first the grade 1. That is the simplest one. And then first will be the simple one and the second will be the other one. And then reconstruction is equally important, because if you leave a big defect, then it will not heal easily, or it may give way. If you try to do a partial closure, then you need some flap. So I will show some flap also on the other side if required.
So pre-workup investigations, what you do in these cases?
In these cases, generally you don't need to do anything, but sometimes they are part of some syndrome as well. Sometimes they are part of bronchorenal otol syndrome. You know, otorenal syndrome, bronchorenal otol syndrome, wherein the patient may have hearing loss also, some renal abnormalities. So if you have some other signs of any congenital disease, then you can do workup like that. Hearing otherwise test is not required. Sometimes people related this to hearing because this develops from the first arch. And you say tube also developed from the first arch. There could be some malfunction, but it's not related.
The MRI you do in all the cases?
No, not in this. This not. Branchial. Type 1 branchial.
Type 1 branchial.
Yeah, that is classical. Type 1B. then MRI is must to see the tract in the facial, otherwise you'll end up damaging the facial in the parotid.
Okay, okay.
So the points are there is no need of methylene blue, there is no need of
Yes,
probing.
we use some time. I asked to put the methylene blue to show you, but that is never sufficient because it doesn't reach the final arborization of the tract. Fine branches from the tract, you cannot trace each and every one. So what people other started to do, because methylene blue injection is outside the duct. If you try to inject, it's a very small duct. So what they do now, they mix methylene blue in fibrin glue. So it becomes solidified, and then you inject. It goes with pressure into the various branches, and you can pick up well. But that is too massive a procedure to use a fibrin glue for this staining. Finally, if you use the supraauricular approach, which I mentioned it, there is hardly any possibility of a recurrence if you completely remove in the plane. That's it. You don't need to do anything. There is hardly any possibility of a recurrence. We have done so many and rarely found a recurrence.
So many people do a probing or a intracat in the tract and they dissect around that thing till it goes.
Yeah, you may damage the tract. There is no control over it, and for that is for the main tract. What to do with the smaller branches?
Yes, sir.
In the bottom of the tracts are many smaller branches. So, anything else, or do we go ahead?
Professor Mazumdar, there is a comment from Professor Mazumdar from Pondicherry. This cholesteatoma is a recent thing. It developed since 200 years only. In mummies, there was no cholesteatoma because they just studied the mummies and there was no cholesteatoma in that case. So I think as per this thing, it is a recent development in human structure, human anatomy.
Oh, really?
Professor Mazumdar.
Really?
Yeah. He just called me up for this.
Oh, great. He's probably the senior most ENT in our country.
Yeah, he's senior most ENT in, I think, India.
He celebrated his 87th birthday yesterday.
Yeah, and you know that as per his last year was the 100 years of the ENT in India.
Wow.
What is the earliest stage of this thing, Satish? What is the earliest stage of doing this preauricular sinus?
No need to rush.
Sir, any role of fistula people are asking.
Dr. Asim is there.
Hello?
Dr. Asim boss. Dr. Asim is there.
Asim?
Yeah, he's there. He's
Yes, how are you?
Hello?
Yeah,
How are you?
Hello, boss.
I just logged in.
Oh, great to see you.
I just saw the last part of your meatoplasty. Wonderful job, boss.
Oh, nothing in front of you.
Okay, boss.
So Asim was in that case, what was your protocol? What you had done in that case? Any reconstruct, anything different, or almost same thing?
Almost the same thing. Almost the same thing. Just very carefully you have to stitch the meatoplasty flaps back. That is the most important part. And there's another thing that I would have done is that I would have lined the raw area with skin, post-auricular skin. You know, the point when you put post-auricular skin on fascia, that will necrose. But if you put it on a vascularized pedicle, it will take very quickly and easily. You see, ultimately what you want is epithelial proliferation. And this is when epidermal cells come in contact with other epidermal cells, there are epidermal growth factors that allow for faster proliferation of epithelialization. So that's the only thing perhaps I would have done different, otherwise he's done a masterful job, absolutely. I think it's fantastic in your surgery, there's no question.
So you use quite frequently the skin graft?
Yeah,
free skin?
That. Yeah, free skin graft, but on the vascularized flap, not on bare. It is not used to cover bare bone, it is not used to cover fascia.
Yeah.
Because you see, fascia is already avascularized, devascularized.
Yeah, but it is on the vascularized flap.
On the vascular flap, it takes beautifully.
Yes. And we had a good skin all around over the fascia.
No, this case is absolutely perfect, boss. Perfect. This last bit, if there's something different, just in the posterior part, where the flap was there, I would have put a little posterior skin. That's an optional thing. We have done it for many years and we found it useful, not mandatory.
Yeah. Are you getting the picture, boss?
Yes, boss.
Very clear, nice.
So this is under microscope, always under microscope का है. चालू है? On, connect. वीरेंद्र. वीरेंद्र.
We do not recommend methylene blue in all the cases.
वीरेंद्र.
Not really essential.
Not essential.
The only time I have used methylene blue is in multiple recurrence.
What, huh?
Then third and fourth time after that the patient has come to me, then I will probably do it. Not.
Revision are the worst cases.
Yeah. Especially when there are multiple abscesses which are burst everywhere. Sometimes you find a tract going behind the superficial temporal artery also. It out and around the artery.
And very difficult to stitch that skin also in this cases. You have to use
you need to take a small flap.
Yes, yes.
Or a VY-plasty or something like that. Because the skin is very necrotic.
Hello?
Yeah, boy.
Yes, sir.
Yes, sir. So this is the primary side I told you. The other side is infected. And this is the fistula you can see.
Yes, sir. Very clearly seen.
This opening we have placed some pale blue inside. So I don't think it has any much relevance.
You're doing a local or GA?
GA. So I told you this ascending helix part,
Yes.
this cartilage, there are a lot of studies done. This fistula is having a close relationship to this cartilage. See what I am doing? Taking this elliptical incision. आज चलेगी हेलो चलेगा चेक करूं कुछ भी तो नहीं है check kar. Yes, I was looking for some other cautery. See the, arey yaar. Hey. Please. See posteriorly.
Yes, you're exposing.
I told you this is a simple fistula. I have to just move it. And I will go superiorly and go in the temporis fascia plane.
So what all are the important things we need to take care while dissecting in this area? Any important structure do we?
See, that's what I'm coming to. The first thing that we need to do is to go in the temporis fascia plane immediately. Come, Pirak. That's why this is supraauricular mop. That is the plane of the temporis fascia. See that?
Yes, yes, yes.
Now, see, this was my methylene blue.
Yes, sir.
See inside. Can you see?
Yes, yes, yes. It looks like a big vein, blue vein.
Yeah. And this is one more sinus.
So that whole block of cartilage has to go.
Whatever is in close relationship.
Yes.
If you leave the cartilage, it is going to come back. But you know, sometimes relying on methylene blue is a big problem.
Sometimes it just got out.
कौन सा pedal? ये? सुनो. Yes, now. I am trying to stay right on the cartilage.
So this is just Haggard flare needle, like kind of a thing which.
See this?
This pointed needle is wonderful thing.
Colorado tip. It's a
yeah. See my cartilage here?
Yes.
Yeah.
Partially I have taken there. This tip gives me opportunity to see the tract better.
Yes.
See this?
Yeah.
Yes, sir.
See where the tract is going. यूँ रख ले यार, बस यूँ रख ले तो इधर. See now this cartilage.
Yeah.
I will take this. Oh, breaking. See what a tool it is.
Just seen this needle using in Haggard flap. First time seeing in this preauricular sinus.
See, the reason is, if I don't use this Colorado tip, the resultant bleeding will not allow me to identify the things. Mop kar dhole. Wash. Wash. See the entire tract.
Yes, sir. Yes, sir.
Region of the tract. Otherwise, you cannot pick up so easily. One can easily leave behind. See this?
Yes, sir.
This is my serious temporis fascia plane.
Yes, sir. Yes, sir.
This sinus will never go deep to temporis fascia. This is for sure.
Yes, yes.
Secondly, see this fascia plane. This will never go beyond this cartilage. It is cartilage.
Yes, sir.
This is my posterior limit. This cartilage. This tract is so close to the perigondium of the cartilage. See this?
Yes, sir.
And anteriorly, see this? Parotid is our limit. Maximum limit. See, with this technique, you don't have to follow each and every branch. See the beauty of this tip.
Hello?
Yeah, had I not been using this tip, the resultant bleeding will not allow me to identify my plane. See this plane?
Yes, sir.
Entire temporalis fascia plane. See this? All the way. See such a huge tract.
Goes up to TM joint.
Hello?
Yeah. Sometimes it goes up to TM joint.
Sir, how far is the facial nerve from here? Can you just...
Miles away. It has nothing to do. I told you, this is away from the parotid. Facial nerve passes through the parotid. How can it be?
Yes.
See this? This anterior, see my limit all the way.
Yes, sir.
Temporalis fascia. Can you see?
Yes.
I have taken this cartilage. This is must. If you don't remove this cartilage, this is not going to be cured. Medial limit, anterior limit is the beginning of the parotid gland that you don't have to go. Okay?
Yes, sir. Fine.
Satish,
Yeah.
hello? Sometimes you have
Only fast, please.
I can't hear you, sir.
Cellulitis, and there is a lot of spread in the preauricular region.
Yeah.
Hello?
Yes, sir. Hello. मेरे को दे सूचना. Hello. Hello.
This sort of preauricular signs.
Sir, I can't hear you. Your voice is breaking.
It's only spread.
Can somebody tell him?
Change your setting the net.
Now see the closure. How to cover the dead space. See this?
Yeah.
Yes, sir. Yes.
Simplest, what I do, see my suture, I'll take mattress. I will take the base.
Okay. Centralized, please. Centralized.
Yes.
Now,
See, the issue is there should not be any dead space.
Yes, sir.
Dead space will spoil everything. See, the suture has come through the base.
Dr. Akansha from Mumbai asking, is there any kind of a deformity chances after this?
Not really. It heals up faster. Practically doesn't give. Chhodna. See now, what I am doing, my suture is to the base. See this?
Yes, sir.
So this is to cover up the dead space. Yes. Okay, double. Yeah, this first suture is very important as my skin flap will remain in contact with the base.
This prevents chance of necrosis and it heals very well. And even
there will be no dead space.
The skin crease in front of the helix will be preserved well.
Shoulder. See now?
Yes, sir. Yes.
Now there is no dead space. See this. See this. This has come.
Yes,
I take such 3 sutures and then regular one. With the dressing, बाद में बात करें.
Yes.
See now again to the base. See this? Simple. Just to take the base in contact. See this base? I hope you got it what I'm trying to say.
Yes, sir. Yes, sir.
Wonderful idea.
Satish,
Yeah.
can you hear me?
Hello.
Hello. I was asking that sometimes there is this kind of a preauricular sinus.
Pardon?
The charge is coming out and the child rubs that area. So there is a.
Sir, your voice is breaking. I didn't get your question.
Hello.
Yes, now.
You have a larger area which is inflamed.
Yeah, on the other side. You will see on the other side.
So that would you follow the same thing or would you ask?
No, we'll make two separate. We'll make two separate incisions. Arey, hurt yaar. Tu laga.
And you'll wait for some.
We'll make two separate incisions and connect them. I'll show that.
Sir, will you wait for the cellulitis to go away, then you will operate, or you?
Yes, you have to control the active infection. Simple.
Yes.
You are not supposed to, operate in the active infection. You can use this if there is some abscess, incision drainage. Give some antibiotic, and then after 5-7 days you can take up. Mild inflammation is no contraindication. That will give you opportunity to identify your tract much better, rather than a dry condition. See, this much of the area we cleared. Nobody can trace each and every duct over here. Impossible.
So there are two main steps. One is the excision of the cartilage, and other is the temporalis fascia plane.
Yes, and the posterior limit is the cartilage.
Yes.
Anterior deeper limit is the temporalis fascia.
Yes.
Anterior and inferiorly the parotid gland.
Carotid. Okay. Yes.
And there is no important structure in this region.
Yes.
Yes, sir. That is the main.
See this now. This is radical clearance.
Yes, sir.
And see, there is no dead space.
Yes.
That this dressing, this will be okay like this. So they laga dega udhar kar. Now I'll go to the opposite side. That is the abscess which burst beyond the sinus.
Okay.
So if there is a pus or abscess, can we drain it at the same time and do the repair, or we have to drain it then?
Better you drain. If there is abscess, you drain first. Then after 5-7 days, you can come.
Okay.
Yes. Now, see that. Are you getting the picture?
Yes, sir. Yes.
This patient's abscess we drained 2 weeks back. See this.
We are not getting picture.
Not getting?
No microscopic picture.
We're seeing a CT scan.
This knife se kaat na ball. Hello.
Yes, sir.
Yes. We are getting now.
Getting now?
Yeah.
Sir, Dr. Girish is asking, do we need to give any pressure dressing over this?
Yes, we will.
Sir, please show how to give.
Yeah, the simple regular dressing. See, we'll keep 1 or 2 gauge balls and then press with the dressing. Okay. See, now the skin is in contact with the deeper surface. We have put 3, stitches involving the deeper surface. And now see here. This is the surface. See?
Yes, sir.
And this is the track which burst there. See how far off. How far off it is, right?
Yes, sir.
We will make 2 incisions, In case, suppose this area is completely inflamed and this skin to be excised. This part of the skin I have to excise. This is gone. In case this area is broader, I can rotate the scalp flap. I can rotate the superiorly based scalp flap and cover whatever skin it is. Even if it is 2 centimeter, 3 centimeter, I can rotate the scalp flap from anteriorly. So here I don't think it is required, but this is a classical example of type 3 kind of a. See here?
Yes, sir.
This is the primary sinus. I will go supraauricular. And this we will take separately. Is this 2 separate?
Yes, sir.
Now to uncover and remove the tract thoroughly, what I can do, simple. What I will do here, see now, the whole area will open up. Could you see the incisions?
Yes, sir.
Now first, number 1. I hope that
very clear, sir. Picture is very clear.
here our aim to go supraauricular is to go to the plane of temporalis fascia. Ajay kahan hai?
So please center the picture with lower.
Yes.
Yes. Now it's focus.
इधर लेंगे वो वेगल वेगल फॉक्स को बुला ले see this blue.
Yes, yes.
This is our cartilage. See, I have divided the cartilage. This one. See, this is my cartilage.
Yes,
yes, sir. Yes.
Hello. See, I have taken the cartilage in the specific.
Dr. Satish. Hello.
Yes, sir. Please.
At what point do you divide the cartilage? Is there a specific area or? Hello.
Yes, sir. Please.
At what point do you divide the cartilage?
At the site of the fistula. See, this is the fistula.
Okay.
At the site of the fistula here.
Okay.
And see, this tract is so close. See, in the recent histological so many publications, this tract is found to be microns in the vicinity of the few microns.
Doctor, repeat it again. Repeat it with some volume.
This tract is in close vicinity of the cartilage. See, I have taken this cartilage. See this?
Yes, sir. Yes.
See, now it is absolutely free. And here, this tract is in close proximity to the cartilage. Can you see?
Yeah.
This one, see blue.
Yes, we can see.
If I don't remove this cartilage, I leave the remnants behind. Very simple. Now this is my temporalis fascia plane.
Sir, Dr. Mohan from Bangalore is asking what will be the plan in case of the recurrence.
Doctor, who is?
Mohan from Bangalore.
Yeah, what's the question?
Sir, if there is recurrence, what is the plan?
Same. You have something left behind. See my temporalis fascia plane, so simple.
Yes.
Gives us full assurance that, see this fascia plane, all around. If you stay in this plane,
No chance of recurrence.
no chance. See this, what a plane.
Yes, sir, very neat.
Okay, this is such a rewarding thing if you do properly.
Yes.
Now see, this incision, I have to, now see this incision I made. This bridging incision I have made to save this skin.
So this skin is very important to save, I think. This.
For the closure.
Yeah.
See, variety of there are congenital sinuses and fistula. These are very rewarding if taken care of properly. Now,
Colorado needle is man of the match.
Yeah, this is the man of the match. Without this, it is not possible. In the sense, there will be a lot of bleeding. You keep on, cauterizing, and then you will miss your plane easily.
The first time ever I have seen the use of this needle in this case.
This is man of the match for this case. See now this tissue, see fistula was here, sinus was here, yes, and it has burst there. So there is continuity of the infected material, continuity of the tract, which you have to take out in continuity. तू लगा
Centralized, please.
Yes.
We are using this needle in our implant cases, flap, elevation, etc. It's worked very well.
Pardon?
We are using in the implant now. This needle.
Yeah, you can use it anywhere. Kar. This is good thing. The issue is you have to stay in the right plane.
Of course.
Not come out. Then only this patient will be cured. See, it has to come out and block.
Yes, sir.
Yes.
Block. Now I am on the parotid fascia anteriorly. Don't worry about the facial now. Facial now doesn't pass on the parotid surface. It passes
temporal
to the
branch. How far is the temporal branch here?
Branch?
Where is the temporal branch of facial nerve?
Yeah, that is deeper. That is deeper. I am quite posterior. That is quite anterior. I will show you the position. See how superficial.
Yes.
See the same fascia plane.
Yes, sir.
The branches of the temporal artery as you go anteriorly here. No issues. Or pakad.
Center. Sir, please centralize.
Yes. See now. See this fistula here and the sinus there. See this all infected granulation tissue. This was the fistula here behind and this was the sinus there. And everything has come out in continuity. And my plane is same fascia plane.
Do you send it for histopath also, this?
Pardon?
Yeah, for histopath, this issue, this.
What?
Yeah, histopath. Do you send it for histopath?
Histopath, yes. Histopath is a protocol. We are going to do. So now, we will do a little bit of both incision. It will be primary close easily.
Yes.
So what I will do now, undermining. For a centimeter, you pakadna. These are very rewarding regions, you know. A small mistake can lead to recurrence.
Like these small cases which you do in these webinars, like snacks between the meals.
So all these are, undermining. So now one can easily close them. So isko suture this, and then finally we'll put in like this. Okay?
Yes, sir. Wonderful.
See, 2 lines of stitches. That's it. You have already seen. This is radical clearance. This is type 3 sinus. The first was a type 1, simplest. Second was a 6 sinus infection. And type 3 is bursting somewhere far off. Sometimes area is too much of infected and lot of openings on the skin with the entire skin gone. And what you can do, what I was telling you, the superiorly based flap, what you do beyond this, see this is zygoma here, see this?
Yes.
Zygoma here entirely, a centimeter more. Here the facial nerve temporal branch crosses. Go make a horizontal incision and vertical above the this thing, hairline, like this. Above the hairline, what you can do, go 1 centimeter anterior above the hairline and elevate this entire thing and pull it behind. Here, that will be primary closure and you can shift almost 2 centimeter of skin behind easily. Yeah. I hope you got what I'm trying to say. Yeah, 3-pointer. Yeah. So now we'll close it and this will be done. Any questions?
No, sir, I think you have answered all.
You have demonstrated in such a beautiful way.
Yeah, everything is.
There's hardly any question from anyone.
Sir, Dr. Prakash Munka is asking.
Yeah.
Hello. If you don't have this needle, any other jugaad.
Hello.
Hello.
Yes.
Sir, Dr. Prakash Munka is asking if you don't have this needle, any other jugaad.
See, cautery is too crude. Cautery is too crude for this. You need a fine tool which helps you identifying the tract everywhere, the blue line tract.
Yes, sir.
There cannot be any better tool. If you use knife, the intermittent bleeding will not allow you. You'll just keep on, taking care of the bleeders, and you'll misdirected from your original job.
Sir, I think for the PGs, if in their instrument Viva, they can tell one more use of this Colorado needle in pre-auricular
Colorado is very important. We have variety of Colorado needles, Variety. Variety means for the nose is a different variety, endonasal. Like if you are raising endonasal flap, if I am raising a Haddad flap and want that, is a different endonasal needle.
Yes, yes, okay.
There are a variety of Colorado needle, long, short, fine, curved, right curved, left curved, up curved. Many times we use for the dura. Because dura bleeds a lot otherwise.
Okay, okay.
Sometimes. Intracranial space
DCR flaps, they're wonderful.
is a good site for the Colorado to use many a times. See, in no time it will be closed like anything. Are you watching?
No, sir.
Hello?
Yeah,
Yes, yes, sir.
Are you getting the picture?
Not getting it. No, sir, we are not getting anything.
Why are you not transmitting? Just show them once.
Now it's there.
Now?
Yes,
Yes,
yes.
sir. Now it's there.
Now this initial incision which you elevate, this horizontal flap, this flap, vertical flap, see this. The flap which is connecting both the incisions is the thing.
What is the suture material you are using?
Hello, tu laga dena stitch.
The suture material which you are using in this?
Pardon?
The
Suture material I am using Vicryl here. See, the material which you want to use should be a strong one and should be absorbable. Because when you remove the suture, it is something which may give way. Because you are putting all mattress sutures. Leave it. This is Vicryl and cut short and leave it. You need a strong suture, absorbable. You can use monofilament, that is better than Vicryl, monocryl. Hello, Mubarak.
Good evening, boss.
Hello, good evening.
Hello, Mubarak, sir. Good evening.
Welcome.
सर थोड़ी देर से ज्वाइन हो गया हूँ क्या खत्म हुआ मालूम नहीं
क्या नाम उसका नेक्स्ट का समा ना
Only half has been done.
Okay. The untiring man called Satish.
Hello. So, Mubarak, our next case, quickly, is already started, the flap is elevated. I am going to go for 5 minutes for the rest of the work inside.
Yes.
That laser work or whatever. And then we'll take a vagal paraganglioma. Can I ask a question here?
Yes.
For endoscopic stepidotomy.
Yes, sir.
I know you are endoscopic person. Any particular advantage or disadvantage?
Trying to be.
So, any particular advantage and disadvantage for everyone?
Endoscopic step is definitely it has got the advantage, at least for me, because I do it with the 2 hands. And when you use a 3mm endoscope.
Okay, you will use with that just attach.
Yes, exactly. Just attach and exclusive endoscope holder. Now we have developed that exclusive endoscope holder. We don't need a microscope also.
Okay, let me tell everyone so that they can understand. There are 2 approaches. One is you hold the endoscope in one hand and your other hand operates with the instrument. That is something like we operate in the nose. What Barak does, he has developed an endoscopic holder. He has gifted me as well. I am so grateful to him. So that by that you can attach to your microscope. And the endoscope will go inside or over the canal. So now you are both hands free. Okay? Yes. You must be putting that stitch also, Tarabichi stitch.
Perfect, yes.
To keep the canal straight.
Yes, because that gives a straight canal and additional 1mm, because that space constraint is really there. But using 3mm endoscope and then using that Tarabishi stitch gives me another 3mm in and around the endoscope. So
endoscope will go inside and you will look at the monitor and operate.
Right. So
is Ashim there? Is Ashim there? Hello?
Yes, I am there, boss.
Boss, सुन लो what Mubarak is saying.
Ashim boss, good evening.
Good evening, Mubarak. How are you?
I'm fine.
So he is using just attached, keeping his both hands free. That is different from a regular endoscopic.
Correct.
Now,
yes,
now go ahead.
You get then the rest thing is what Satish does with his two hands. So you have to do getting that panoramic view of the endoscope and the two hands. So it becomes a lot easy. Okay, and based on my this Just Attach and the exclusive endoscope holder, just now the European, I think Professor Sturter and all, they have developed the robotic arm for the endoscopic ear surgery. Based on that, so it moves, that robotic arm moves in the ear, and they are using the two hands to do the things. Okay, that is the last paper. Just
okay, let's talk
published
about the stapes.
Yes, so in the stapes, what you get is one is a panoramic view, and another thing is that transcanal you can do it nicely, and whatever posterior superior canal overhang is there, you did not to take out that much of the overhang in case of the endoscope.
That is one advantage. Yes.
And if you use a 30-degree endoscope, then life is too easy to visualize the retrotympanum. Okay.
But what about the depth?
Yes, depth perception is the one problem what the single-handed endoscopic ears talk about. But here, with the endoscope holder, we overcome the depth perception by moving in and out. So
both hands, using both hands, using both hands.
We are using both hands, and the endoscope is mobile. Okay, when you are moving the microscope, it goes in and out. So you can overcome that depth perception. That's not a big problem. Only concern they raise is when you put the endoscope static in the ear, the temperature is raised. That is what they have claimed. But in case of the two-handed endoscopic ear surgery, that's not a problem because my left hand is holding the suction. So those vapors are actually getting sucked out. So I need not to be worried about that temperature. But
so how it controls the temperature?
It's with the suction because the left hand is with the is holding the suction. So whatever vapors are which are generated there, so it is sucking out completely. And intermittent irrigation with the normal saline, okay, that takes care of the heat issue. Being two-handed, so you can move it endoscope in and out. That's not a problem. And up till now, I have not seen any heat issue. Almost not a stapes, but I must have done thousands of other ear surgeries, but I have not seen any of problem like a cornea burning or any other things.
Ashim,
yeah.
What I believe out of his approach, the endoscopic stapedotomy, Tarabichi also talked about it. What I see distinct advantage, to be very open. One is the overhang, that you don't need to remove that much overhang. And second is what I believe, you get a panoramic view of the foot plate, like you can see anterior crust better.
Perfect.
Yeah.
Rest, the experience of the depth and all that, I don't know.
Boss, how do you use a micromanipulator? That's my biggest
problem. What you have not seen it.
I do a traditional way because I don't have any experience of laser. That you need to work it out because
that you cannot use laser with that. You can use laser.
Yeah. No, I think the fundamental advantage of the endoscope is when you have to drill out the anterior crust. That's a very good advantage. There's no doubt on that.
You can come from in front here.
Yeah, you can come from the front and you can drill out the anterior crust under vision, which otherwise is a blind procedure. But
see, most of the time,
of the chorda.
I tell you, out of 1,000 stapes, how many times you find problem with the anterior crust being thick or honestly?
Less than 10%.
10?
Less than 10%. I would say 5% also.
Yeah, even that is, it looks too much. For the anterior crust to be so problematic or thick.
5 out of 100 or maybe 3 out of 100.
Yes, so the incidence is so less. Anterior crust is so fragile. Almost always we break it towards the promontory and it doesn't give problem. It is not like posterior crust which is so stout.
Yes.
And one more advantage what I get is while doing the reverse fish. Okay, so I get an advantage to visualize that foot plate very nicely. When I take my endoscope very near, so I can visualize that whole foot plate directly on my
you can overcome the overcrowding.
Yes, you can overcome that. And I use a digital zooming a lot when I'm doing these steppies. So I need not to take that endoscope too near to the to the bony annulus. So you can keep it at the isthmus level and just zoom it, because you have got almost 3 to 4x zooming in the digital in your camera. So
see, the only issue is operating under microscope with a binocular vision. On the other hand, operating with the endoscope with a monocular vision, looking at the monitor. This is the basic difference.
Yes.
Either you have to get used to it.
Yes.
This is something you need to get used to. Otherwise, it is difficult.
Because I told you that robotic scope is going to be there. It's completely a virtual 3D. So it's actually exoscope, and you will be putting the lens in front of you, and you are not looking at the monitor and all. Everything is happening in your eyes. Okay.
Another fun way of spending $1 crore.
And that's a virtual reality. You move the head, so your exoscope will move, and you will visualize. If you want to see like this, just turn around, and you can look into the retro department like that. Okay. I just mentioned you a few days back.
Great. So, Munjal sir, any experience of endoscopic surgery? You like it? Munjal sir, are you doing endoscopic? Anything in otology?
Manish?
But many people have started doing it, and thanks. Credit goes to Mubarak for this thing.
I do believe that endoscope is it has to be part of your armamentarium for sure.
Yeah.
No, your operation table setup is not complete without an endoscope. I'm very sure. So it is
but
not.
The microscopic training is must.
It is not one versus the other. It's one with the other. Both are tools for you to use in your appropriate scenario.
Yes, you are right, but I recommend that the microscopic training should be thorough. Okay?
I say both should be thorough.
Like a laparoscopic surgeon. ओपन करना पड़े तो माइक्रोस्कोप इस्तेमाल करना आना चाहिए. So that is the.
You must practice with the endoscope, and for those people who are starting, I'm saying use the endoscope regularly in your cholecystoma work to look at the sinus tympani, look at the facial recess, look into the attic. Start using it, get your hand moving.
That's
I will always recommend that.
Yes.
It's not a primary modality. I'm still a two-handed surgeon with the microscope. And, but it's a must. Endoscope should be used from time to time. Absolutely.
Yes, that's a perfect advice.
Using endoscope in OPD now. That is a good starting. Many people are using endoscopes for the ear examination in OPD. That is a good starting.
No. In OT also, look at the sinus tympani and all. You're doing cholecystoma work. Switch over from microscope to endoscope so that you can see, you can correlate the two views and try and understand how the anatomy works with the microscope as well as the endoscope. That's my advice to people who are starting.
Difficulty is
people who want to start, get started using endoscope to do wax removal in the ear. Get started from there.
Yeah, that's good. That's good. That's why OPD they are using it and they are getting acclimatized. That is the first point.
It's a must. It's a must.
Udbhav, any question related to preauricular?
No, boss.
You have answered all the questions. There are only congratulation messages, so I just nothing else.
Oh, so our next case is this is already started. The flap is raised. I think it's curating. Where I am going to go quickly. As I told you, we are not going to show flap again and again for the stapes, so we can show more in less time. So this is again a same case for exploration with a conductive hearing loss, bilateral. Girl, 23-year-old, and the next case we are taking is a vagal paraganglioma. The vagal paraganglioma is unique in the sense it pushes the carotid anteriorly, laterally, or anteriorly means you will first come across the carotid and the deep will be the tumor because the vagus is deep to it. So this is a different tumor from carotid body. So can I show this quickly? This stapes. As we discussed in the last case, I'll just touch upon the positive findings or the issues related to stapes, what to be seen on CT scan. Only related to stapes. First of all, superior canal. Can you see? Quickly, quickly see the superior canal in the coronal one. See this? This is the level of the round window. This is the level of the vestibule. This is superior canal. And if I follow it all the way, all the way, all the way, there is no dissonance. See this?
Yes. Yeah. Thick bone all around.
Absolutely. See the intra-auditory meatus, absolutely normal. So first rule out any inner ear abnormality which can complicate your case. Just quickly. So this is intra-auditory meatus. The vestibule is normal in size. The vestibular aqueduct is normal. Even the lateral canal, all semicircular canals normal. This is facial now. And then this is cochlea, the cochlear aperture. This communication with the intra-auditory meatus is a problem of gusher in stapes. No other thing gives gusher. Then the cochlea, and this is cochlear aqueduct. See this one. This one is cochlear aqueduct. And about the facial now, the most important thing. This is horizontal facial.
Yes, and we can see.
This is vertical. This is horizontal. And this is our vestibule. See the stapedial arch here?
Yes.
This is incus, this is malleus. And see how they are in continuity. Incus and stapes. See this? And the incus and the malleus. Now the malleus anteriorly has no bony fixation. What I want to see two things more in the coronal. Any fixation of the malleus in the atic. See this malleus and see the atic far off.
Yes. Yes, sir.
So no fixation, no lateral fixation of the malleus. The ligaments are good. And lastly, and the most important thing is the facial now. The facial prolapsing or occupying the oval window. See the oval window where the stapes is going. See the stapes is going and the facial is much above.
Yes, sir.
It is not coming in below onto the oval window. So all these things are to be seen. This is your, jugular bulb. This is your cochlea. The cochlea, this is your jugular bulb, much below. That's a carotid artery. See, going there. This is jugular bulb. This is jugular bulb. And what we need to see in relation to the round window. This is far off, far off. Jugular bulb is quite below. So by and large, the dimension of the facial is also normal. The, this foramen ovale and spinosum normal. Yes, so there is no question of any other abnormality, no third window lesion. The carotid is also good with no communication to the cochlea. See this? So no third window lesion, inner ear is normal, ossicular chain looks normal, the facial is normal, no overhang. And this is a small foci, if you see carefully. This is a small foci, that is otosclerosis here.
Yes, sir, very nice.
Fistula antefenestrum, see this.
Classic fenestral otosclerosis.
See this hypodense area, small hypodense area, if you can appreciate.
Yes, sir, clearly seen.
Clearly seen, and this is the stapes. This is the stapes. Let's see, the only concern. The vestibule is normal, absolutely normal. So hope so. Last case, we had a little abnormal incus which was not bothering, little short incus, not an issue. The oval window height was less and the facial was bulging from above. Every case is little different, and CT prevents you from getting intraoperative surprises. That is the advantage. Sir, anything you want to add on? Mishra sir, you want to see additionally anything in stapes?
Unmute also, sir.
Sir, unmute. Unmute.
Yeah.
Mute.
Hello. Yeah. You have shown most of the parts that you need to see on the CT scan, like the concerns like cushion, overhang, thick foot plate, or any area where there is a weak point or the area of otosclerosis. All have been covered nicely. So I don't think anything else remains to be covered. Fixation of malleus.
Yes.
message for all that you recommend CT scan for all the steppies case or for the selective case.
All.
And
By
0.5
default.
mm cut is the must, or at
All
least.
steppies, CT scan, all steppies titanium piston by default.
And 0.5 mm cut. Suppose 0.5 mm cuts are not available at some places, then minimum cut.
Then you will miss lot of things. See,
Many people,
if you want to see the oval window and steppies, and if that is missed in larger cuts, then what is the fun? And third thing by default, CT scan, titanium piston and laser.
Dr. Satish. Hello.
Yes, sir.
Yes, sir.
Is any time in your experience CT scan has been diagnostic for confirmation of autosclerosis, like
yes.
other investigations were misleading and it could say, okay, oh no, this is autosclerosis, because earlier we used to depend on the negative RNA and audiometry findings.
The least role of CT scan is in diagnosis of autosclerosis. Least role.
Okay. Yeah. This is only to find abnormalities which could.
Yes. It is to rule out problems which can complicate. वो ले लिया वेगल. ले ले उसको induce करा दे. To rule out the things which can complicate your surgical course.
Satish boss.
To rule out any surprise diagnosis. Yes.
Yes.
What's your criteria for single hearing ear, and how do you counsel if at all you are operating only hearing ear?
Only hearing ear, the counseling has changed now, because you can rehabilitate majority of the only hearing ears now.
Okay.
So this was answered best by Ashish last time, if you remember. Now, since you can rehabilitate the ear, why we were not operating on the only hearing ears earlier? Because the patient may lose the hearing both sides in case the SNHL develops. Now, in this era of cochlear implantation, you have, ways to rehabilitate the hearing.
Okay.
Are you getting the picture?
Yeah, wonderful.
Perfect. Clear.
Say this. So first of all, see the mobility.
Yeah.
Yes.
I am focusing on the foot plate now.
How much is the ideal removal of overhang?
Yes. Overhang?
The full face. Yeah.
Yes, see now. I mentioned.
You is that you should see the long process. You should see the base of the pyramidal process. You should not see the body of the incus.
Yes.
You should see the anterior ligament. And you should see the part of the facial nerve.
See this in
ideal.
malleoinguinal joint, inferior part.
Yes.
That is seen. Posteriorly, like Ashim said, you should be able to see the pyramid, you should be able to see the facial canal. The reason is, for maneuvering your piston, you need space. It is not that this is mandatory. Like Mubarak was saying, in endoscopic surgery, if you are doing with endoscope, you don't need to remove overhang. Because you have a panoramic view, you don't need a lot of space to maneuver your instrument when you are coming with endoscope. Now see, this is the level. This is the level of the IS joint.
Yeah.
I am opening the joint here. Last case I had shown through the joint knife. This is to the pick. See this?
Yes.
I have opened up the
This
joint.
is very important step that Satish has done, and that is he has opened it in the axis of the stapedius. It is not from left to right. It is in the axis of the stapedius.
Yeah.
So that lateral movements can dislocate the stapes. Anteroposterior movements can.
Now, looking at the overcrowding here, I cannot do a, reverse stepidotomy.
Yes.
See, with laser, what I am trying to say, the comfort level. First, I will rehearsal.
Yes, that one shot is perfect.
This laser cannot be attached to the endoscopic system.
Yes, that needs to be find out certain things for that.
Next time you will understood.
Mubarak, you can use the wave fiber. You can use the wave fiber.
Okay, okay.
But the problem with the wave fiber is that the power delivery is not guaranteed, depending on the number, because they use it only once. It's it's guaranteed for the first shot only.
Let me try that on the ship head.
Center, please, center.
Yeah. I am trying to find my laser beam.
Mubarak can come
Gola.
with
नहीं बना गोला. Gola. हाँ. Now. Can you see my laser beam now?
Yes. Picture to
in the center.
little bit centralized, yeah.
Yeah, just a minute.
So what's the magnification at present?
9.
It is. कितना है?
It's a zoom microscope, so difficult to say.
I can't see from here. I can't see from here because this is a zoom microscope, no?
Okay.
Now see my laser beam.
Yes.
Yes.
On tendon, it is just for rehearsal. I told you. Tendon is just for rehearsal that my beam is in alignment. That's it.
Gone. Yes.
Now posterior crus. See that? See, it is weakened. Can you see?
Yes.
Hollowed out. Now, once it is weakened, I can quickly break it. See this? How easily I can break it. See that?
Right. Yes. Very nice.
Yes.
And the posterior anterior crus rarely gives
Little
problem.
bit centralized. Can you centralize little bit? Yeah.
Yes.
Yes. That's nice.
Anterior crus is broken easily.
Beautiful.
See this?
Perfect.
Forceps.
Yes.
And now I will remove this and see my foot plate. See that?
Already small
Yes.
fenestra is made or what?
No, not fenestra. It was just a beam.
Bubble. Okay.
Yeah. When I was
I think
shining.
Mucosa.
no. Yeah. It was actually
Yeah,
patla.
it is made.
When I was firing at the posterior crus.
Posterior crus. Yes.
Since it was far off from that, so energy was not going to that level. See this plate?
Yes.
Now my area of fenestra. Give me the measuring rod. Measuring. Just a minute. This looks greater than the previous one to me.
More deep.
Previous one was 4.25. One less. Yes, now 4.25, same. See the same size? Now last two shots, one shot fenestra, another shot piston, and it is done.
Yes.
Oh, next, can I induce?
Boss, you are doing so much
Wiggle.
of steppies with this piston. What's the difference? How much difference you have noticed in your cases
Ore,
from
boss.
the Teflon?
Raat or din.
Raat or din, oh, perfect. And in terms of hearing, in terms of
Yes, everything. In terms of sense of security, in terms of need of revision. See, it is you can say it is a sort of luxury.
Okay.
See my fenestra?
Yes.
In the lower part section. Lower part in the center. See this?
Yeah.
Yes.
Ready? See now, finished.
Yeah.
Pick the. We'll remove this.
Chapter closed.
Yes, perfect.
See this? So simple.
Yes, this is the beauty of that laser.
Without mobilizing anything.
Anything, right?
Even if it was mobilized, the laser would still work beautifully.
Yeah.
Yeah, and
Section patla, 24. Yeah, and the piston first.
You are widening this fenestra with what?
Yeah, see, it is not widening. It is a chairing at the margin,
Okay.
Making the margin little irregular. So I make it regular. That's it. This is not widening exactly. But that shot from the laser was so calculated. It will make the size of fenestra what we want. See this? Now completely full of perilymph.
Beautiful. I can see very beautiful, nice fenestra.
One more point
The
over
bubble
here.
of perilymph is not broken. Very important that the bubble of perilymph should not break.
Yes.
Okay.
Now lastly, video game again to piston. See the beauty of the piston. It is so simple to apply.
It's in your hand. Satish,
No,
it's so simple. I know because I even.
No, it is really simple in sense because you don't have to crimp.
Yeah, that is one advantage. But putting it very precisely at one point, so it's a calculated pressure, okay, and that force in your hand. That is what matters for that.
Yeah, that comes with time, obviously.
Yes, and
I remember in one stapage webinar, someone asked Ashish sir if you have a floating plate, what to do. He told, send the patient to one having CO2 laser, do nothing.
See that?
nice,
Very
nice.
No, I have a doubt about the size.
Yes, little bit size, yeah.
Let me check. It is well in the fenestra. Yes, right.
Yes.
Perfect, boss, perfect.
See now, what you have to do is just push gently.
Right.
Yes, that is
the calculated force.
yes, yeah, that is calculated one. That's the only
Yeah,
thing.
because that is very calculated. Very nice, beautiful.
One more point is that while doing suction at space, try to use good quality suction tips. If you use a local one, then it just move around and sometimes it put on the foot plate and then the hole.
See, boss, your hanging test. So
Yes,
bending. I can't bend it, but I can feel it.
Yes.
No, it's but you cannot bend it. But can you hang it?
Yes. Now see.
Yes.
Perfect, perfect. Wow.
Blood.
It fits so nicely and snugly. It looks like so simple, but believe me, it's not simple.
See, it doesn't take more than 5 minutes once canal is opened.
The problem with Satish is makes everything look simple.
Yes.
It is. That's why we are here. That anybody can do it. And believe me, this laser and piston makes a difference. This piston makes your life so easy. I told you several times. We cannot be Ashim. He uses 2 hands. I don't know how a human being can do that. 2 hands through this transcanal opening to crimp the piston. That is not possible. That is really difficult.
Yeah.
Boss, you can do it if you want.
Dr. Ashim,
Yes, sir.
why have you not developed the taste for titanium till now?
No, he uses.
I have to do titanium.
He uses.
No, he used
I use
Teflon for
Teflon, I use titanium, I use case to case.
Okay.
But honestly, I find Teflon equally good. But in certain cases, when there's a lot of facial nerve overhang,
That is in your hand, boss. Boss, that is in your hand.
Asim boss, you have any video right now? Just show us because so many things.
Yes. Because that crimping is a really tricky thing.
See now, this blood in the oval window.
Yeah.
That's it.
Yeah.
that finds a form fibrillary seal.
बंद कर देना.
Always prefer to put a drop of blood in the oval window.
Yes. Ayub will close it. Thank you.
Fantastic.
So now our next case is a vagal paraganglioma. इधर ऑन करो ये. हेलो.
Yeah, boss.
इसका वॉल्यूम बढ़ा ना. वो चाय मंगा. Hello.
Yeah, boss.
Yes, sir.
Yeah, two things to see from Hashim. How he uses vein graft. He told last time.
Yes, I have seen that. Yeah.
I follow his technique. He will use the wrist vein, the inside out, the the intima facing outwards. He'll apply on the fenestra after denuding the oval window, and then use the piston. And his technique is superb in the sense he has been doing this for years together. I told you, this guy is monster, done more than 6,000 stps.
Yes.
So that is consistently he's getting results. So there is no question over something which is to be doubted or which is not to be followed. This is something like a dictum. What he's doing in his stps, we follow it.
No, boss, whatever you're doing is perfect. It's really, there's nothing to doubt about what you're doing. It's absolutely fantastic. We have our own philosophy regarding vein. That's a different story.
It is institute. So, Udbhav, any questions? You can direct to Hashim.
Sir, everything has been answered. We have a full stapes webinar now, 2 cases, everything completely covered.
I am keeping this time, every time if we get some variety. What we'll do like this, we'll keep the flap elevated and curated, overhang curated so that it will not take time. In between like filler.
Dr. Satish.
Yes, sir.
This flap, tympanometer flap, inferior extent, it should be till 6 o'clock so that you expose
no need to go. No need to go till then, sir. Inferiorly, you are not supposed to go too inferiorly because that is not our area of interest.
Okay. In this case, round window is also exposed completely. So I thought that is.
Yeah, it was visible. It was like that. Anatomy was like that, but flap was same.
Okay.
Again, I was just talking about that crimping. That's also a skillful job, and I have seen Hashim and even Bhumkar boss, that doing that crimping. That's a perfect. That needs to be a very perfect, and that glitch is there. That's why this clip is. I find it very easy. But it's again a tough thing. Yeah.
Absolutely, the crimping is absolutely essential with the stapes. It has to precisely oppose. So what you need to do is take one needle here, take the other needle, bring it down, and then use a forceps. Not just a forceps, because the forceps, if the loop is there, the forceps tends to flatten it.
Under crimping and over crimping both are hazardous.
Both are
exactly. Yeah.
So it is not already. That's why this piston, anybody can use it simply. You don't have to apply your brain. Just push it. That's it.
I always remember with this anybody can dance now. Naam ka ek movie tha. Oh, it's not like that easy.
No, this piston is really.
That's called ABCD.
It really makes life easy.
We have seen one piston where half is the Teflon and upper one is the titanium. That is also very good because for the crimping part you can manage.
Yeah, but that is not a clip like this.
The problem those is that the two diverge.
Yes, that is not a clip like this.
Yeah, that is not a clip like this.
Yeah, this is different. This clip is made so calculated, the mouth of the clip, the spring is working in such a manner that you apply close to the incus, and according to the dimension of the clip, this clip is designed so the spring opens a little bit and the middle slot goes and takes up. So it holds tightly. Even a junior most guy can do it with the same efficiency what a senior most guy like Hashim is doing with the Teflon. That is the beauty. It is making the life simple.
That's true. No doubt.
That's the beauty of the tool. Same with the laser. Years back, it was almost 20 years back, I'd been trying to have some tool at these two steps, chrotomy and fenestration, that is always a sort of uncertainty that it may mobilize. You know, in spite of all drilling, micro drill, and your skeeter, whatever, the mechanical pressure is always, there is a possibility of transmission. Particularly if the footplate is not completely fixed. Now, whatsoever it is, 90% time you can go ahead with whatever tool you have. But what happens in case the footplate gets mobilized, you are gone. Now you are left with no option but to place a fascia and put a piston. You have to compromise. This laser gives you a sense of security. That's the only reason. You are always secure that nothing is going to happen, such sort of thing. That's it. And Ashim is using now.
No, honestly, Satish, I am using laser with a hollow waveguide from 94 onwards. The Luxar lasers were the first laser in the world with a hollow waveguide with a CO2, semi-flexible. So since 1994, I've been using those. But unfortunately, the power delivery system was not precise till I rediscovered the luminous thanks to you. So about 7 years ago, you showed me the luminous. That's when I started using that.
And since then, he has been using regularly.
We need to share the contact details of the person from whom people have to buy this piston. Many people are asking where to buy, from whom to contact.
Give his email ID. That is best.
Okay.
Asim you use lots of this vein graft. And what's the experience in you can say AB gap? How much AB gap you can by using the vein graft? Does it affect the AB gap and outcome?
What differences?
In my hands, the wider, and it has been our experience that the wider the moving surface of the perilymph, the better the airborne gap closure. So we can virtually guarantee about a 5 decibel airborne gap in over 90% of cases because of the very wide moving area of the perilymph. So we're using a 0.4 piston, but the moving surface of the perilymph is 0.8 millimeters.
Yeah, that's good.
And we have shown in intraoperative audiometry, I think we discussed it in one of the webinars earlier, that with the intraoperative audiometry we've showed very meticulously from 1998 onwards. My father and me, we've been doing, we make a 0.5 hole, 0.4 piston, do an intraoperative audiogram. In the same patient, we widen the hole to a 0.6 hole, put a 0.5 piston.
Okay.
And in the same patient, make a 0.8 hole and then put a vein and a 0.4 piston, and we compare the audiograms on the same patient on the same day, and we've done that for almost 100 cases. And in all of these, we came to realize that using this vein gives us a maximum airborne gap closure.
Okay.
So we do.
Can I ask one thing?
And there have been three authors. One is Laske Rusli from Switzerland. The second one is Saumil Merchant and Rosowski in the Harvard Institute, and the third one is in the Netherlands. All three have shown that the wider the orifice, the fenestra, the better the transmission. Sorry, Satish, you were saying something.
I have a question. Many want to know how to harvest the vein graft. If any video you have in the laptop.
Last time you showed
I had it right here.
I have a question.
You can see it whenever you want.
You bring your laptop in between, you show that. Now, I have a question. In your opinion, in terms of decibel, how is the difference in using 0.4 mm piston as compared to 0.6 mm what you are using? In terms of final gain.
I use the 0.4 mm piston only, but the 0.8 mm fenestra.
Okay, 0.8 mm fenestra, 0.6 mm fenestra. How much is going to be overall difference in terms of?
Overall difference about between 5 and 10 decibels.
5 decibel.
Yeah, 5 decibels.
And what about the higher tones? Higher tones?
That's exactly at the higher tones where you get the maximum difference. And that is where discrimination comes into play. Because see, at the end of the day, what you want is not just a change in the audiogram. You want a meaningful change in discrimination also.
Yes.
And that is why we also recommend trying to save the stapedius in as many cases as you can. Because we have seen discrimination improving where the stapedius has been saved. That is anecdotal. I don't have complete data.
No, but how do you save?
I can show you in 5 out of 10 cases I can save it.
No, but how do you save intraoperatively?
Intraoperatively, what I need to do is I use a right angle needle in the same way as you dissected the IS joint, but I take it from inferiorly to the stapedius. As long as the stapedius is attached to the capsule, it can be saved. If the stapedius is attached lower down to the capsule, it cannot be saved. Obviously,
you separate from the attachment. You separate the attachment to the neck of the stapedius.
Yeah. See, now there are two places. The stapedius either attaches to the neck or the capsule of the joint. If it is attached to the neck, there is no way you can save it. Then you need to preserve the maximum length and reconstruct it using a piece of vein wrapped around it. And then wrapping it on the edge of the piston. Now, otherwise, see all of this. In 5 out of 10 cases, you cannot save it in any way. Because sometimes you have a very short stapedius, sometimes you have a very ossified stapedius, sometimes it's very, very pulled back posteriorly. In all such cases, you cannot save it. But when you have a good long stapedial tendon, you should try and save it, is my suggestion.
In long tendons?
When the long tendon is there.
What are the long-term outcomes comparing this piston, means this clip piston with the Teflon versus Teflon or versus the longest means after 10 years, 20 years, whether early sensor in your...
There's no question of 20 years. They've not been there for 20 years. But in the 10 years, I have not had any higher incidence of sensory neural loss using either. Both are equal.
Okay.
Yes.
So no, not much difference in that time.
No.
That will be. So, yes. So, can you go ahead?
Yeah, please.
So, this patient, see this, I am starting from below. She has a right side lesion. She is a middle-aged lady. Now see, I am going up. Keep an eye on this jugular and this carotid artery.
Yeah.
I am going up, the carotid dividing into two. The external as well as internal. Okay? I am going up. See now, this is anterior, this is posterior. This is lateral, this is medial. What is happening? Going back. See, this is the vein. One by one. Keep an eye on the vein. Vein is completely compressed posteriorly, laterally. Okay? See, this vein is compressed laterally.
Yes.
If I come back, this is internal carotid, this is external. Now keep an eye as we go up. There is something coming up behind and pushing the carotids anteriorly. See?
Yes.
This is a different lesion. The external and internal are close to each other. Nothing is separating them at all. The lesion is behind both the carotids, which is pushing them anteriorly. Now see the internal here, how it is involved with the tumor. See? And the external, see how many branches it is giving. See all branches of external, huge. See all these branches going to the tumor.
Yes. 1, 2, 3.
Number of. Now see, this is the external going behind the mandible to divide into two. And this is the maxillary going there. Now if I come back, see this external. See this external coming back. Now see how many branches it had given. Huge one. See this huge branches. Yeah, coming here now, I will focus only on the external because all the branches are going to be from external. This is external now, don't focus on the internal, keep an eye on the external. See 2 branches given off here, you see here. 3 branches here. Now see yes. two more branches, now 2-3 branches here. Now these branches there, now again dividing into 3 branches here. And now this finally the external is going to go behind. See this. So it has given all these bunch of branches to this tumor. Internal never gives. And as we go up, right from the beginning, I will again go up. Now keep an eye on the internal. See how closely it is related to the tumor. This is our concern number 1. Concern number 1, to save the internal carotid to separate the tumor from the carotid. Then as we go, see at multiple places it is in contact with the tumor. See here. Though I don't think it is completely encased kind of a carotid here. And as I go up now, I am going in the carotid foramen. Yeah, this is carotid foramen. And this is carotid foramen. This is horizontal. Going up. Petrous going up. This is intracranial. This is anterior cerebral on both sides. And this is the posterior cerebral joining. Here, posterior cerebral joining here. It's a circle of Willis. It's a good collateral correlation, circulation. Now the most important thing to know, the height of the tumor, vertical height and proximity to the skull base. How proximal it is to the skull base. Now see this tumor. See this tumor, and what I will do, MIP setting. Yes. Now one by one you can see all structures. Oh, come on. Sorry. Yes. One by one. This is very important scan, the coronal one. Now this is the internal carotid, you see. Can you?
Yes, sir.
Now see the relationship. See the relationship, how it is going into the skull base. See this?
Yeah.
Completely. That is the internal carotid going to the skull base. Okay?
Yes, sir.
Here, this is the common carotid dividing into external, internal, external going there, outwards, and the internal going up. Now, another thing, as you see from behind, this is vertebral artery. See this?
Yeah.
Yes.
Going in the transverse process of all these vertebra. And here, as it comes out, it goes intracranial. So all the vessel, this is intracranial vertebral. This is where my cursor is. This is going to form the basilar.
Basilar.
See this? How it forms the basilar. And if I go back, you can see, you can trace it out to the extracranial compartment. And trace this all vertebral all the way. So now the next thing to be known is the vertical height of the tumor and distance from the skull base. See this?
Yes.
Let me change the intensity. Yes. Intensity. Yes. See this vertical height. This is important because if it is too high, approaching the skull base, it has an implication on our surgical approach. How's the picture?
You're fine.
Okay.
Is it good?
Yes, sir.
See, this is the tumor and it is roughly how many centimeters away? Skull base? 3.5, something like that. This is important because if it goes up, it may invade the jugular foramen and then you have to, choose a different approach like infratemporal A, like we use for the jugular tumors or something like that. If it is too high, not reaching the jugular foramen, you may have to do a mandibulotomy to expose it. So the vertical height dictates your approach. And see how the carotid is in relation. It is pressed anteromedially. See, the carotid has a medial turn. Pushed by the tumor. And many a time these tumors have a prominence in the oropharynx, pushing the tonsil medially. You will find in this parapharyngeal space, such tumors push the tonsil medially. Okay? And this is full of, flow voids. Now, if I show you MRI of this particular patient. See this. Can you see this tumor?
Yes, sir. Yes.
See the number of flow voids, the vessels into this tumor. Amazing vessels into this, that makes the diagnosis of a paraganglioma. This could be otherwise a vagal schwannoma as well. Why not vagal schwannoma? Because of these flow voids.
Flow voids.
And these vagal paraganglioma arise from the vagus nerve. In the peritoneum of the vagus nerve are the paraganglionic cells. At what level? At the level of nodose ganglion. Few centimeters below the jugular foramen where the vagus nerve runs. And in that nodose ganglion, inside the vagus nerve are the paraganglionic cells from where this tumor arises. So, sacrificing the vagus nerve is an inherent part of the procedure. It is inevitable.
In glomus jugulae also we saw the flow voids. In glomus jugulae.
Yeah, but there it doesn't involve the vagus.
Yes, yes.
Here it arises from the vagus. So, the sacrificing the vagus nerve is inevitable. It's part of the procedure. You cannot save the vagus nerve in a big tumor.
Yes, sir.
So this is the tumor and this is the carotid which is anteromedially. So now when we raise the flap, the carotid will be superficial. It is pushed anteromedially and the jugular is pushed posterolaterally. Because tumor is coming from behind. So you have to separate from the carotid. This is the party wall with the carotid. That we have to see how adherent it is. We saw in the previous paragangliomas, sometimes the carotid is so adherent.
Yes, sir, yes.
And it is so vascular. That is, I am sure, it is extremely vascular because this is just bunch of vessels. So what we'll do, in the beginning, we'll take the control of external carotid to minimize the bleeding. Then only we'll be able to separate it much better. So now exposure is the big key, as we have to go quite deep in the parapharyngeal space, and we'll have the same philosophy like we did in the carotid body. We'll expose superiorly first by dividing the digastric, preserve the hypoglossal, then we'll go up, if required, we'll divide the styloid process and the muscles attached to the styloid process, and that's how we'll keep going up. Okay?
How will you address sequelae of vagal nerve damage?
See, that is how this tumor decision making is done. In young patients, there are two philosophies. Some people believe that let it be until the vagus is paralyzed by the tumor itself, so that you will automatically develop compensation by then. Okay? This is one philosophy. Other philosophy is, if it is in young patient, remove it as early as possible. Don't allow it to become so large that removal of a large tumor will involve paralysis of the other nerves as well. It will make your life difficult by involving the carotid artery then.
Yeah.
Okay. So both philosophies are different. In young patient, even if you sacrifice this nerve, it compensates well, and you can then add on some thyroplasty and cricopharyngeal myotomy to rehabilitate those patients. But in that situation, when it is small, you can preserve the other cranial nerves much better. Bigger it is, difficult will be to separate from the carotid artery. The challenge is carotid, and not only carotid, the other cranial nerves. A single vagal nerve palsy will not produce that much of issue as compared to the compound lower cranial nerve palsy. And that is always a possibility when you deal with a larger tumor.
Many times these patients have post-operative profuse vomiting because the esophagus is also paralyzed due to the dominant vagus.
Dominant vagus?
Yeah, means earlier the motility of the esophagus will also be affected.
Yeah.
So they have a lot of vomiting in post-operative phase. Quite a few patients which I have seen in past.
Okay, that's great to know.
So you must have experienced that as well. I don't know.
Not really about the vomiting, sir. But as you are saying, we'll keep an eye next time.
Earlier, people used to use highly selective vagotomy for peptic ulcers. You know, the entire esophagus and stomach are supplied by vagus.
Yes,
if it is damaged at this level, there must be some changes there as well. Now that we have all those PPIs and all that available, this surgery is now become obsolete. Vagotomy, which used to be done in past.
Yeah.
Satish boss, what different approach you are going to take in this tumor?
Simple transcervical approach as usual.
Okay. I remember the case in Agra. I think you have done. I remember one case.
Huge one.
Huge one. Huh? You remember, Rajeev?
Of course.
Because it's at your center only, but it was huge. And I was just mesmerized to see that case, you know.
So, Dr. Satish, what are the symptoms of this case?
She had a swelling in the neck, fullness and pain on swallowing, that is vague symptom. Mostly they remain asymptomatic and present with the swelling. Sometime, because of the compression, they may come with dysphonia or dysphagia and all those symptoms of the cranial nerves. This being a young patient with already almost a 4 centimeter tumor. Now, you have two options. Either allow it to grow until the fetus is paralyzed on its own, because ultimately, eventually, this is going to get paralyzed. Or you do it now in the young age and rehabilitate. Both the options are there. So you have to give option to the patient to choose.
Okay.
Secondly, out of all paragangliomas, head and neck paragangliomas, vagal paragangliomas have highest chance of malignant conversion.
Okay.
15 to 20% convert to malignancy as compared to the carotid body and jugular. They have very less chances. So that is another hidden fact. This is natural fact that we need to keep in mind. If the tumor goes above 5 centimeter, the challenges posed, whatever it is going to give, is difficult to deal with. Challenges to carotid artery, challenges to skull base involvement. If skull base is involved, 5 centimeter tumor, difficult to preserve other cranial nerves. Then the chances of giving a compound cranial nerve palsy are more. Then if it involves the jugular foramen, you may have to, that infratemporal fossa approach, that will involve the facial nerve transposition. Then that also comes into problem.
Dr. Satish, we don't have surgery picture. We have this MRI picture.
Yeah. I just meantime washed up and I asked my associate to raise the flap. Just raise the flap. So he has raised the flap. I am going to join now.
Satish boss, any tumor markers as in diagnosis to diagnose it early?
Yes, there are many ways. The best is, I tell you, octreotide scintigraphy, because these patients have, octreotide, and that is very important, not only for diagnosis, correct diagnosis. If you have a doubt with this lesion in the neck, whether it is paraganglioma or not, get octreotide scintigraphy. That will tell you 100%, almost right, that whether it is paraganglioma or not. Number one. Number two, it will pick up if there are any other paraganglioma in the body anywhere.
Yes.
Third, has a role in the post-operative situation. If you have a doubt of the recurrence, the routine CT and MRI cannot effectively differentiate between a post-op fibrosis and the recurrence. But yes, octreotide will pick up, because octreotide will pick up because this tumor has a receptors, octreotide.
Yes.
So that is one thing one can, and these tumors are not uncommon to have multiple tumors, other paragangliomas and all that possibly is always there.
Yes.
Correct?
You asked for CT scan, then MRI and MRI angio.
CT angiogram.
CT angiogram in all the cases.
Any role of PET scan?
Not really. PET DOPA you can do, that is same.
Excellent picture.
Zoom out little bit.
Zoom out, yeah.
Now?
Yes.
Yeah,
Yes,
so-
nice.
Okay.
And I want to learn the anatomy, Satish boss.
Okay.
Today I want to learn again the neck anatomy.
You are late. You are late.
Every time we are keeping some or other neck case. We are keeping every time some or other neck case.
Yes.
And now, I hope the picture should be focused.
Very nice.
Yeah.
It's
Okay.
really good. Yeah.
See now, the important thing here, this is your greater auricular,
Yes, sir.
Yes.
this is your, see the external jugular forming. Pakadno.
Any role of harmonic, boss?
Yes, harmonic is good. Very good. Now see what I am trying to show here is the anterior border of the sternomastoid. This is anterior border of the sternomastoid.
Yes.
So please center the picture.
Okay. There are certain landmarks here. You can see. Yes. Okay.
Yes. Yes, sir. Now clear.
This is the anterior border of the sternomastoid.
Yes.
Okay, let's open up because I have to go high up. This is the lower part of the tail of the parotid. This is lymph node in level 2. Another important thing about the paragangliomas, you cannot differentiate the malignancy on the basis of histology. Never. Only by means of metastasis. So, if there are lymph node metastasis, then you can consider malignancy. Not by means of same vein.
So many people are asking about FNAC in these cases.
Never. Why? These are vascular tumors. What you will get in FNAC?
Yes.
See, I am opening the sternomastoid further. I have told you several times how to identify the 11th cranial nerve.
Yes, sir. Sir, the choker is
Choker's vein.
choker's vein. Yes, sir. Yes, sir.
ये नहीं है. उधर है.
Spinal accessory and
अब पकड़ियो. Yes. No. That vein is retracted. Artery run. Yes. छोड़ना. Now. Hello.
Yes, sir.
अब क्या करें? Clean क्या कर? साफ कर. Now see, I am opening up this sternomastoid space. See this? यार इसको पकड़ यार, ऐसा मत कर दो. Don't do this. नहीं, open up. There is some vein retracted. Let us catch it first. It is going to spoil our field again and again. It is not. I am blind. Should have caught now. Okay. See the lymph node at level 2.
Yeah.
Yes. Now see the choker's vein. this vein, see this? Broke. See it.
Sir, it is seen almost every time. We have seen in last 4 or 5 cases, every time we have seen
always.
this.
I've been seeing for years. See, the nerve is immediately deep to it.
Yes, sir, it's seen.
Another thing can take into reference, I tell you, very simple thing. See this sternomastoid muscle?
Yes, sir.
And see how it converts into tendon. See this?
Yes.
Where it converts into tendon, it is in the vicinity of the nerve. This is your, 11th.
11th.
Yes.
This is your digastric. This is your lymph node at level 2. All these lymph nodes need to be sampled for malignancy. If it turns out to be malignancy, you have to do a proper neck dissection followed by radiation therapy. See my tumor here below.
Yes, sir. Yes.
You do the frozen section?
Yes.
Okay.
We have 24-hour facility for frozen here.
Oh, wonderful.
Sir, even
what is the energy? What is the very basic question? What is the energy of this cutting and coagulation cautery? because it's so I find it so nice here, dissection. So what is, because that energy matters, I feel.
Yeah.
What you must 20, around 20. How much is that?
इसको भेजो frozen. लाओ दोनों. This is the level 2 lymph nodes. See, they look normal, but still will stand for frozen.
This is Martin's cautery you are using, na? Martin's company.
We have Martin, Velilab, and L&T. Now see, see now, this is digastric.
Yes, sir.
Yes.
Now, when you divide the digastric, be careful. Immediately underneath the digastric is occipital artery.
Yes, sir.
See there. Can you see the occipital artery?
Yes, sir.
See, it is here.
Yes.
Yes, sir. Yes, sir. Seen.
Ox. Yeah. See, we have given some more superior access. See that? How it has opened up. The moment you open up the digastric, the space opens like anything. Now this second muscle, what is this? Sternohyoid.
Yes.
No, short. This is sternohyoid. Can you see?
Yes, sir. So please center the picture is going.
Okay.
Yes.
Now?
Fine.
Oh, the picture is good now. Oh, the picture is good now?
Yes, sir. Now good.
Yes.
Now see, this is your occipital. Okay?
Yes, sir.
And see, occipital arises from what? External carotid.
Yes, sir.
See, I have cauterized the occipital, though it's a main branch from the carotid artery.
Hello? Satish?
See this, where the occipital is arising from. This is external carotid.
Yeah, Dr. You're saying something?
Hello?
Yes, please.
That was the stylohyoid, not stylohyoid.
Sternohyoid is here in the midline, sir. This is
Hey, you said stylohyoid, no?
Stylohyoid.
Stylohyoid. It's stylohyoid.
Yes, sir. Stylohyoid. What I spoke is sternohyoid. Sorry,
Yeah, you said stylohyoid.
No, sorry. This is stylohyoid. Now see, this was the external carotid giving rise to this thing, external, this is thing, you see this thing? Occipital.
Yes.
One day. See the huge tumor here.
Yes.
This is jugular, that we have to separate, and anteriorly the carotid that we have to take care. We will get the same picture like we got in the, scan, how the vessels were oriented.
Yeah.
Now, yes, get some more access anteriorly up to the submandibular gland. See, that is submandibular gland. See this? This is hypoglossal.
Hypoglossal, sir. Yes, hypoglossal.
This is hypoglossal going.
Second last glomus case, occipital artery was the main feeding vessel.
Yes, yes, yes. Even this supply the vagal paraganglioma as well. Yeah, this is hypoglossal.
Hypoglossal.
So that need to be protected.
Yes, preserved.
Oh, chota. Now this tumor, as I said, is quite this is the carotid fork.
Sir, please enter the image. We are not seeing.
Yeah. See, this is carotid fork here.
So this is lymph node which you are.
Yeah, this is lymph node. This is nothing. What are this? Yeah, retractor लगाओ. Retractor here. Yes. Mop. Mop करो ना. This is ANSA.
Yeah.
Yes.
And Ari. See, this is the carotid artery, the jugular vein here.
Yes, sir.
This is the common facial opening here into the jugular. See this? Probably. This one. Here is the carotid artery, you see?
Yes, sir.
See that? The carotid fork.
Yes, yes.
And sacrificing the yeah. This tumor surface has so many vessels.
Yes.
And all this external carotid is giving through number of branches, supplying this tumor. Now we'll go up. See, this is external carotid.
Yes, sir.
Oh. See the vessel on the surface. This is vein.
So we showed on the CT, it's very vascular tumor, lots of flow void all around.
Yes. पानी डालना यार. You cut it. मेरे को दे. This is the vein. इधर artery लगा यार. Draining into the jugular. See, this is the direct tributary to the jugular.
Yes, yes.
So I am ligating. So now my jugular I can push behind
Yes, sir. Yes.
to evert the tumor. Oriented?
Yes, sir.
Now. पानी नहीं डालते हो. See, this way all the branches from the external carotid coming to the tumor, I am dividing. Many small branches. You see? Yes. Now, this tumor's proximity to the carotid here. We saw on the angiogram how it was contacting the carotid here. Internal.
Yes.
This is the key process. Bipolar. And we should be able to separate it easily.
Sir, like in last carotid body tumor case, you had a vascular surgery view. In this case also, any standby vascular surgeon around?
Yes. Always. We have a fantastic, top vascular surgeon with us. See this?
Yes.
That was the ANSA, which was originating from here.
Yes, sir.
This is hypoglossal.
Hypoglossal.
See, the first nerve to be saved is the hypoglossal. This is always in close proximity. See, the nerves are in so close proximity, mop. See, the close proximity.
Yes, sir, yes.
ज़्यादा मत खींच. External, yeah. Plus.
Hi, Rajat.
Hello, sir.
Yeah.
Rajat Jain has joined. Rajat Jain from LGPGI.
Yes, Rajat.
Yeah.
Hi, dear.
Good evening, sir.
Good evening. Now see, this was the hypoglossal.
Yes, sir, yes.
That is always, we have seen in all paragangliomas, how the hypoglossal crosses.
Yes, sir.
And we always save it. What my aim is to go above the tumor and separate it from the carotid.
Yes, sir.
You should have an upper margin of the carotid, upper stump of the carotid in control. See, this is jugular being separated.
Yes, sir.
Jugular. On the surface, these are the oozers, which you can always control. See this? One tooth. How the tumor is embedded in all these vessels and nerves.
All are surrounded by.
Yes.
Superior.
Usually the surface of the tumor is also very vascular, sir. So we need to revascularize it.
Paragangliomas are known for all this.
Yes.
So this is like a frontal sinus in the box, all around.
I think that is even more dangerous.
No, yeah,
It's all around the major vessels.
Major vessels. Yes.
See the location. That is how the challenges it gives.
Yes.
Now, my goal is to separate from this. When this is away from carotid, then you play your game. निकलने दे थोड़ा फोन निकलने दे चलने दे yes it is quite separated see little bit of the bleeding I don't care and this is the vagus nerve. Sorry, this hypoglossal.
Hypoglossal. Yes.
See how it is in close proximity all the way. This is the biggest concern.
Yeah.
So for us, everything is a very big concern.
Leave it. छोटा जोर लगा दो. Again, see my concern is this carotid.
Yes.
Please center the image service.
Centralize?
Yes, sir.
Yes.
Yeah, now it's fine.
इसको उठा ट्यूमर को तो पकड़ इसको. Now I will mobilize it. See, surface is so vascular.
Yes.
The moment you touch it, it starts showing what it is.
So the key is to like devascularize it by bipolar and like
on the surface, you know.
Use
Yes.
Guru.
Hypoglossal, Guru.
Yes, sir.
See, concern is this hypoglossal. The carotid here is quite separated. See this carotid?
Yes, sir.
Yes.
Hello.
Yes.
Dr. Satish, is tumor incorporated vagus? Vagus is passing through it?
Yes, I will show that. Vagus is always inseparable. See now, this way it is
separated from the carotids.
Yes. Yeah, that is my vagus. Now I will go up and separate. Now, more than carotid, the bigger concern is this hypoglossal.
Yes. We cannot lose two nerves.
Yeah, it is going like a bridge.
Yeah.
Yes, sir. Yes.
Satish, can you tell me that anybody can do this surgery? Like me, like a poor man like me can do this surgery?
Yes, everybody can do. Believe me.
Just keep on hugging the tumor.
That is the beauty of this man, you know.
Believe me, everybody can do.
But it's fantastic dissection. Fantastic dissection.
Scissors.
What is this?
See this? Below is the carotid. See this? Here.
Yes, sir.
That is the internal carotid going. See this?
Yes.
Yes, sir. Yes, sir.
Away. The concern is this. Hypoglossal.
Hypoglossal.
That is the bigger problem, boss.
And we can recommend thyroplasty in this case after how much time?
Pardon?
When we can go for thyroplasty if needed in this case, suppose how much time you will recommend to wait?
Let us see first the status of the scissors. Vegas. People claim 5% of the situation you can save.
Okay.
Keeping a sliver of the tumor on the Vegas.
Okay.
See now this is.
Yes, sir. Now hypoglossal is
nice.
Little away.
Beautiful. Little away. Wonderful, sir.
Now this is.
You're seeing through the microscope?
Yes.
Okay.
All the surgery in the microscope.
The microscope and endoscope. I don't think I do any surgery without.
Yes, it's a tributary to the jugular, which I am ligating. Now it will be away from the jugular also.
Yes.
Finally, we'll see upper and lower stump for the Vegas.
I can see the Vegas completely surrounded by this and the part of this tumor.
Yes. Yeah.
The trick is to just stick on to the tumor. I think that's what you would also agree. Just stick to the tumor.
See, this is Vegas.
Yes.
And this is Vegas only. What you are seeing there is a sympathetic trunk probably.
Yeah. Back is the trunk, I think.
Because sir, it has happened with us, like we have thought it to be a vagal schwannoma, and it has come out to be a cervical seborrheic schwannoma.
See, schwannoma and paraganglioma you can always differentiate from radiology. I told you the flow voids will never be in schwannoma. Flow void, that's how the role of radiology is.
Yeah.
Yes, sir.
See this, what we have separated is the sympathetic trunk. See the sympathetic trunk.
Yes, sir.
Yes.
Centralized.
Now this could be Vegas. See this Vegas. See this tumor.
Yes, sir.
Arising from the Vegas only.
Yes.
This is, to me, is inevitable to, protect the Vegas.
Yes, sir.
Now it is going to be out soon.
Yeah.
It is dying to be out now.
Once we operate in our OT, we usually say Alu is about to come out.
Can we switch to the Vegas? Can we switch to the Vegas now or anastomosis? Cutting two hands.
Can we? Yeah, I will show both hands. That's what I am trying to show you. See, this is the upper end of the Vegas here. And this is the lower end of the Vegas.
Can we do grafting in this case?
Pardon?
Can we do grafting over here?
What?
Grafting.
Cable grafting or end-to-end anastomosis?
I have read about grafting, but this nerve,
Yes, motor.
is not a good nerve now. It's ruined by the tumor. If You will never know into what length the nerve is trying to be normal. This looks normal now here.
Yes, yes.
Like the ANSA we cut, can we use that ANSA as a cable graft?
ANSA will be too thin for this. Sural now.
Okay, Sural.
Do I do sural nerve grafting?
Do it.
See now, my tumor is ready to be cut.
Yes, sir.
All around.
Just on a lighter note, I can call it as an cyst of the vagal nerve.
Yes.
Got it. Separate कर वो रख उधर कर उसको हाँ Got. Yes.
Hypoglossal is nearby.
Now it is solely on the vagus now on both sides.
Yes, sir.
Very nice.
See now. See, no embolization.
Yes, yes.
Why too?
Yes.
There was hardly any bleeding.
Satish, you told that there is a chances of recurrence of this tumor and all. How will you decide the margins here for the upper limit?
Margins for this. See the normal now. I can see the normal now here.
Okay.
From where the tumor is forming.
Yes, we can see.
See what I am bringing out is the normal now.
Yes, nice.
And here is the normal now. That's it.
Yes.
I am
Very
cutting
nice.
off now. Cutting off. Cut.
Seeing the vagus like this with the bipolar.
See how cruel. How cruel
Yes.
is to cut the vagus like this.
Yes. Beautiful.
See this. Oh, उसको नहीं hypoglossal. That is
Sound is
hypoglossal.
echoing.
Yes, sir. Some sound. What?
Is it fine now?
That's okay.
Yes.
That's it.
Fantastic.
Fantastic.
You must have first time the cutting the Vegas now, I think.
Big round of applause.
Actually, I'm witnessing.
That is inevitable, boss. Inevitable.
How the Vegas can be cut.
See now, not a single drop of blood. There was hardly any blood loss.
One demand
People, people embolize for this.
Satish, can you show us the superior laryngeal now?
What?
Branch of it. Superior laryngeal nerve.
Superior laryngeal. Superior laryngeal probably is above. Probably that is intact because we cut the vagus here lower down.
Yes.
Superior laryngeal come little above and go medial from here deep to the carotid. Deep to the carotid here. Maybe that is intact.
Like Dr. Binni from Mumbai wants to know any special thing in consent. You ask.
Yes, the vagus. The need of future procedure like thyroplasty and cricopharyngeal myotomy or something like that should be required. Yes, sometimes. Karna. Postal खोल. Yes, postal. Clap उठा. CP है. बाकी देखते हैं पीछे क्या है. Facial palsy है. चारों तरफ. CP की तरह. हाँ और पीछे से खोल. Facial देखते हैं. हेलो. हेलो. Yeah, the next patient is the man with the facial palsy. He has a CSOM. The central perforation is evident. Let's see what is there beyond that. चालू करा दे इसी को बोल टेटवा hello. So last two cases both induced. The facial now, the CSOM with palsy is being started, being induced. Last step is, so step is again I'll come for 5-10 minutes after the flap is raised to see the finding finally. And the CSOM, they're raising the flap to see what is there. The last CSOM with facial palsy case we had turned out to be tubercular. The histopathology also confirmed. Yes. Histopathology also confirmed he is on ATDs. And
what made you to think of tuberculosis?
yes, even that time, from the basis of CT scan, I had a doubt. Tuberculosis, yes. Patients have typical granulation in the middle ear, coming in the extraordinary canal, facial palsy, yet on CT scan, the mastoid is classically normal. Pneumatized mastoid. Though in that patient the mastoid was not big, but this is classical finding of tuberculosis. And when I cleaned up the ear, there was evidence of osteomyelitic bone coming out. Dead osteomyelitic bone coming out, that is classical of tubercular. In our countries, when such suspicion you have, the first diagnosis should go to tubercular. It is so common.
Yes, yes,
in the glomus. What would have been? Ore yaar. लाओ कुछ जाना मत ऑक्स जाना मत ये नहीं चाहे कुछ क्या है अबे इतना क्या लेके आ रहा है यार तुझे पानी दे हेलो यस बॉस so I will so meantime the case is being opened. I will take you through if some important finding this patient has. Yeah. Outcome. The best outcome is grade 3. Best outcome is with grade 3. So, for any grafting, the best outcome is grade 3. Vegas, I have never seen people grafting.
Because even I have not read in any study.
Yes, Vegas grafting is something new. We'll definitely explore it. Now this man, as a, I remember he is a central.
The question is what exactly you see in a facial palsy now? What is in your mind when you are looking at the CT scan?
Yeah. So what I want to see at what level the facial now might be affected.
Yes.
So here I have very good cuts of the facial now. Let me show you. Now see, this is the labyrinthine segment. Yeah, 0.7 mm. This is labyrinthine segment.
Yes.
This is tympanic segment coming.
Right.
See the tympanic segment?
Yes.
And here is the genu. This is sinus tympani. Here is the genu. And see now classically see this. There is something in the sinus tympani and this facial nerve is bare there underneath. See, this is, let me show you to understand. This is the tympanic segment. Now this is genu. Genu coming, this is genu. Now see at this point, this is sinus tympani, huge. Yeah, and see as I go down, see this facial nerve is in the same opacity of the sinus tympani.
Yes, perfect.
And now it is separating again, see this, as I go down. Now down, the rest of the lower part is absolutely normal.
Yes, got it.
Only area where it is, see this, fused with the sinus tympani.
Yes, yes.
Now,
It is almost a similar thing.
yeah, now I have some other views of the facial as well. Let me see this view.
Wow.
This is vertical course and here at the genu is something wrong.
Yes.
Just after the genu or genu. This is opposite side normal.
Yes. What is this view?
This is longitudinal oblique. Seventh nerve view. Seventh nerve view. See this entire course of the seventh nerve is visible along with the entire course of the cochlea. This, otherwise, technically it is double oblique coronal view.
Yes.
Now this, see on this side what is happening to the facial now. This side. This is normal and this is on the, this is abnormal.
Yeah.
So you were asking about the facial, what could be the wrong thing.
Yeah.
Now this facial palsy for a month, finding by and large is a large central perforation, what I remember. Let us see, Dr. Ayub has already, Ayub has already opened up. Let's see what it is. See the lateral semicircular canal is normal.
Yes, sir.
Lateral canal is normal, absolutely normal. The inner ear, this inner intra-auditory canal is little bulbous. Otherwise, the cochlea and the vestibule are normal. And here, this deep sinus tympani, some opacity, unusual thing. Say this.
Yes, sir. Yes.
And again, such things point out to possible tubercular. I don't know.
You are expecting some granulations which are just eroding the fallopian canal and impinging on the...
Maybe. Sometimes you don't find granulation absolutely pale.
Okay.
Tuberculosis has variable presentation. I am not saying it is tubercular, but it may be.
But possibility, yeah.
Anupam, just a minute. Anupam, वो ले ले. टेबल ट्रॉली पे लगा. Pardon, for this patient,
yeah.
Let's see first what it is there once we raise the flap, and then we'll think of.
Okay.
Hello?
Facial palsy for how many months?
1 month.
1 month, okay.
So now the case is ready. Ayub is already raising the flap. So let's go ahead.
Okay.
Hearing is profound loss. Again, he had discharging ear for last 20 years, but had profound loss also. Hearing loss also earlier, but now profound and facial palsy for 1 month. Again, this is something, unusual. Connect. Are you getting the picture? Yeah, this is, are you doing, and I have gone for wash up. Are you wash? Hemostasis, huh? What do you think it? Some evidence of TB? Look like? Huh?
Not that pale and not that typical.
Let's see, yeah. You clean the 2 minutes में आ गया. ये कर. Is any positive finding so far?
Yes, with endoscopic you can directly now with a 30-degree you can visualize the retrotympanum and start with what is called inside out.
उतारना मत. खोलना मत.
Because the retrotympanum can be visualized with a 30-degree here. So the construction you get to visit in the endoscope. Yeah, you can do that. I don't have that much experience, but two patients I have done. Huh?
Now, just I am having a look what exactly it is. Yeah, but see the mucosa looks pale, huh? You? See the mucosa here looks pale. See this mucosa. Yeah, it is. See. Yeah, pale. See this pale. Can you see this pale mucosa? Yeah. Yes, sir. Right. Could be something unusual. So all these. Yeah, says boss, this should be tubercular. Oh. Basically. All this.
So can I say something?
Actually,
these are the what sir said. These are few other granular conditions which present in various problems. But these are mainly predominant in Western countries. We have come across these conditions with facial palsy.
yes, could be. And see these granulation. Now see the granulation here up. These are more convincing. Focusing, I don't know. Let us see what it is. See the granulation.
Yes, sir.
See this granulation? Yellow, he stopped. Yes. This looks representative. Yes, but he has a perforation. We don't have evidence of histological evidence. How will you confirm? We need to establish diagnosis. Now, here was the granulation which was quite convincing.
Sometimes these gram-negative biopsy can be taken to just like endoscopy and taking biopsy. But since this patient is having a patient on biopsy,
Yes, yes, this is indication. Sometimes, in spite of having a tuberculosis, sometimes, in spite of having tuberculosis, your histopathology doesn't prove. Because they need evidence of AFB to give a diagnosis of tuberculosis. What is it? बोल ले ले. Now I will open up from behind. Let's see what is there. Yeah. It is normal mastoid. Or I refer to my physician. We don't give OTG ATDs on our own. And nowadays the regulation is to take the inventory, Let's see.
lot of places, somewhere they follow 1 year, somewhere for 1.5 years, some places they give you 2 years. There's no fixed like some, but WHO says it to be 1 year.
Something very funny.
Yes, it is.
Bar dena cutting. Something very funny. See, we have yeah, long standing. That is again something going in.
One comment, Satish from Dr. Khalid, that patient was having a wide IAM, intravenous because totally clear cardiomyocytes of the patient was that vertical and visual part of the.
Oh, so remote. Yeah, osteomyelitis. Osteomyelitis. Yes, he's right. The bone becomes avascular in those areas where it is affected. Dhire. Pardon? Complete. See now. This is something there. क्यों रखना है? Right angle देना. छोड़ के भाग जाता. See how the mucosa is. Yeah, give me forceps.
Dr. Satish.
Yes, sir.
Do you intend to do prostate temperature and then deconstruction?
Yeah, I will first. I may have to do. I will first see from behind the vertical course of the facial now. Follow it. See this classical granulations, pale granulations. See this.
Yes, sir, yes.
What this is tuberculosis, I tell you. for sir? This is definitely tuberculosis, sir. No, no. See, this is all pale necrotic area. This is 100% now. I can show clinically it is. This pale necrotic area. See this? This is quite unusual. And we have to think of the commonest diagnosis first. And in India, TB is so common. And the presentation is so varied. Many times you will find cases coming with the unusual pain. Unusual pain, hardly any discharge, hardly any finding. And then they develop facial palsy. Yes, 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 yes. Yes, yes. See this? Now let's see. Yeah, but ATD, there is no harm in starting ATDs. I will definitely wait for biopsy, otherwise. But there is no harm in giving. Let me see.
Now they have started saying this.
Water.
I think it should be only started once we get confirmed.
Yeah, nowadays there is regulation also in giving ATDs. See, let me see the vertical course. At least I will see the course of the facial now. Once he has come with the facial palsy, I would at least have a look at the facial now. Now, after this, my location. See, this is the incus. Parallel to the incus. Zero, zero.
Are you planning for any grafting or something?
No. I don't know what is the status of the nerve. How can I plan grafting?
Okay.
At least I should know the status of the nerve. Now see my nerves.
Showing in the only lower part of the facial, in the sinus tympan, that only part is affected.
That we'll see from this side as well.
Yeah. Try not to go inside out of this place.
Why to? Because anteriorly your ossicles are good, your flap is good, Why to damage the canal? Let me check. Inside out is one alternative, no doubt about it. See the now. Such an unusual location. So lateral location, huh? Diamond, no? See, it's lateral. This is the lateral canal. Can you see? I was not expecting. I saw it earlier also. Yeah. Yeah. Oh, expose करा ले. This is unusual. This nerve or something else. How can it be so lateral? Incus is there here. I am following incus only. See, one more now. Abnormalities you have seen, but this is too lateral. Cannot anticipate. वो देना. Side circle.
Yes, that I just as an type C, almost 7 millimeters to 7 millimeters to more than 10 millimeters. That goes bigger to the facial.
See, there is no scope of making a tympanotomy.
Yes, I am just trying to judge the depth of the sinus entirely from anterior part. Because I can judge almost 10 millimeters. If I consider the facial nerve as a boundary for the
One more nerve behind. There's one more nerve behind.
Yes. Something must be dividing this two front, two up, possibly. I think it should be reported facial to the mandibular. The bifurcation nerve may not pivot towards its scale. No, that could be the nerve which will be dividing two up.
Now, give me a smaller one and a diamond one. Under छोटी diamond है ना? Let me.
Can we go inside or because
Yeah. That's. Yes. That's what I'm now coming to.
Yeah.
पतला यार.
Because
don't know 10 millimeter, but it is unusually up. धीरे यार. अरे बीच में मतलब.
But for young people like us, it's a very big lesson. You can get anything, anywhere. You have to be
Yeah, abnormalities you can come across. थोड़ा दूर है. Yeah. Yeah, I didn't connect nerve monitor.
What's the use of nerve monitor here?
Confirm, to confirm.
Confirm later. Yeah, better idea.
And nerve monitor is always useful in these conditions, you know.
Point of discussion, Satish bro.
See this, see this, see this, see this granulations.
Yes, yes, yes. Yeah.
See this pale granulations. This is classical of tuberculosis. No doubt I have. Now look.
But how to judge these anomalies, if at all, with the CT or any other lab investigation? Is it possible?
About the tuberculosis.
Not about tuberculosis, about the variation of this nerve.
That is different. That you don't have to prove. That can happen. It is a accurate. No? See.
It's a complete nerve palsy? Yes.
Yes, complete.
So the things must be happening at the main trunk.
Yes. Yeah, here it is main trunk only.
Yeah,
Patla the size.
just above the pyramid.
I will remove the incus to clear. Yeah, that will be better.
You are not going to harm anything, remove it.
Yeah, it is not going to, because reconstruction is not the aim here.
Yeah. And you told that found a hearing loss in this patient.
Yeah.
Here comes the role of endoscope. You can see by the
Yes. Exactly.
Even 2.1 or 3 millimeter, 45 degrees.
Yes. See, this is facial only.
Yeah. Oh, but that's an amazingly different.
पतली वाली है ना? See this is facial only.
Yeah. If at all we take that it is dividing too early, so
Yes. See this. Let me show you in continuity with the. This is genu.
yes. Vertical canal.
Yes. See, this is my lateral canal. This. See, this is lateral canal. This is facial now. इनका the side देना.
I am expecting something in the sinus tympanic.
Granulation now. What else?
Yeah, granulation. Oh, that's
See.
so nice continuity. Fantastic.
See the nerve. Just to show you the course of the nerve. See this?
Wow.
And there is neuritis of the nerve. Yeah, this is.
Beautiful. Beautiful. Yeah, beautiful. Beautiful. आज मेरा लॉकडाउन 5 का दिन सफल हो गया स्पेशल विद
See this nerve? It is involved in neuritis. See this here. Whitish, abnormally. See this nerve?
Yes,
I've decompressed it.
the kind of disease in menstrual doesn't
And now, what is this?
as compared to the kind of voice is breaking a lot.
This is thick mucosa.
Okay. Okay.
This is thick mucosa.
So this is actually sinus tympani only, lead to facial nerve.
Yes, this is sinus. It's just thick mucosa. Yeah, retrofacial. Yes. Yeah.
And so maybe this can be the color in this case.
The forces. See, the nerve is turning up laterally. These are the, yes, something in contact with the deep part of the facial nerve. These were the granulations. Yes. Yeah, the space medial to the facial nerve is. Yeah, it is quite good.
Very deep, sir. Very deep.
See that? The facial now we have decompressed the facial. We have taken a lot of biopsy from different areas. Clinically, to me, it is,
But can we see little bit more taking out the posterior or posterior inferior little bit to see actually sir wants you to put an endoscope and show the sinus.
yeah, look, give me endoscope. Give me endoscope.
Because there can be the granulations in the posterior inferior part of that loop, that overhang.
The first time we will be seeing sinus tympani posterior to the canal wall.
Yeah, it is extended pneumatization.
Yes, sir.
We can't see the round window here. Am I right?
The round window, I can see the glimpse of it. You see here.
You can see?
Yeah, here.
A little bit, yeah. Now it is there, yeah.
This is here.
But it's really interesting and quite deep facial. What we have seen on the CT, I am just trying to correlate with the CT because that whole of the sinus tympani and the facial was one opacity or one density.
See now, this is through and through.
Can you pass it in?
Yeah.
So that's some sinus tympani. That's all.
See this?
Yes, sir. Wonderful.
I showed you on CT scan there is something big area, big sinus tympani, which was in contact with facial nerve. Yeah, एक 2.8 वाला भी ला देना. Yeah. Let me put the endoscope directly first.
So should we conclude the granulations in the sinus, deep sinus tympani, pressing over the facial, causing the facial palsy?
Facial palsy is because of TB.
TB. Okay. You're right. What kind of physiology goes on like this? Because I don't see the much granulation.
Yeah. So TB has varied presentation,
Okay.
TB has varied presentation.
Degree 45?
This is 0 degree, no? See, I am seeing first seeing from behind.
Okay.
Now the same thing we'll see. 45 is there, from front.
Yes.
Section there, no?
See, there are a lot of granulations in the
Yes, yes.
pyramid. See those granulations. They are just down the epithelial tendon and the pyramid and in the sinus lymphatic.
Right angle there, no? See, the important thing is this kind of granulation. This is classical. See this kind. Let me this kind.
Right.
See this pale.
Yes. Right.
See this. These pale granulation. See this? Avascular, absolutely avascular pale granulations. See this? See this? This is classical. Something जैसे बिल्कुल गल गया हो ना, something like that. Completely rotten. See, this is the nerve. And see, in a close proximity to the nerve, what is happening? See,
From above, this is absolutely an abnormal course. It's not as a routine.
Yeah.
And which is the vertical part is forming with the vertical axis. That's absolutely a different course.
See, this is the facial nerve. And I told you this is like inflamed, neuritis going on. And see here, this all rotten. See this completely. This kind of condition is classical. Biopsy ले लो. See, I have taken another biopsy from different place. This is classical. I will update you with the report.
Yes. With the endoscope, I can see across JU, I can see the tensor there, and I can see that kind of mixed view.
Dr. Satish,
Yes.
will you further decompress the nerve or leave it there?
No point. No point, sir. What are we going to achieve? You mean?
The surgical part is there and the medical part is not there.
Yes, it is that. Now the treatment of choice is medical. Okay, I have removed this compression. What you are trying to say?
Yes.
See now, this bone I have removed.
Right. That's a surgery.
Yeah. Surprising. So what we'll do? We'll graft the ear here. Okay.
And I will your boomerang. I'm not boomerang. Not did it. What did it?
No, temple is fascia. You have seen earlier, no, many times.
Since the patient is having an active tubercular disease, shouldn't he be using?
No, it has nothing to do. No, that is not difference. Once we start anti-tubercular, that part will be taken care of. Now, grafting for the tympanic membrane, it has no effect on the tuberculosis. The cartilage or anything is going to make the difference.
Some people, instance, have powder and all that. Do you believe that?
Not really, boss. The moment you start the ATD, the result is so dramatic, so dramatic. See now, we'll just put the interlay grafting. And you have seen me doing interlay several times in this webinar also. So I will move on to the other case which is ready, and Ayub will do grafting.
Can we do 2-stage procedure like after 1 month of ABD, can we again come back and do the grafting and everything?
But why not grafting here? It has nothing to do with the taking up of the graft.
Okay.
Nothing to do. It will take up. Yeah, it is a good environment for the take up. We just.
Should we address the eustachian tube in such cases when you are actually thinking of the tuberculosis?
Yeah.
So should we address the eustachian tube here from the middle ear?
No. What will you do to that? Nothing. Boss, I have seen several times. One TB is there. You start ATDs, everything revert back to normal. It is medical disease and the results are so dramatic. Now, I am quite sure it is tuberculosis. The last case was also, I had a doubt and it turned out to be tuberculosis. Again tubercular. So, I am going to the... Network है? बोलो. Hello?
Yes.
So, the chest physician. We have our in-house physician who takes care of everything 24 hours. A team of physicians round the clock. So all medical part is taken care of by them. Some patient hypertension, diabetes, asthma.
One question. If you would have gone through the inside-out approach, what landmarks you would have kept in your mind for finding out such patient? Because you are not expecting it.
Not expecting. The way the facial turned out to be so lateral,
yes,
the chances of injury by inside out would have been more. You will never expect.
Yes, right. So, but still, what landmarks you will tell that
The advantage in that you can follow the tympanic segment easily, because tympanic segment is always visible when you come from inside out, and you can follow that. But this was an abrupt lateral turn of the nerve and little unusual course as well.
Yeah. Totally unusual, not little.
But in spite of all odds, the moment ATDs is diagnosed and ATD is given, he'll improve like anything, including dry ear, discharge. May. It should improve to some extent, yes.
Satish,
Yes.
in your experience, just following the incus as a landmark, you can still tend to protect the patient because that will be constantly in a normal course as well.
Yes, sir, exactly. I was following that. But in this case, it was going lateral to incus. Little lateral or in the line of the incus rather. It is always otherwise medial to incus. Always. It is never lateral to the lateral canal. And it was little lateral to the plane of the lateral canal. That's why it was unusual. अरे एक वो सीढ़ी थी ना अंकित को बोला so any question Udbhav?
No, sir, we have discussed each and every question, sir. During the segregation, covered everything.
Otology is full of surprises regarding anatomy and presentation.
Yes, I call it as an Pandora's box for the otologist.
Yes.
After a long time, I saw the facial. And said, like, deep scientific when I never have only known it. I see it there, but
It was the kind of granulation, mucosa and the bone, all in favor of tuberculosis.
any role of MRI? Any role of MRI here to just like that?
It will show just inflammation. MRI can show inflammation, it cannot differentiate into inflammation.
Okay, normal course of facial can be picked up on MRI.
Yeah, even on the CT scan, if you see slightly, maybe slightly lateral be ignored. But this is something.
When we were discussing the CT, I was expecting something different, and I got something different. So,
I told you it was looking like.
Yeah, it was a totally one mark there, actually.
See, this one point is there. Suppose there is one lady, any patient of 70-year-old, parental CS1, and what is the maximum age of it in these cases?
70 years.
Yeah.
See, as long as the patient is fit, and now depending upon the disease, if it is a cholesteatoma, you have to do. And if it is a central perforation, patient is fit, conductive hearing loss, wants to improve hearing, you can go ahead. Then age is no bar.
These patients have been very poor with hearing aid actually.
Huh?
We get many cases like they are not fit for surgery and they cannot bear the hearing aid because of
फुल ऑफ सिंपल है, देखो बड़े में देखो
कहाँ का पिक्चर है?
टीएम पे फुल ऑफ सिंपल फ्लोरोसिस है.
Rajeev, mostly we get these patients nowadays with malignant external and facial palsy. These 70 years. In this situation, mostly diabetic neuropathy. So if you do facial palsy, if we consider the same sort of situation that we have today, 70 years. So what is your consensus of that? What should we do? Patients should improve.
No, mainly because since they are diabetic, you cannot form a surgery. You have to manage your hearing aid with them.
Hello? Hello? Yeah, we are just grafting that case.
Many people want to see the grafting again.
Already placed a gel form.
Okay. So I think this case will take a lot of time. I think almost 10:30 is there.
Yeah, it's 10:30, yes.
And for the almost 8 hours, almost 8 hours, more than 8 hours.
So?
Doesn't look like looking at the Satish, it doesn't look like a
Look like so many people are asking regarding the diabetic, doing gastric surgery in diabetic cases. And one question is there precautions in diabetic mastoid surgery. Point something about it. We can call for the day. Almost we must be tired and it's almost 8 to 9:30. One step is there, huh?
Yeah, we are just inducing. Okay.
So just a few points about the precautions during diabetic surgery.
Diabetics, you have to be careful about the infection because diabetics are often immunocompromised. So, just infectious complications you have to be careful about. Most important.
Age is not a bar for any method surgery.
Age is not a bar. As long as patient is fit, no issues. Even, recent report, 87-year-old got implanted, got cochlear implant done for hearing. He wanted to hear better.
Yeah, we got visited. There's a owner of an hosiery out here. Family was mostly infected. So we did it. We linked for.
So, do we call it a day? Hi, boss.
This Thursday, one announcement, this Thursday we are off because of commitment from other team. So we can make it for Sunday. Can we make it for next Sunday?
Yes, we're all prepared, all set.
This Sunday we are off and Bhavna sir joined? Bhavna sir, who is saying Dr. Bhavna has joined?
I have not seen. So we'll see you next Sunday.
Yeah, we will see you on, all will be together on that Sunday with lots of cases, good infected cases, and I think two cases are left, like some head and neck benign lesion, brachial cyst, they want to see. And whatever case, we'll try to make it on next Sunday. Almost 8 or more than 9 hours so far being done. And again, we would like to thank Dr. Mubarak Khan,
Yeah, everyone. Look what?
and Mubarak, thank you for Manish Munjal boss and Girish Mishra sir.
Mishra sir, thank you so much. Munjal sir. Hello.
मैं तो हेड एंड नेक बनना चाहूंगा अभी कुछ दिन के बाद. You will call me
अरे.
Rajat and our young dynamic Rajat Jain है वो तो Mr.
Yeah, Rajat, thank you. And thank you, Udbhav, for the great job.
Thank you, sir.
Thank you.
Thank you, sir, for wonderful this support all around. And Varman, anything comment from your side? And Udbhav, what's your experience today?
So मजा आ गया मतलब I enjoyed so much and I still feel that we can go for hours and hours. You cannot say that he's going for surgery or he's coming after surgery.
No, but you did a great job, man.
Mr. Varman is there. Mr. Varman is ready. Just a comment from him. And actually, with Satish Jain, nobody can say no, Mr. Varman, any comment from your side?
Sir, I would say that my happy thanks to you. What else I could say this time? So once again, I think you're also been helping us for establishing our branch.
Today, attendance was very good. So all the people enjoyed the basics to advanced. And I think, thank you all of Ms. Santana, our colleagues, Dr. Munjal, Dr. Mishra sir, Mubarak, and all, Dr. Satish Jain, at all.
Of course, yes.
Again,
I would if we actually we have been calculating the touch point. The last 15 within us, the touch point what we have created at most if you take on an average around 4,000 also, then it is almost 50,000. I'm talking about minimum touch point.
Yeah, only
1,000. Yeah. So it's really a great achievement by
YouTube, then it's 1,20,000.
Yes. So all credit to Dr. Jain and you and
from you and the crowd-based people who are logging in us.
Yeah. Grateful to the people who are really showing that much of interest. Sir, thank you. Thank you, Munjal sir.
Just one question for you.
Yes, sir.
Dr. Satish is powerhouse energy. You know what is the source? He will not explain that. This is the most common question asked. What love?
Thank you.
Something like staples and big surgery like carotid body tumor, all same finesse. So versatile personality.
I agree with this man.
Thank you very much. I think we can follow over the day.
Thank you.
9 hours. And YouTube doesn't allow more than 9 hours recording.
Thanks to all the audience. Thank you very much.
Thank you. Thank you. Thank you.
See you, Rajeev.